What if everything you thought you knew about medicine was only half the truth? For decades, we've trusted doctors to keep us healthy, but what if they're missing a crucial piece of the puzzle? What if the key to preventing and even reversing chronic disease isn't in a prescription bottle, but on your plate? Welcome to What Your Doctor Doesn't Know About Nutritional Medicine May Be Killing You. In this eye-opening audiobook, you'll discover the dangerous gaps in conventional medicine, how nutritional science is transforming health, real stories of recovery beyond the doctor's office. Are you ready to take control of your health? Stay tuned and uncover the life-changing truth your doctor might not tell you. Listen, learn, and reclaim your well-being before it's too late. Be healthy.
A converted doctor. You may not have heard of me before, and I understand if you question why you should consider the perspective of a physician practicing in a modest Midwestern city. That skepticism is not only reasonable, it's necessary. As a medical professional, I have always valued evidence-based practice, and I would expect no less from you as an informed reader. That is precisely why I invite you to engage with every chapter of this book. My journey led me to uncover compelling medical evidence demonstrating the profound impact of targeted nutritional supplementation on health and disease prevention. I want to present you with the same data and clinical insights that changed my approach to medicine. I urge you to resist the inclination to skip ahead to the sections most relevant to your current health concerns. While I understand that impulse, a strong foundation in the science of human physiology and cellular health will allow you to fully appreciate the broader implications of this approach. Without this context, the specific recommendations may seem isolated rather than part of an integrated strategy for lifelong wellness. Finally, I ask only this. Approach this book with an open yet discerning mind. Early in my journey, I too was skeptical. Despite years of medical training, I had to acknowledge that there was still much to learn about optimizing health, not just treating disease. That realization required humility. If you are willing to embrace that same openness, I believe you may find, as I did, a transformative new perspective on preventive medicine. Physicians are, by training and practice, fundamentally disease-oriented. Our education is deeply rooted in the study of pathology, diagnosis, and treatment. We are trained to identify disease, assess its progression, and implement therapeutic interventions, primarily through pharmacological means. A significant portion of medical education is dedicated to pharmacology, where we master the intricate mechanisms of drug absorption, metabolism, and excretion. We understand how medications interact with biochemical pathways to achieve therapeutic effects, as well as their potential adverse reactions. With this foundation, we confidently prescribe medications to manage a broad spectrum of conditions, from hypertension and diabetes to arthritis and cardiovascular disease. The advent of antibiotics marked a pivotal shift in medical philosophy, reinforcing an aggressive, disease-targeted approach to treatment. Medicine has since carried this ethos into the modern era, addressing chronic degenerative diseases with an ever-expanding arsenal of pharmaceuticals. The numbers are staggering. In 1997 alone, over 2.5 billion prescriptions were filled in the United States, and spending on prescription medications more than doubled over the previous 8 years. Prescription drugs have become the fastest-growing component of healthcare expenditures, escalating at an annual rate far exceeding inflation. Physicians and insurers alike have largely placed their trust in pharmaceutical interventions to mitigate the rising burden of chronic diseases, a reliance that has significantly benefited the pharmaceutical industry. Despite this pharmacological focus, it remains a universal truth that every individual desires optimal health. Yet, in my clinical experience, I have seen firsthand how patients, physicians included, gradually lose their health over time. Each day, I am faced with informing patients of newly diagnosed conditions, diabetes, degenerative arthritis, cardiovascular events, and even terminal cancer. The common goal among all patients is to maintain or reclaim health, yet the path to achieving this goal is often unclear. Because our training is centered on disease identification and drug therapy, physicians dedicate much of their professional effort to diagnosing conditions and prescribing treatments. As even Scripture acknowledges, it is not those who are healthy who need a physician, but those who are sick. However, it is a fundamental principle that maintaining health is far easier than restoring it once lost. True preventive medicine should be the cornerstone of healthcare, yet it is often overlooked in clinical practice. Patients seeking guidance on proactive health measures may find themselves at a loss. Does their physician provide this essential information? The medical field frequently emphasizes the importance of preventive care, with institutions adopting titles such as health maintenance organizations, HMOs. However, the reality is that less than 1% of healthcare expenditures are directed toward true preventive medicine. Instead, what is commonly termed preventive care often consists of early detection strategies, mammograms, blood tests, and screenings designed to diagnose disease at its earliest stages rather than prevent its onset. Physicians monitor cholesterol levels, blood pressure, and glucose readings, yet minimal attention is given to educating patients on the lifestyle modifications necessary to protect their health. The overwhelming demands of disease management leave little time for comprehensive preventive counseling. Compounding this issue is the striking deficiency of nutritional education in medical training. Fewer than 6% of graduating physicians receive formal instruction in nutrition, and even fewer are educated on nutritional supplementation. I can personally attest to this gap. During my medical training, nutrition was scarcely addressed and supplementation was dismissed outright. Like many of my colleagues, I once regarded vitamins as unnecessary at best, or as producing expensive urine at worst. If patients inquired about supplements, I often dismissed their value, advising them to opt for the cheapest available options if they insisted on taking them at all. This perspective, however, has undergone a profound transformation in my practice. Over the past several years, a growing body of scientific literature has compelled me to reevaluate my stance. The research is compelling, and the clinical outcomes I have witnessed are undeniable. My approach to medicine has fundamentally changed as a result. So, why have many physicians not embraced this shift? The answer lies in the rigorous skepticism ingrained in medical training, a necessary trait to protect patients from unproven or potentially harmful treatments. Physicians rely on peer-reviewed, double-blind, placebo-controlled clinical trials as the gold standard of medical evidence. This book is rooted in that same standard. The research I present is drawn from the most reputable medical journals, including the New England Journal of Medicine, Journal of the American Medical Association, The Lancet, and other respected sources within the medical community. Another critical factor is that many practicing physicians remain disconnected from the latest advancements in the biochemical understanding of degenerative diseases. The gap between research scientists and clinical practitioners is wide. While groundbreaking discoveries are being made regarding the pathophysiology of chronic disease, few physicians translate these insights into their daily practice. Instead, they continue to rely on pharmaceutical developments as the primary means of disease management, waiting until conditions manifest before initiating treatment. Yet, as this book will illustrate, the most effective defense against chronic disease is not found in a prescription pad. It is within our own biological resilience. The integration of nutritional medicine into clinical practice has yielded remarkable results. I have witnessed patients with multiple sclerosis regain mobility, individuals with cardiomyopathy avoid heart transplantation, cancer patients achieve remission, and those suffering from fibromyalgia reclaim their quality of life. These outcomes are not anomalies, but rather evidence of the profound impact that targeted nutrition and preventives can have on health. As our understanding of cellular function deepens in this era of biochemical research, the fundamental mechanisms of degenerative disease are becoming increasingly clear. The findings are not merely academic, they are actionable. Physicians willing to objectively evaluate the medical evidence presented here may find themselves rethinking their approach to patient care. For patients, it is important to recognize that change within the medical establishment is often slow. Do not expect your physician to immediately embrace these concepts. Nutritional medicine remains a contentious topic within the medical field, and skepticism persists. However, the evidence is conclusive. What your doctor does not know about nutrition could be impacting your health in ways you may not yet realize. The encouraging reality is that you do not need a medical degree to begin making informed decisions about your health. By understanding the principles outlined in this book, you can take proactive steps to preserve and enhance your well-being, starting today. As a seasoned medical professional with over 3 decades of experience, I was no stranger to complex diagnoses and challenging cases. However, nothing in my career had prepared me for the helplessness I felt as I watched my wife's health steadily decline. This was not just the concern of a devoted husband, it was the frustration of a physician accustomed to finding answers. After earning my medical degree from the University of Colorado Medical School and completing postgraduate training at Mercy Hospital in San Diego, I established a thriving family practice in western South Dakota. My wife, Liz, had always struggled with certain health concerns, but she had hoped that marrying a doctor would improve her well-being. Unfortunately, reality proved far different. With 3 children under the age of 4, Liz's exhaustion went far beyond the typical fatigue of a busy mother. At just 30, she described feeling as though she were twice her age. Over the years, her symptoms compounded: chronic pain, persistent fatigue, severe allergies, and recurrent respiratory infections. By our 10th anniversary, even the simplest tasks were a challenge. Walking, standing, and engaging in daily activities required an extraordinary effort. Following extensive evaluations, Liz was diagnosed with fibromyalgia, an often misunderstood condition characterized by widespread pain and profound fatigue. Historically dismissed as psychosomatic rheumatism, fibromyalgia was once thought to exist solely in the minds of patients. However, modern medicine has recognized its legitimacy, and I had first-hand evidence of its devastating impact. Determined to alleviate Liz's suffering, I employed every available medical intervention: amitriptyline for sleep, anti-inflammatories for pain, muscle relaxants, inhalers, allergy medications, and weekly immunotherapy. Despite aggressive treatment, her health continued to deteriorate. By early 1995, we resolved to prioritize our health, committing to regular exercise. However, Liz's recurrent infections often prevented her from maintaining any consistent regimen. Then in March, she developed a severe pneumonia that resulted in complete consolidation of one lung lobe. Her condition was precarious, requiring intravenous antibiotics, corticosteroids, and nebulizer treatments under the care of a pulmonologist and an infectious disease specialist. Though the acute infection resolved, her fatigue became debilitating. Liz's ability to function diminished to the point where she remained bedridden for most of the day. Even brief walks to the barn to see her beloved dressage horses became rare. The children took turns staying home from school to assist her, as she lacked the strength to manage even the simplest tasks. Despite multiple consultations with specialists, the consensus remained the same: recovery would take months, if it came at all. Amidst this uncertainty, a family friend mentioned that her husband had experienced profound fatigue following pneumonia and had found benefit in nutritional supplementation. Liz, fully aware of my skepticism regarding vitamins and alternative therapies, approached me for my opinion. My response surprised even me. "Honey, you can try anything you want. We doctors certainly are not doing you any good." To be candid, my knowledge of nutrition and nutritional supplementation was initially minimal. Throughout my medical education, I received little to no formal instruction on these subjects. Unfortunately, this is not uncommon. In fact, only approximately 6% of graduating physicians in the United States receive any substantive training in nutrition. While elective courses are available, they are rarely pursued. As I mentioned in the introduction, medical education is largely disease-oriented, with a strong emphasis on pharmaceuticals, training us to understand medications, their mechanisms of action, indications, and contraindications. Despite this, the general public often assumes that physicians possess comprehensive expertise in all health-related matters, including nutrition and dietary supplementation. Prior to my personal paradigm shift regarding nutritional medicine, my patients frequently inquired about the efficacy of vitamins and supplements. They would bring bottles to my office, presenting them for my evaluation. With an air of professional authority, I would carefully inspect the labels, then return the bottles with a firm recommendation against their use, believing them to be of no benefit whatsoever. My intention was well-meaning. I simply did not want my patients squandering their money on what I perceived as unnecessary supplementation. My medical training had reinforced the notion that a well-balanced diet provided all necessary nutrients, and I could even reference select studies highlighting the potential risks of certain supplements. However, what I did not disclose was that I had never rigorously examined the extensive body of scientific literature supporting the role of supplementation in optimizing health outcomes. Then an unexpected challenge presented itself: my own wife's declining health. While I could maintain clinical detachment in the office at home, I was just a husband watching helplessly as my wife struggled. With no other viable options, I conceded and told Liz, "Go ahead, try the vitamins. What do you have to lose?" The next day, a friend delivered an assortment of supplements, predominantly antioxidants such as vitamin E, vitamin C, and beta-carotene, known for their role in mitigating oxidative stress. Liz eagerly incorporated them into her regimen, along with 2 specialized health drinks. Remarkably, within 3 days, her energy levels noticeably improved. I was pleased yet perplexed. Over the following weeks, she gained strength, remained active later into the evenings, and, most significantly, discontinued her steroid and nebulizer treatments. 3 months later, Liz had experienced a complete transformation. Her resilience had returned, and she exuded a vitality I had not seen in years. The most striking improvement was in her ability to engage with her horses without suffering severe allergic reactions. Gone were the nights of exhaustion and pain. Instead, she remained awake, active, and engaged well into the evening hours. As a physician trained in the scientific method, I needed to understand the mechanism behind this dramatic improvement. Skeptical yet intrigued, I conducted an informal trial with 5 of my most severely affected fibromyalgia patients. Each patient was given the same guidance, an opportunity to try nutritional supplementation, with no guarantees but the potential for benefit. Given the chronic and often debilitating nature of fibromyalgia, they were eager to participate. Over the course of 3 to 6 months, every single patient reported improvements. While not all experienced as profound a recovery as Liz, each expressed newfound hope. One particular case stood out: a woman who had sought care at the Mayo Clinic and multiple pain centres, yet found no consistent relief. Her condition had driven her to the brink of despair, even leading to a suicide attempt the year prior. After months on the supplements, she left a message on my answering machine, her voice trembling with emotion. "Dr. Strand, thank you for giving my life back to me." As a physician, there is no greater reward than witnessing a patient regain their quality of life. However, my preliminary observations with 5 patients were not enough to satisfy my clinical curiosity. I knew that anecdotal evidence, while compelling, does not constitute scientific proof. If these results were real, I needed to investigate further. My journey into the field of nutritional medicine had only just begun. My research on supplementation. During a visit to a bookstore, I encountered Dr. Kenneth Cooper's book, The Antioxidant Revolution, Thomas Nelson, 1994. Dr. Cooper, a renowned authority on aerobic exercise and preventative medicine, introduced the concept of oxidative stress, which he identified as a fundamental driver of chronic degenerative diseases. Intrigued by his perspective, I engaged in a thorough examination of his findings. Oxygen, while indispensable for sustaining life, paradoxically poses a significant threat to cellular integrity. This phenomenon, known as the oxygen paradox, is well documented in scientific literature. Decades of research have conclusively demonstrated that oxidative stress, an imbalance favouring free radical formation over antioxidant defences, plays a pivotal role in the pathogenesis of over 70 chronic degenerative conditions. The same oxidative mechanisms that cause metal to rust or an apple to brown are implicated in the etiology of coronary artery disease, cancer, cerebrovascular accidents, arthritis, multiple sclerosis, Alzheimer's disease, and macular degeneration. In essence, oxidative stress accelerates the process of biological rusting at the cellular level. Every chronic degenerative disease mentioned is fundamentally linked to the deleterious impact of oxygen-derived free radicals. Furthermore, environmental pollutants in our air, food and water, coupled with the physiological toll of modern stressors, exacerbate this oxidative burden. Without strategic intervention, unchecked oxidative stress leads to cellular deterioration, culminating in disease and ultimately aging itself. This paradigm shift in understanding chronic disease etiology has profound implications. For instance, oxidative stress-mediated DNA damage has emerged as a potential oncogenic mechanism, thereby positioning antioxidants as a viable strategy for cancer prevention. Similarly, oxidative injury has been implicated in autoimmune disorders, neurodegenerative diseases, and metabolic syndromes, raising the prospect of targeted antioxidant supplementation as an adjunctive therapeutic approach. Dr. Cooper's research also explored oxidative stress in athletes experiencing overtraining syndrome. Paradoxically, while exercise is heralded for its health benefits, excessive training can precipitate oxidative damage, leading to chronic fatigue and systemic inflammation. Notably, the symptomatology observed in these athletes closely mirrored that of fibromyalgia patients. This observation prompted an important clinical question. Could oxidative stress underlie fibromyalgia pathophysiology? The observed symptomatic improvement in my wife and several patients following high-quality antioxidant supplementation further fueled this hypothesis, warranting deeper investigation into oxidative mechanisms. Compelled by these findings, I undertook an extensive review of the medical literature. Over the past year, I have analysed more than 1,300 peer-reviewed, double-blind, placebo-controlled studies evaluating the role of nutritional supplementation in chronic disease management. The preponderance of evidence underscores a compelling correlation. Patients who receive nutrients optimal, often super RDA levels, exhibit substantial health benefits, reinforcing the therapeutic potential of strategic supplementation. The evidence is clear. Oxidative stress is a major contributor to chronic disease, and targeted antioxidant supplementation holds significant promise for mitigating its impact. As medical professionals, it is imperative that we remain at the forefront of this evolving research, integrating evidence-based nutritional strategies into patient care to optimize long-term health outcomes. Vitamins and You, a physician's perspective. Understanding the profound impact of oxidative stress on the human body is essential for maintaining long-term health. Oxidative damage occurs daily, contributing to cellular aging and increasing susceptibility to chronic disease. As a physician and researcher, I have come to appreciate that our most powerful defense against these threats lies not in pharmaceuticals, but in the body's own antioxidant and immune systems. These natural mechanisms surpass any medication I can prescribe. Through extensive study and clinical experience, I have concluded that nutritional supplementation is not merely an adjunctive therapy, but a fundamental component of preventive medicine. This is not alternative medicine. Rather, it represents the very essence of evidence-based, proactive healthcare. High-quality nutritional supplementation is not about treating disease. It is about fortifying the body, optimizing cellular function, and promoting sustained well-being. After reviewing a vast body of medical literature, I have no doubt that my patients who incorporate properly formulated nutritional supplements into their daily regimen experience superior health outcomes compared to those who do not. When I recommend supplementation, my goal is not necessarily to target a specific disease, but rather to ensure that the body receives the essential nutrients required to function optimally. This principle, which I term cellular nutrition, enables the body to operate as it was designed, supporting repair, regeneration, and resilience against disease. The case studies I share in this book are derived from my own clinical practice. While I have modified some details to maintain patient confidentiality, these are real accounts from individuals who have experienced remarkable health transformations. Their stories provide compelling evidence of how strategic nutritional interventions can restore vitality, improve quality of life, and even reverse long-standing health challenges. For those currently facing health struggles, take heart. Many of the individuals featured in this book were once in similar situations, battling debilitating symptoms with limited options. Their perseverance led them to explore a more integrative approach, one rooted in sound scientific principles, and the results speak for themselves. One of the most remarkable cases is that of Liz. Years ago, her daily life was overshadowed by pain and fatigue, yet today she thrives, enjoying the full life she once thought unattainable. Her journey, from illness to renewed energy and passion, demonstrates the profound potential of cellular nutrition. If you seek to enhance your health, prevent disease, and reclaim vitality, I invite you to explore the principles outlined in this book. The path to optimal health is within reach, and the science behind it is compelling. Let's begin. Living too short, dying too long. As we entered the 21st century, medical professionals and researchers took a critical look at the evolving landscape of health and disease in the United States and other industrialized nations. A retrospective analysis of the past century reveals striking shifts in morbidity and mortality patterns. In the early 1900s, the predominant causes of death were acute infectious diseases, with pneumonia, tuberculosis, diphtheria, and influenza leading the list. At that time, life expectancy hovered just above 43 years. However, the advent of antibiotics, combined with significant advancements in medical science and public health measures, led to a dramatic decline in mortality from infectious diseases, even in the wake of the AIDS epidemic of the 1980s. Today, the primary threats to health and longevity are no longer acute infections, but chronic degenerative diseases. These include coronary artery disease, cancer, stroke, diabetes, neurodegenerative disorders such as Alzheimer's and Parkinson's disease, as well as autoimmune conditions like multiple sclerosis and rheumatoid arthritis. The spectrum of these conditions continues to expand, underscoring a shift from infectious to inflammatory and degenerative pathologies as the predominant health challenge of our time. While life expectancy in the United States has increased significantly over the past century, this extended lifespan has not necessarily translated into extended health span. Many individuals now experience prolonged periods of morbidity, marked by a progressive decline in function and quality of life. This phenomenon has been aptly described as living too short and dying too long, a sentiment echoed by Dr. Myron Wentz, a distinguished immunologist and microbiologist. His insights into oxidative stress and cellular nutrition have underscored the critical role of proactive preventive strategies in mitigating the burden of chronic disease and enhancing overall well-being. Addressing these modern health challenges requires a paradigm shift in medicine, one that prioritizes early intervention, lifestyle optimization, and cellular health as foundational elements of care. By integrating advances in nutrition, genomics, and personalized medicine, we have the opportunity to not only extend life, but also improve its quality, ensuring that longevity is accompanied by vitality rather than prolonged decline. A wake-up call, rethinking life expectancy and quality of life. Life expectancy, a sobering reality. How long do you expect to live? While many discussions on longevity focus solely on lifespan, they often overlook a more pressing concern: how well we live those years. The United States, despite its unparalleled investment in medical technology and healthcare infrastructure, has seen a concerning decline in global life expectancy rankings. In 1950, the US ranked 7th among 21 leading industrialized nations in life expectancy. Since then, we have poured trillions of dollars into healthcare, more than any other country. By 1998, our nation was spending over $1 trillion annually on healthcare, accounting for 13.6% of the gross national product. This expenditure dwarfs that of any other country. With cutting-edge medical advancements, including MRI and CT imaging, coronary interventions such as angioplasty and bypass surgery, joint replacements, chemotherapy, radiation therapy, and intensive care units, one would expect a corresponding increase in life expectancy. However, by 1990, the US had plummeted to 18th place among those same industrialized nations. The data speaks for itself. Despite leading the world in medical expenditures, we lag in longevity. If a country's healthcare system were truly the best in the world, wouldn't its citizens live longer, healthier lives? The stark reality suggests otherwise. Quality of life, the true measure of healthcare. For many of my patients, the length of life is secondary to the quality of those years. What good is a prolonged lifespan if it is marred by cognitive decline, chronic pain, or severe disability? Neurodegenerative diseases such as Alzheimer's and Parkinson's disease are reaching unprecedented prevalence. Degenerative arthritis, strokes, heart disease, and macular degeneration continue to erode the quality of life for millions. Gone are the days when people simply died of old age. Today, they succumb to a cascade of chronic illnesses that often leave them dependent on caregivers for years. Cardiovascular disease alone afflicts over 60 million Americans, with more than 13.6 million suffering from coronary artery disease. Despite some progress in reducing cardiovascular mortality over the past 25 years, it remains the nation's leading cause of death. Each year, 1.5 million Americans suffer heart attacks, half of which prove fatal. Alarmingly, in 30% of cases, the first manifestation of heart disease is sudden death, leaving little to no opportunity for preventive intervention. Cancer remains the second leading cause of death, with over 537,000 fatalities in 1995 alone. Despite over $25 billion spent on research in the past 25 years, we have seen no significant decline in cancer-related mortality. The primary advancement has been in early detection rather than more effective treatments. Many therapies remain grueling and only marginally improve survival rates. For patients with macular degeneration, routine ophthalmologic visits often serve only to document the disease's inexorable progression. Even laser treatments offer limited benefits. Similarly, those caring for loved ones with Alzheimer's disease understand the heartbreaking reality of a condition with no truly effective treatment options. Watching a parent lose all cognitive function, trapped in a body that still functions, is a devastating experience for any family. A call for change. It is time for a paradigm shift in our approach to healthcare. As physicians, we must acknowledge the limitations of our current treatment strategies. Unlike the victories achieved in combating infectious diseases, chronic conditions remain formidable adversaries with few decisive interventions. The focus must move beyond managing disease to proactively fostering health and longevity. This requires a commitment not only from the medical community, but also from individuals who must prioritize preventive measures, nutrition, exercise, stress management, and lifestyle modifications over reliance on reactive medical interventions. If we fail to change course, we will continue to see declining returns on our vast healthcare expenditures. The goal should not simply be to extend life, but to enhance its quality. The time for a new approach is now. Preventive medicine, a paradigm shift toward true health preservation. The prevailing attitude among patients today that the onset of chronic degenerative diseases is an unavoidable aspect of aging is deeply concerning. Many individuals place unwavering faith in modern medicine, expecting pharmaceutical interventions to serve as a cure-all. However, it is often only after the manifestation of illness that patients come to realize the limitations of our current treatment modalities. As the baby boomer generation transitions into their 50s and beyond, I anticipate a significant shift toward proactive health management. More individuals are beginning to recognize the necessity of taking charge of their well-being before disease takes root. A close colleague recently expressed a sentiment that resonates profoundly with me. I simply want to live until I die. This statement encapsulates the essence of optimal health, maximizing both lifespan and health span. After more than 3 decades in medical practice, I find the prospect of chronic disease and its associated pain and suffering increasingly troubling, not only for my patients, but for myself as well. This concern is the driving force behind my advocacy for preventive medicine. However, it is essential to clarify what true prevention entails. Traditional preventive medicine, a misnomer? The healthcare industry takes great pride in promoting preventive care, yet a critical evaluation of this approach reveals its fundamental shortcomings. Physicians frequently recommend routine physical exams, pap smears, mammograms, blood panels, and other screenings as a means of maintaining health. However, these interventions primarily serve to detect disease in its early stages rather than preventing its onset. Undoubtedly, early detection improves patient outcomes, but it does not eliminate disease altogether. The medical community, constrained by the demands of treating active illnesses, often lacks the time or resources to educate patients on how to maintain optimal health through lifestyle modifications. This represents a critical gap in our healthcare system. At the essence of true preventive medicine, if we are to use the term preventive medicine, it must encompass strategies that genuinely prevent disease. A robust preventive approach should empower patients to adopt a three-pronged strategy. Nutritional eating habits, encouraging a diet rich in whole, nutrient-dense foods that support metabolic health and reduce inflammation. Consistent physical activity, implementing a sustainable exercise regimen tailored to individual needs and capabilities. Targeted nutritional supplementation, utilizing high-quality vitamins, minerals, and antioxidants to address specific deficiencies and support overall physiological function. True prevention necessitates patient engagement and commitment. However, when individuals fully grasp the profound impact of lifestyle choices on long-term health, they are often highly motivated to make the necessary adjustments. The medical profession's role in prevention. The medical field must evolve beyond its current reactive model to embrace a proactive, patient-centered approach. Physicians have a responsibility not only to diagnose and treat, but also to educate and empower their patients. By fostering an environment where preventive strategies are prioritized, we can collectively reduce the burden of chronic disease and improve quality of life for future generations. It is time for a fundamental shift in our understanding of preventive medicine, one that moves beyond early detection and truly safeguards health from the outset. The ingredients of a healthy lifestyle. Exercise. The human body is a remarkable defense system against illness, yet many individuals neglect its role in disease prevention. Dr. Kenneth Cooper, a pioneer in preventive medicine, introduced the concept of aerobics in the early 1970s, fundamentally shifting the medical community's perception of exercise as a therapeutic intervention. 3 decades ago, the medical profession was divided on the merits of prescribing exercise. However, through persistent advocacy and compelling research, Dr. Cooper demonstrated the extensive health benefits of regular physical activity. By the late 1970s, consensus among healthcare professionals emerged, leading to widespread recommendations for structured exercise programs. By the early 1980s, the US Surgeon General formally recognized the vast health advantages of modest exercise, including weight management, reduced blood pressure, strengthened bone density and lower risk of osteoporosis, increased HDL good cholesterol levels, decreased LDL bad cholesterol levels, lower triglyceride levels, enhanced muscular strength and coordination, reducing fall risk, improved insulin sensitivity, strengthened immune function, elevated overall well-being. A consistent, moderate exercise regimen is a cornerstone of disease prevention, significantly reducing the likelihood of chronic illness. Healthy diet, nutritional choices play an equally critical role in maintaining health. Research consistently supports that individuals adhering to a low-fat diet rich in fruits and vegetables, consuming at least 7 servings daily, experience significant health benefits, including weight control, reduced risk of diabetes, lower incidence of cardiovascular disease, decreased prevalence of numerous cancers, lower blood pressure, improved cholesterol profiles, enhanced immune response, increased insulin sensitivity, boosted energy levels and cognitive function. A balanced, nutrient-dense diet is integral to preventing metabolic and cardiovascular diseases and fostering long-term well-being. Nutritional supplements. Extensive medical literature underscores the benefits of high-quality nutritional supplementation, even among healthy individuals. Supplementation provides several potential health advantages: strengthened immune response, enhanced antioxidant defense mechanisms, reduced risk of coronary artery disease, decreased likelihood of stroke, lower cancer susceptibility, reduced incidence of arthritis, macular degeneration, and cataracts, possible mitigation of neurodegenerative diseases including Alzheimer's and Parkinson's, potential improvement in chronic obstructive pulmonary disease and asthma outcomes, improved management of chronic degenerative diseases. Lifestyle modification versus pharmacologic intervention. A compelling body of evidence suggests that patients who adopt a structured exercise program, adhere to a nutrient-rich diet, and incorporate supplementation may achieve significant clinical improvements in conditions such as hypertension, diabetes, and hyperlipidemia. This raises the possibility of reducing or even eliminating the need for pharmacologic intervention. Despite broad physician agreement on the value of lifestyle modification, its implementation in clinical practice remains inconsistent. Many healthcare providers prematurely resort to prescribing medication rather than emphasizing sustainable behavioral changes. The assumption that patients are unlikely to modify their habits often leads to missed opportunities for non-pharmacologic management of chronic diseases. Physicians have a responsibility to advocate for a structured trial of lifestyle interventions before initiating long-term medication therapy. By integrating exercise, nutrition, and supplementation into standard treatment protocols, healthcare providers can foster a paradigm shift toward proactive preventive medicine. Giving patients a choice. In recent years, I have adopted a more patient-centered, conservative approach to pharmacologic intervention, reserving medication as a last resort rather than a first-line treatment. I have been consistently impressed by the number of patients willing to take an active role in their health when given the opportunity to avoid or minimize pharmaceutical dependency. While some individuals remain reluctant to modify their lifestyle, for whom medication remains necessary, many others demonstrate a willingness to engage in meaningful behavioral changes when presented with an evidence-based alternative. There are, of course, cases in which immediate pharmacologic intervention is essential due to the severity of a patient's condition. However, even in these instances, I emphasize the potential for lifestyle modifications to complement medical therapy, with the long-term goal of reducing or discontinuing medication when clinically appropriate. The benefits of a well-structured exercise regimen and a balanced, nutrient-rich diet are widely recognized. However, an often overlooked component, particularly among medical professionals, is the role of high-quality nutritional supplementation. I once shared this skepticism, but emerging research continues to highlight the significant impact of targeted supplementation in optimizing health outcomes. When combined, these three pillars, nutritional excellence, regular physical activity, and evidence-based supplementation, form a powerful strategy for both disease prevention and recovery. By educating patients and empowering them with choices, we shift the paradigm from reactive disease management to proactive health optimization. Case study: a remarkable journey with leukoencephalopathy. David, a long-time driver's license examiner in Utah, had enjoyed excellent health throughout his life. He had no prior medical conditions and was not on any medications. However, in early 1990, he began experiencing progressive weakness in his lower extremities, accompanied by unexplained fatigue. By spring of that year, his condition had worsened. His gait became unsteady, he struggled with frequent falls, and his mobility significantly declined. After consultations with multiple physicians, a neurologist ultimately diagnosed David with a rare and severe neurological disorder, leukoencephalopathy. Understandably, David was unfamiliar with this condition, as are most patients upon first hearing such a diagnosis. The neurologist explained that leukoencephalopathy is a progressive, degenerative and demyelinating disorder of the brain akin to multiple sclerosis, with no known cure or effective treatment. The prognosis was bleak. The disease typically follows an inexorable downward trajectory, culminating in severe disability and ultimately death. The progression of disease. Receiving this diagnosis was devastating for David and his family. The weight of an untreatable, life-limiting illness took both a physical and emotional toll. True to the physician's predictions, his symptoms worsened. Over time, he developed severe vertigo and lost control of both bowel and bladder function. By 1993, he was confined to a wheelchair. As his condition deteriorated, neuropathic pain in his lower limbs became so severe that by mid-1995 he required oral morphine for pain management. The once independent examiner was now entirely reliant on his wife and children for daily care. In November 1995, David contracted a severe case of influenza. Already profoundly debilitated, his condition declined further, His extremities became cold, suggestive of impaired circulation, and his overall weakness intensified. Given the advanced stage of his neurological disease, his medical team informed the family that recovery was unlikely, estimating a remaining lifespan of no more than 2 weeks. David, under the care of a hospice program, chose to remain at home, as the family began preparing for the inevitable, making funeral arrangements and saying their goodbyes. Though he had long since come to terms with his prognosis, the finality of the moment was overwhelming, an unforeseen turn. Contrary to expectations, David survived beyond Christmas. Though still bedridden, he did not succumb as predicted. In early 1996, he decided to explore alternative approaches and introduced a regimen of nutritional supplementation into his routine. His regimen consisted of an antioxidant formulation, a multi-mineral supplement, and grapeseed extract. Within 5 days of initiating supplementation, David noted subtle yet significant changes. He was sleeping less and reported a modest increase in energy. Over the following weeks, his improvements became more pronounced. He regained enough strength to sit upright and, on Mother's Day, was even wheeled to a local flower shop by his children, a tradition he had long cherished but assumed he would never partake in again. Inspired by his progress, David continued his supplementation regimen. By summer 1996, he watched the film Lorenzo's Oil, which depicted a young boy afflicted with a severe demyelinating brain disorder. The film highlighted the potential therapeutic role of lipid-based antioxidants, specifically grapeseed oil. Recognizing the similarity to his own condition, David increased his intake of grapeseed extract. Clinical observations and recovery. The results were remarkable. Over the ensuing months, his pain diminished and his mobility steadily improved. He transitioned from being wheelchair-bound to standing, then walking, albeit with an impaired gait. By late 1996, David was able to walk into his church unaided for the first time in over 3 years. His physician, who had documented the relentless decline over the years, was astonished. The necessity for morphine ceased, and while skeptical, the clinician could not ignore the objective improvements observed in his patient. In a moment of personal triumph, David, who had spent his career administering driver's exams, was finally able to pass his own and regain his independence behind the wheel. The broader implications. It is important to emphasize that David's underlying disease remains. He is not cured. However, through an integrative approach, including targeted nutritional support, he has regained autonomy over his life. His case underscores an essential principle in medicine. While certain conditions may not be reversible, optimizing physiological function can profoundly impact quality of life. David's story is one of resilience, curiosity, and the potential of adjunctive nutritional strategies in chronic disease management. While more research is needed to fully elucidate the mechanisms behind his improvement, his experience serves as a compelling case study for the broader applications of antioxidant therapy in neurodegenerative conditions. A call to action. In this chapter, we have explored the conventional approach to healthcare in our society. But what about your personal approach? Have you resigned yourself to the inevitability of chronic disease, pain, or decline? Or are you willing to take proactive steps to safeguard your health? A fulfilling, vibrant life does not need to wane prematurely. Aging does not necessitate suffering. Instead, it presents an opportunity to actively engage in preserving and enhancing well-being. The key lies in understanding the biological challenges at play and addressing them with evidence-based interventions. In the next section, we will delve into the physiological battle occurring within every human body and explore strategies to fortify and sustain long-term health. The war within, the impact of oxidative stress on health. Sit back, close your eyes for a moment, and focus on your breathing. Relax your shoulders, inhale deeply, and then slowly exhale. Repeat this process several times, allowing your body to fully engage in each breath. As you do, imagine your entire body inflating with fresh oxygen, extending even to your toes. The sensation is revitalizing, isn't it? Oxygen is the essence of life, fueling every cell and sustaining our physiological processes. When we engage in aerobic exercise, our respiration quickens, leading to increased oxygen intake. This often brings a sense of invigoration, even euphoria due to the biochemical changes occurring within. As a physician, I often envision the intricate physiological processes that unfold within my body as I breathe. When oxygen enters through my nose, it travels down the trachea into my lungs, reaching the alveoli, tiny air sacs responsible for gas exchange. Here, oxygen molecules diffuse through the thin alveolar walls and bind to hemoglobin within red blood cells. With each heartbeat, this oxygenated blood is pumped throughout the body, delivering oxygen to tissues where it is needed most. Once within the cells, oxygen enters the mitochondria, our cellular powerhouses, where it plays a pivotal role in the production of adenosine triphosphate ATP, the fundamental energy currency of life. Within each cell, the mitochondria function like a controlled combustion engine, harnessing oxygen to generate energy through oxidative phosphorylation. Imagine a well-maintained fireplace, its flames flickering warmly as it burns cleanly and efficiently. However, on occasion, a stray ember escapes and lands on the carpet. A single ember may not cause significant harm, but if this process continues unchecked over months and years, the cumulative damage can be considerable. This escaped ember is analogous to a free radical, a byproduct of cellular respiration that results when oxygen is not fully reduced during ATP production. While mitochondria operate with remarkable efficiency, achieving complete reduction of oxygen to water approximately 98% of the time, there is a small yet consequential margin of error. When the reduction process fails to proceed as planned, unstable oxygen species, known as free radicals, emerge. These reactive molecules seek stability by attacking nearby cellular components, leading to oxidative damage. The metaphorical carpet represents the body, and over time, repeated exposure to free radicals contributes to cumulative wear and tear. The tissues most vulnerable to oxidative damage are often the first to exhibit signs of degenerative disease. If oxidative stress targets the eyes, conditions such as macular degeneration or cataracts may develop. If it impacts the vascular system, it may contribute to atherosclerosis, leading to heart attacks or strokes. In the joints, oxidative stress exacerbates the breakdown of cartilage, accelerating arthritis. When it affects the brain, it has been implicated in neurodegenerative conditions such as Alzheimer's and Parkinson's disease. Over time, the body, much like a carpet subjected to repeated exposure to embers, begins to show visible signs of deterioration. While we often associate oxygen with vitality and life, there exists a lesser-known narrative, one that underscores its potential for harm. This darker side of oxygen metabolism manifests as oxidative stress, a pervasive force that underlies the development of many chronic degenerative diseases. Oxidative stress is not merely an abstract concept. It is a tangible phenomenon that we can observe externally, particularly in the skin. Consider a multi-generational family portrait. Upon close examination, the stark contrast between the skin of the youngest and oldest members becomes apparent. The visible signs of aging, wrinkles, loss of elasticity, and uneven pigmentation are direct consequences of oxidative stress. What occurs on the surface is a reflection of the oxidative processes transpiring within. Understanding the balance between oxygen's life-sustaining properties and its potential for harm is crucial for mitigating the long-term effects of oxidative stress. By adopting lifestyle interventions that enhance antioxidant defenses, such as proper nutrition, regular exercise, and stress management, we can effectively counteract oxidative damage and promote longevity. The war within is ongoing, but through informed choices, we can tip the scales in favor of health and resilience. The dark side of oxygen, a physician's perspective. Recent advancements in biochemical research have elucidated a striking revelation. The underlying etiology of degenerative diseases, and perhaps even the aging process itself, is oxidative stress, an insidious consequence of free radical activity, the biochemical warfare within. At the molecular level, the reactive nature of free radicals is so intense that their chemical activity can produce measurable bursts of light. These unstable molecules, if left unchecked, trigger a cascade of oxidative reactions, leading to cellular damage and systemic dysfunction. Unbeknownst to most, a perpetual battle is taking place within the human body, a silent conflict between destructive oxidative forces and the body's intrinsic defense mechanisms. To comprehend this ongoing biochemical struggle, we must first delineate the key players. The enemy, free radicals, highly reactive oxygen species ROS that seek stability by extracting electrons from surrounding cellular structures, leading to cumulative oxidative damage. The allies, antioxidants, endogenous and exogenous compounds that neutralize free radicals, thereby mitigating oxidative stress and preserving cellular integrity. Behind the lines, supporting nutrients, essential cofactors such as B-complex vitamins, B1, B2, B6, B12 and folic acid, and antioxidant minerals. These function as critical supply lines, sustaining metabolic processes and ensuring cellular repair. Enemy reinforcement, environmental and lifestyle factors. Exposure to pollutants, chronic stress, inadequate physical activity, and suboptimal dietary habits all contribute to an excessive generation of free radicals. MASH, Mobile Army Surgical Hospital, cellular repair systems. The body's intrinsic mechanisms, including enzymatic antioxidants like superoxide dismutase, SOD, catalase, and glutathione peroxidase, serve as critical first responders in mitigating oxidative damage. Understanding free radical pathophysiology. Free radicals, primarily reactive oxygen species, are oxygen-derived molecules characterized by the presence of an unpaired electron in their outer shell. This structural instability compels them to seek electron stability by interacting with neighboring molecules, often causing chain reactions of oxidative damage. The physiological process of cellular respiration, a fundamental mechanism for ATP production, inevitably generates free radicals. However, when these radicals accumulate beyond the neutralizing capacity of endogenous antioxidants, oxidative stress ensues, leading to pathological consequences. Oxidative stress is implicated in a myriad of chronic conditions, including cardiovascular disease, neurodegenerative disorders, cancer, and accelerated aging. The deleterious effects of oxidative stress manifest through lipid peroxidation, protein degradation, mitochondrial dysfunction, and even genetic mutations within the cell nucleus. A call to action. Counteracting oxidative stress. The key to mitigating oxidative damage lies in optimizing antioxidant defense mechanisms. This entails nutritional strategies. A diet rich in antioxidant-dense foods, including polyphenols, flavonoids, and vitamins C and E, plays a pivotal role in neutralizing free radicals. Lifestyle modifications, regular physical activity, stress management, and minimizing exposure to environmental toxins can significantly reduce oxidative burden. Medical interventions. Emerging therapeutic strategies, including antioxidant supplementation and pharmacological agents targeting oxidative pathways, are being explored to combat free radical-induced pathology. Conclusion: while oxygen is indispensable for life, its byproducts can be paradoxically detrimental. Recognizing the intricate balance between oxidative processes and antioxidant defenses is paramount in the pursuit of longevity and disease prevention. As scientific exploration continues, a deeper understanding of oxidative stress will undoubtedly pave the way for innovative strategies to enhance human health and resilience. Our ally, antioxidants. The human body is constantly under assault by free radicals, unstable molecules that, if left unchecked, can cause oxidative damage to cells and tissues. However, our bodies are not defenseless in this battle. We are equipped with a sophisticated antioxidant defense system, a testament to the remarkable complexity and resilience of human physiology. Antioxidants serve as critical safeguards, neutralizing free radicals by donating an electron without becoming unstable themselves. This mechanism prevents the cascading cellular damage that free radicals can inflict. To illustrate, consider a fireplace. While sparks may still fly, a protective glass door or fine-wired mesh prevents them from igniting the carpet. Similarly, antioxidants intercept free radicals before they can compromise cellular integrity. Endogenous antioxidant defense systems. The body possesses intrinsic antioxidant defense mechanisms, primarily composed of three major enzymatic systems. Superoxide dismutase, SOD, converts superoxide radicals into hydrogen peroxide, reducing oxidative burden. Catalase further detoxifies hydrogen peroxide into water and oxygen, preventing cellular damage. Glutathione peroxidase neutralizes lipid peroxides and hydrogen peroxide, playing a crucial role in maintaining redox balance. While these endogenous antioxidants are highly effective, they are not sufficient to counteract the cumulative oxidative stress encountered through environmental exposures, metabolic processes, and lifestyle factors. Exogenous antioxidant sources. To maintain an optimal antioxidant defense, dietary intake is essential. Key antioxidants derived from food and supplementation include vitamin C, a water-soluble antioxidant that circulates in the plasma and regenerates other antioxidants. Vitamin E, a fat-soluble antioxidant that protects cell membranes from lipid peroxidation. Beta-carotene and vitamin A, essential for neutralizing single oxygen from free radical species. Coenzyme Q10, CoQ10, a mitochondrial antioxidant critical for cellular energy production and protection against oxidative stress. Alpha-lipoic acid, unique in its ability to function in both lipid and aqueous environments, enhancing overall antioxidant synergy. Bioflavonoids, plant-derived antioxidants that support vascular integrity and complement endogenous antioxidant activity. Antioxidant synergy and regeneration. Antioxidants do not function in isolation, but rather in a synergistic manner. Some antioxidants possess the ability to regenerate others, extending their protective capabilities. For instance, vitamin C regenerates vitamin E, allowing it to be reused in lipid membranes. Alpha-lipoic acid assists in regenerating both glutathione and vitamin C. Glutathione plays a pivotal role in cellular detoxification and antioxidant recycling. Maintaining the balance, the key to cellular protection. Oxidative stress arises when free radical production exceeds antioxidant availability. Over time, persistent oxidative stress contributes to chronic degenerative conditions such as cardiovascular disease, neurodegenerative disorders, and metabolic syndromes. Thus, a proactive approach is necessary, ensuring a consistent supply of antioxidants through a nutrient-dense diet, rich in colourful fruits and vegetables, strategic supplementation when needed, and lifestyle practices that minimise oxidative burden. A well-fortified antioxidant defence system is essential to preserving cellular integrity, optimising physiological function, and ultimately supporting long-term health and vitality. Behind the lines, the strategic defense against oxidative stress. In warfare, victory is not determined solely by the number of soldiers on the battlefield. A well-structured support system, logistics, supply chains and reinforcements is critical for sustaining combat effectiveness. The same principle applies to our body's defense against oxidative stress. While antioxidants serve as the frontline soldiers neutralizing free radicals, their efficacy is contingent upon a robust and sustained supply of essential nutrients. The role of antioxidant minerals. For optimal function, antioxidants require the presence of key minerals that facilitate enzymatic reactions. Copper, zinc, manganese, and selenium act as biochemical catalysts, enabling antioxidants to effectively neutralize oxidative threats. When these minerals are deficient, the body's ability to counteract free radical damage diminishes, leading to an imbalance that fosters oxidative stress. Cofactors, the unsung support system. In addition to minerals, antioxidants depend on enzymatic cofactors to maintain efficiency. These cofactors function as logistical support, akin to mechanics servicing military equipment, or supply officers ensuring the availability of fuel and ammunition. The primary cofactors involved in antioxidant defense include folic acid and B-complex vitamins B1, B2, B6, and B12. Without adequate levels of these nutrients, the biochemical machinery responsible for neutralizing free radicals becomes impaired, weakening the body's defense mechanisms. A dynamic and unpredictable battlefield. The oxidative landscape within the body is not static. The production of free radicals fluctuates based on metabolic activity, environmental exposures, and physiological stresses. The defense system must continually adapt, yet it lacks precise foreknowledge of the volume of oxidative stress it will encounter at any given moment. Factors such as inflammation, pollution, poor diet, excessive exercise, and chronic disease states can significantly increase free radical production, overwhelming the body's antioxidant capacity. This realization led me to an in-depth exploration of the sources of free radicals and the variables that exacerbate oxidative stress. To effectively mitigate their impact, we must first identify and understand these contributors. Let us now examine these underlying culprits in greater detail. What creates free radicals? Excessive exercise. In his book, The Antioxidant Revolution, Dr. Kenneth Cooper highlighted the significant increase in free radical production associated with excessive exercise. Dr. Cooper observed that many highly active individuals, including marathon runners who completed numerous races over their lifetimes, suffered from premature cardiovascular events and malignancies. This raised concerns about the long-term impact of excessive oxidative stress induced by extreme physical exertion. Research confirms that while mild to moderate exercise generates only a slight increase in free radicals, excessive exercise results in exponential free radical production. This heightened oxidative burden can contribute to cellular damage, inflammation, and chronic disease. Dr. Cooper ultimately advocated for a balanced approach, encouraging moderate exercise while emphasizing the importance of antioxidant supplementation, particularly for endurance athletes.
Excessive stress.
Similar to exercise, emotional stress can elevate oxidative stress levels. Acute stress leads to a temporary surge in free radicals, but chronic emotional distress results in sustained oxidative damage. Clinical observations reveal that individuals subjected to prolonged stress often experience immune suppression, increasing their susceptibility to infections and chronic diseases such as cardiovascular disease and cancer. Patients frequently report significant life stressors preceding the onset of serious illnesses. The biochemical mechanisms underlying this phenomenon include the overactivation of the hypothalamic pituitary adrenal HPA axis, leading to excess cortisol production, mitochondrial dysfunction, and systemic inflammation, all of which contribute to oxidative stress. Air pollution. Environmental pollutants are well-established sources of free radicals. Airborne toxins such as ozone, nitrogen dioxide, sulfur dioxide, and polycyclic aromatic hydrocarbons generate oxidative stress in pulmonary tissues, exacerbating respiratory conditions such as asthma, chronic obstructive pulmonary disease, COPD, and lung cancer. The occupational exposure to fine particulate matter, including mineral dust and asbestos, poses additional risks, contributing to conditions such as pulmonary fibrosis and mesothelioma. Long-term exposure to polluted air correlates with increased incidence of cardiovascular diseases, neurodegenerative disorders, and metabolic syndrome, underscoring the systemic impact of environmental oxidative stress.
Cigarette smoke.
Cigarette and cigar smoke represent one of the most potent sources of oxidative stress. The combustion of tobacco produces a complex mixture of reactive oxygen species and pro-inflammatory compounds, directly damaging lung epithelial cells and increasing systemic inflammation. Smoking is unequivocally linked to respiratory diseases, cardiovascular pathology, and malignancies. Nicotine addiction compounds this problem, as withdrawal often leads to increased stress levels, perpetuating a cycle of oxidative damage. Secondary smoke exposure is equally concerning, with well-documented risks including heightened susceptibility to asthma, COPD, and cardiovascular disease. Pollution of food and water. The widespread contamination of food and water supplies with pesticides, heavy metals, and industrial chemicals further contributes to oxidative stress. The US Department of Public Health has previously reported significant contamination of drinking water sources, with over 50,000 different chemicals potentially infiltrating supply lines. Heavy metals such as lead, cadmium, and aluminum are particularly concerning due to their capacity to induce oxidative damage at the cellular level, leading to neurotoxicity, cardiovascular disease, and renal impairment. Similarly, agricultural chemicals, including herbicides and fungicides, have been implicated in increased oxidative stress, necessitating more stringent regulatory oversight to mitigate long-term health consequences. Ultraviolet sunlight, ultraviolet radiation, is a well-established source of free radical formation within human skin. Chronic UV exposure leads to DNA damage, lipid peroxidation, and collagen degradation, accelerating skin aging and increasing the risk of cutaneous malignancies such as melanoma. While sunscreen use is widely recommended, it is critical to utilize broad-spectrum formulations that protect against both UVA and UVB radiation. Many sunscreens primarily block UVB rays, reducing the risk of sunburn, while allowing UVA-induced oxidative damage to persist unchecked. This partial protection may contribute to the rising incidence of skin cancer despite increased sun protection measures. Medications and radiation. Pharmacological agents, particularly chemotherapy and radiation therapy, exert their therapeutic effects by inducing oxidative stress to target cancer cells. However, this mechanism also generates collateral damage to normal cells, leading to adverse effects such as immunosuppression, gastrointestinal toxicity, and fatigue. It is crucial to recognize that all medications, including commonly prescribed drugs, contribute to oxidative stress to some degree. The metabolic processing of pharmaceuticals places significant demand on hepatic detoxification pathways, increasing reactive oxygen species production. The overuse of medications has become a significant public health concern, with adverse drug reactions constituting a leading cause of morbidity and mortality. Conclusion: oxidative stress is a fundamental driver of over 70 chronic degenerative diseases, including cardiovascular disease, neurodegenerative disorders, and cancer. The pervasive presence of free radical generating factors, ranging from lifestyle habits and environmental pollutants to pharmaceuticals and radiation, necessitates a proactive approach to mitigating oxidative damage. Endogenous antioxidant defense mechanisms play a critical role in counteracting oxidative stress. However, in the modern environment, exogenous interventions such as dietary antioxidants, lifestyle modifications, and pollution control measures are essential to preserving long-term health. Understanding the biochemical underpinnings of oxidative stress allows for targeted strategies to reduce its deleterious effects and improve overall well-being. Our repair system. The MASH unit casualties are an inevitable consequence of war, both on the battlefield and within our bodies. Despite our intricate antioxidant defense mechanisms, oxidative damage occurs, affecting lipids, proteins, cell membranes, vascular walls, and even the nuclear DNA of our cells. Scientific research has now firmly established the presence of highly specialized damage removal and repair systems that address oxidative injury at multiple levels. In essence, the human body is equipped with a remarkably sophisticated, state-of-the-art Mobile Army Surgical Hospital MASH unit. During my early years as a physician, I prepared for the possibility of serving in a MASH unit during the Vietnam War. At the University of Colorado Medical School, I trained alongside residents who had first-hand experience from the war, while many of my fellow interns were soon to be deployed. However, by the time I completed my internship, the war had ended, and the draft was no longer in effect. Although I never served in Vietnam, I vividly recall the depictions of battlefield medicine in the original MASH film, where helicopters transported wounded soldiers to field hospitals for urgent, life-saving interventions. This high-stakes, high-pressure scenario is an apt metaphor for what occurs within our bodies daily. We possess an internal medical team comprised of molecular triage nurses, enzymatic anesthesiologists, and biochemical surgeons, working tirelessly to mitigate the damage inflicted by oxidative stress and free radicals. Our bodies employ both direct and indirect repair mechanisms. While the direct repair system remains largely enigmatic, its existence is well documented. In contrast, the indirect repair system has been extensively studied and provides a more comprehensive understanding of cellular restoration. In clinical medicine, triage nurses prioritize patients based on the severity of their conditions, ensuring that those in critical need receive immediate care. Similarly, cellular triage mechanisms identify compromised cellular components and initiate reparative processes. Rather than merely patching up damage, our biological systems dismantle defective proteins and reconstruct them using recycled amino acids. Lipids and DNA undergo analogous restoration processes, reaffirming the body's intrinsic capacity for self-repair. Reflecting on these complex physiological processes, one cannot ignore their exquisite precision. During my first year of medical school, I studied the anatomy and physiology of the human eye, an organ of remarkable complexity. The retina alone comprises 12 distinct layers and billions of specialized photoreceptor cells, rods and cones that capture light waves and relay signals to the brain. This intricate system enables us to perceive the world in dynamic, full-color vision. Observing the depth of this design, I found it implausible that such complexity arose by mere chance. The same awe resurfaces as I examine the body's sophisticated immune and antioxidant defense networks. As a physician, I am convinced that the most effective defense against chronic degenerative diseases resides within the body itself, not solely in pharmacologic interventions. Biochemical research continues to unveil the inner workings of cellular processes, revealing a system far more intricate than early evolutionary theories suggested. Cells are not amorphous entities suspended in cytoplasmic fluid. They are highly organized structures housing genetic codes, transport mechanisms, and elaborate biochemical pathways essential for life. Consider the analogy of an ink pen. If we stumbled upon one, it would be illogical to assume that plastic, metal, and ink had randomly coalesced over millions of years to form a functional writing instrument. Rather, we would infer the existence of an intelligent designer. Likewise, the human body is an unparalleled masterpiece of biological engineering, a testament to the extraordinary design underlying its function. Understanding and nurturing our body's innate repair mechanisms is paramount in maintaining health and preventing disease. While modern medicine plays a crucial role in managing pathology, we must recognize and support the body's own regenerative capacities, a system that remains one of the most sophisticated and effective defenses against illness. The devastation of war, oxidative stress, and cellular breakdown. Despite the remarkable defense and repair mechanisms inherent in human physiology, cellular damage remains an inevitable consequence of oxidative stress. When the production of free radicals surpasses the capacity of endogenous antioxidant systems, a cascade of biochemical dysfunction ensues, ultimately contributing to chronic degenerative disease. Under conditions of excessive oxidative burden, the body's intricate network of enzymatic and non-enzymatic antioxidants may become overwhelmed, leading to the accumulation of damaged proteins, lipids, cellular membranes, and DNA. If these molecular components are not adequately repaired, they compromise critical cellular functions. Misfolded proteins disrupt enzymatic activity, oxidized lipids induce membrane rigidity, and cholesterol oxidation accelerates atherosclerosis. Furthermore, DNA damage, when ineffectively restored, sets the stage for genetic mutations, a fundamental driver of oncogenesis and aging-related pathology. The cumulative effect of chronic oxidative damage is profound. When the body's reparative capacity is exceeded, a spectrum of diseases emerges, including cardiovascular pathology, neurodegeneration, and malignancy. Biochemical research has long underscored the precarious balance between oxidative injury and cellular resilience, emphasizing that without robust antioxidant defenses, the deleterious effects of free radical damage would render life unsustainable. This underscores the critical importance of optimizing endogenous protective mechanisms through both physiological regulation and strategic clinical intervention to mitigate the long-term consequences of oxidative stress. Our best defense. In today's world, our bodies face an unprecedented level of physiological stress. Since the time of Eden, both our environment and our food sources have undergone profound changes, many of which are detrimental to human health. Air and water pollution, the cumulative effects of smoking, and the relentless pace of modern life have significantly increased oxidative stress on the body. Compounding these challenges, the nutritional quality of our food supply has declined dramatically. In 1970, Americans spent approximately $6 billion on fast food. By the year 2000, that figure had skyrocketed to over $110 billion. Today, the nation spends more on fast food than on higher education, technology, or even entertainment. These environmental and dietary factors have led to an increase in free radical activity, unstable molecules that contribute to cellular damage and chronic disease. The only effective countermeasure is to optimize the body's natural defense systems through evidence-based nutritional medicine. By incorporating essential antioxidants, vitamins, and minerals into our daily regimen, we can fortify the immune system and enhance our resistance to oxidative damage. The human body is remarkably designed to repair and protect itself when given the right tools. Nutritional intervention provides the critical elements necessary to sustain cellular integrity and combat the effects of a polluted world. When we supply the body with optimal nutrient levels, we empower it to function as intended. Understanding oxidative stress and its far-reaching impact is the first step toward taking control of your health. Armed with this knowledge, you can make informed choices that enhance longevity and vitality. While aging and mortality are inevitable, the goal is not merely to extend life, but to improve its quality. As a colleague once remarked, the true aspiration is to live until we die, maximizing wellness for as long as possible. Balance, the cornerstone of oxidative health. As a young teenager, I witnessed a fascinating economic shift when the federal government removed most of the silver from our coins. Overnight, solid silver coins became more valuable than their newly minted counterparts. Businesses and individuals alike scrambled to acquire these older coins, and I was no exception. I had a distinct advantage. My father owned a Dairy Queen. Each evening, he brought home a collection of coins, which I dutifully rolled into paper sleeves. With his permission, I set aside the silver coins, later taking them to Mr. Smalley's hardware store on Main Street. Walking through the store's heavy wooden door, I was met by the familiar scents of aged timber, oil, and furniture polish. Mr. Smalley always greeted me warmly before pulling out his antique balance scale, the kind with dual trays suspended from a central beam. He placed my silver coins on one side and began adding brass weights to the other, carefully counterbalancing the load. As the scale approached equilibrium, he'd glance at me with a knowing smile, and when the trays finally aligned, he'd exclaim, "Bingo!" before calculating my payout. This vivid memory serves as an apt metaphor for oxidative stress. Just as Mr. Smalley worked to balance the scale, our bodies constantly strive to counteract free radicals with antioxidants. Free radicals, much like the silver coins, accumulate due to environmental toxins, processed foods, and metabolic processes. Antioxidants, akin to the brass weights, are our body's defense system, mitigating oxidative damage and promoting cellular health. Historically, whole, unprocessed foods supplied ample antioxidants to maintain this balance. However, with modern agricultural practices and dietary habits, we no longer receive the same level of protective nutrients. Compounding this issue, our exposure to pollutants and stressors has escalated dramatically, shifting the scale unfavorably toward oxidative damage. To restore equilibrium, strategic supplementation with high-quality antioxidants is essential. By enhancing the body's intrinsic defense mechanisms, we can shift the balance in favor of optimal health. In the chapters that follow, I will present the scientific evidence supporting nutritional interventions, including diet modification, moderate exercise, and targeted supplementation. Additionally, I will introduce optimizers, potent antioxidants that can not only maintain well-being but also restore health in those already affected by oxidative stress. Before we delve into the science, let's meet someone who has first-hand experience with the transformative power of nutritional medicine. Evelyn's story, a case study in oxidative stress and cellular nutrition. Evelyn had recently relocated to Spokane, Washington with her family when a catastrophic automobile accident left her hospitalized with multiple traumatic injuries. Soon after, she developed left-sided weakness and numbness, raising clinical concerns for a cerebrovascular event. Despite exhaustive diagnostic testing, Evelyn and her family remained in a state of uncertainty, unable to comprehend the underlying cause of her symptoms. Approximately 6 months later, after consulting with no fewer than 18 physicians, Evelyn was diagnosed with multiple sclerosis, MS. Research has long established that oxidative stress, often triggered by physical trauma or major surgical interventions, can play a pivotal role in the pathogenesis of MS. Evelyn's physicians hypothesized that the severe physiological stress from the accident had precipitated the onset of her disease. Despite the gravity of her diagnosis, Evelyn was determined to maintain a positive outlook. She was initially prescribed betaseron, interferon beta-1b, a widely used disease-modifying therapy, DMT, for MS. This medication functions by modulating immune system activity. However, it is known for its high cost and challenging side effect profile. Unfortunately, Evelyn exhibited significant intolerance to betaseron, experiencing profound systemic adverse effects that severely impacted her quality of life. After 2 months of persistent and debilitating symptoms, she made the difficult decision to discontinue the medication with the full support of her family. Reflecting on this period, Evelyn recalls the emotional toll. "I was devastated. I spent countless nights wandering through my home, struggling to make sense of my diagnosis. I would sit by the window, overwhelmed by uncertainty, searching for answers." In an effort to cope with her new reality, Evelyn and her family actively participated in MS support groups and adapted their lifestyle to accommodate her evolving needs. The unpredictability of MS meant she had to confront the looming possibility of vision loss. She vividly remembers watching her children sleep, committing their faces to memory, fearing she might one day lose the ability to see them. As the disease progressed, Evelyn's functional capacity deteriorated significantly. Over the next 4 years, she experienced progressive lower extremity weakness, necessitating the transition from a 4-pronged cane to a walker. Compounding her physical limitations were debilitating complications, including neurogenic bowel and bladder dysfunction, leading to recurrent urinary tract and kidney infections. The cumulative impact of these symptoms rendered her fully dependent on her family for both physical and emotional support. Despite these setbacks, Evelyn remained resolute. She sought physical therapy and engaged in extensive research on MS, exploring both conventional and alternative treatment modalities. However, despite her proactive approach, her condition continued to decline. Then, nearly 4 years after her diagnosis, Evelyn decided to implement a targeted nutritional strategy aimed at mitigating oxidative stress and slowing disease progression. She introduced a regimen consisting of high-potency antioxidants, essential minerals, grapeseed extract, and coenzyme Q10, CoQ10, a vital cofactor in mitochondrial energy production. The results were nothing short of remarkable. Within weeks, she reported a significant improvement in her overall well-being. "For the first time in years, I slept through the night and woke up feeling refreshed. My bladder and bowel function normalized, my endurance improved, and my strength began returning. One day, I even ran up the stairs to answer the phone, something my children hadn't seen me do in years." Evelyn's improvements extended beyond her MS symptoms. She had previously struggled with heart palpitations, a condition managed with the antiarrhythmic medication Norpace, disopyramide. To her surprise, her cardiac rhythm stabilized, prompting her physician to re-evaluate her treatment. After a thorough assessment, her cardiologist deemed medication unnecessary, noting in her medical record, "off all meds." Evelyn's case raises important clinical questions. How did she experience such profound functional recovery? Could targeted nutritional intervention have contributed to neuroprotection and disease modulation? At the time I became involved in Evelyn's care, I had never encountered such dramatic improvement in an MS patient. While it is well documented that MS can exhibit periods of remission, sustained functional gains of this magnitude are exceedingly rare. Unlike typical MS remissions, which often occur alongside progressive neurodegeneration, Evelyn's trajectory suggested a fundamental shift in her underlying pathophysiology. The key mechanism at play appeared to be the restoration of redox balance through optimal nutrient intake. By addressing oxidative stress and supporting mitochondrial function, Evelyn facilitated an environment conducive to cellular repair and neuroprotection. Her case exemplifies the emerging paradigm of cellular nutrition as a foundational approach to chronic disease management. Today, Evelyn continues to thrive. More than 7 years since initiating her nutritional protocol, she maintains an active lifestyle. She remains engaged with the MS community, attending support group meetings, not for her own benefit, but to inspire and educate others facing similar challenges. Her neurologist, initially skeptical, recently ordered a follow-up MRI to assess disease progression. The findings were striking. The characteristic white matter plaques, a hallmark of MS, had significantly regressed. In conventional MS pathology, these lesions typically increase in number over time. Yet in Evelyn's case, healing had objectively occurred. Her neurologist was left without a clear medical explanation. Evelyn's journey underscores a profound clinical truth. When the body is provided with essential nutrients at optimal levels, it retains an intrinsic ability to heal. While MS remains an incurable disease, Evelyn's case challenges us to reconsider the role of nutritional medicine in disease management and neuroprotection. As we delve deeper into the principles of oxidative stress and its implications for chronic degenerative diseases, Evelyn's story serves as a compelling testament to the power of cellular nutrition. Whether seeking to prevent disease or to optimize health outcomes in existing conditions, understanding and applying these principles may hold the key to a more resilient, vibrant future. Heart disease, an inflammatory disease. As physicians, we are constantly reminded of the pervasiveness of America's cholesterol problem. Cardiovascular disease remains the leading cause of mortality in the United States, yet the conventional narrative surrounding cholesterol as the primary culprit is deeply flawed. Emerging research indicates that inflammation, rather than cholesterol itself, is the fundamental driver of atherosclerosis and heart disease. This paradigm shift is critical in understanding the true pathology of cardiovascular events. In fact, more than 50% of patients who suffer heart attacks have cholesterol levels within the normal range. Such findings challenge long-held assumptions and call for a more nuanced approach to prevention and treatment, one that focuses on mitigating vascular inflammation rather than solely reducing cholesterol levels. The role of cholesterol, a historical perspective. For decades, cholesterol was not considered a major cardiovascular risk factor. In the early years of modern cardiology, a total cholesterol level below 320 milligrams per deciliter was deemed normal. However, landmark epidemiological studies, such as the Framingham Heart Study, established a correlation between elevated cholesterol levels and increased cardiovascular risk. By the late 1970s, thresholds were redefined, with total cholesterol levels above 240 milligrams per deciliter classified as high risk. Subsequent research in the 1980s further refined our understanding. It became evident that not all cholesterol is harmful. High-density lipoprotein HDL cholesterol was recognized for its protective role, whereas low-density lipoprotein LDL cholesterol was implicated in atherogenesis. This discovery led to a more comprehensive lipid panel assessment, with clinicians now evaluating total cholesterol, HDL, LDL, and their respective ratios to assess cardiovascular risk. The inflammatory hypothesis of heart disease. While cholesterol remains an important biomarker, it is not inherently harmful in its native state. LDL cholesterol plays a crucial role in cellular function, contributing to membrane integrity and hormone synthesis. However, oxidative modification of LDL by free radicals transforms it into an atherogenic form, triggering endothelial dysfunction and plaque formation. Dr. Daniel Steinberg, in a seminal 1989 publication in the New England Journal of Medicine, proposed that the oxidation of LDL cholesterol rather than LDL itself is the true driver of atherosclerosis. His hypothesis was met with significant interest, leading to a surge of research investigating the role of oxidative stress and inflammation in cardiovascular disease. Subsequent studies have reinforced this concept. In 1997, Dr. Marco Diaz conducted an extensive review of clinical trials, concluding that patients with the highest levels of antioxidants exhibited the lowest incidence of coronary artery disease. Additionally, animal models corroborated these findings, demonstrating a direct link between oxidative stress and vascular pathology. A new approach, targeting inflammation and oxidative stress. The implications of these findings are profound. Rather than focusing exclusively on cholesterol reduction, cardiovascular prevention and treatment strategies must prioritize inflammation control and oxidative stress mitigation. This involves nutritional interventions. Diets rich in antioxidants, such as the Mediterranean diet, have been associated with reduced cardiovascular risk. Key nutrients, including vitamins C and E, polyphenols, and omega-3 fatty acids, play a protective role against oxidative damage. Lifestyle modifications. Regular physical activity, smoking cessation, and stress management are essential in reducing systemic inflammation. Pharmacological approaches. While statins effectively lower LDL cholesterol, their pleiotropic effects on inflammation may be equally, if not more, beneficial. Emerging therapies targeting inflammatory pathways, such as IL-1 beta inhibitors, show promise in reducing cardiovascular events. Conclusion. The conventional cholesterol-centric model of heart disease is being replaced by a more comprehensive understanding of vascular inflammation. As clinicians, we must embrace this evolving paradigm, integrating anti-inflammatory strategies alongside lipid management in our approach to cardiovascular care. By addressing the root cause of atherosclerosis, oxidative stress and inflammation, we can develop more effective prevention and treatment protocols, ultimately reducing the burden of heart disease. The nature of the inflammatory response. Inflammation of the vascular system is a complex, multifaceted process that extends beyond the role of low-density lipoprotein, LDL, cholesterol. Other significant contributors include homocysteine, discussed in detail in Chapter 6, and oxidative stress induced by factors such as cigarette smoking, hypertension, poor dietary habits, and diabetes. The pathophysiology of arterial inflammation mirrors that of inflammatory processes elsewhere in the body. A clear understanding of this phenomenon at the cellular level is essential, though the intricate details may be challenging even for medical professionals. The goal here is to delineate the key mechanisms involved in this process and highlight strategies for mitigating arterial inflammation. Step 1. Endothelial injury and the initiation of atherosclerosis. The endothelium, a single-cell thick layer lining the interior of blood vessels, serves as a critical barrier regulating vascular homeostasis. This delicate layer is particularly susceptible to oxidative stress, which is widely regarded as the initial trigger for atherosclerotic disease. Oxidized LDL cholesterol, homocysteine, and free radicals generated by environmental and metabolic insults contribute to endothelial dysfunction. When native LDL cholesterol infiltrates the subendothelial space, it undergoes oxidation, thereby provoking a localized inflammatory response. Step 2. Activation of the inflammatory cascade. The immune system responds to endothelial injury by recruiting monocytes, which differentiate into macrophages upon entering the vascular intima. These macrophages attempt to clear oxidized LDL cholesterol through phagocytosis, transforming into lipid-laden foam cells. In a physiological setting, a controlled inflammatory response would suffice to restore endothelial integrity. However, in the case of persistent oxidative stress, this process becomes self-perpetuating. Without a regulatory feedback mechanism, macrophages continue to engulf oxidized LDL, leading to the formation of foam cells, which aggregate to form the earliest detectable lesion of atherosclerosis, the fatty streak. This lesion marks the inception of chronic inflammation within the vascular wall, setting the stage for progressive plaque development. Step 3. Chronic inflammatory response and plaque progression. Chronic inflammation is the driving force behind atherosclerosis and its sequelae, including myocardial infarction, stroke, and peripheral vascular disease. Over time, the fatty streak evolves into a more complex atherosclerotic plaque, characterized by ongoing leukocyte recruitment, foam cell accumulation, and smooth muscle cell proliferation. This persistent inflammatory milieu not only exacerbates plaque burden, but also disrupts endothelial function by impairing nitric oxide synthesis, which is essential for vascular dilation and platelet inhibition. The loss of nitric oxide bioavailability predisposes the endothelium to thrombosis and vasospasm, further narrowing the arterial lumen. Step 4. Plaque rupture and thrombotic events. Atherosclerotic plaques may remain asymptomatic for extended periods until a critical event occurs, plaque rupture. In approximately 50% of acute coronary syndromes, plaque rupture initiates an acute thrombotic event, leading to abrupt vessel occlusion. Notably, plaques most vulnerable to rupture are often small and non-obstructive, making preemptive diagnosis challenging. In cases of significant arterial stenosis, patients may present with symptoms of angina, prompting further diagnostic evaluation via coronary angiography. If severe obstruction is identified, interventional approaches such as percutaneous coronary intervention (PCI) with stenting or coronary artery bypass grafting (CABG) may be required to restore perfusion. Clinical implications and preventive strategies. The primary focus of contemporary cardiovascular medicine remains centered on managing the advanced stages of atherosclerotic disease. However, a paradigm shift toward prevention through lifestyle modification, risk factor management, and pharmacological intervention is essential to curtail the burden of cardiovascular morbidity and mortality. By targeting the root causes of endothelial dysfunction and chronic inflammation, oxidative stress, dyslipidemia, and metabolic dysregulation, clinicians can effectively mitigate the progression of atherosclerosis and reduce the incidence of life-threatening cardiovascular events. True prevention and evidence-based approach to cardiovascular health. The role of antioxidants and supporting nutrients in cardiovascular health has been extensively studied, with compelling evidence demonstrating their ability to mitigate or even prevent the inflammatory processes that could contribute to arterial disease. Numerous clinical trials underscore the efficacy of nutritional supplementation in reducing the risk factors associated with cardiovascular pathology. Below, we examine the key nutrients involved in this protective mechanism and their specific contributions to vascular health. Vitamin E, a critical antioxidant in atherosclerosis prevention. Vitamin E is a pivotal fat-soluble antioxidant that plays an essential role in preventing lipid oxidation, a key factor in the pathogenesis of atherosclerosis. Due to its lipophilic nature, vitamin E is incorporated into low-density lipoprotein LDL cholesterol, where it exerts a protective effect against oxidative modification. Elevated concentrations of vitamin E within the LDL particle enhance its resistance to oxidation, thereby decreasing its potential to initiate an inflammatory cascade within the arterial wall. Oxidation of LDL cholesterol occurs not within the arterial lumen, but upon penetration into the subendothelial space, where antioxidant defenses are markedly lower. Research suggests that systemic antioxidant capacity within plasma is sufficient to prevent oxidative modifications in circulation, but once LDL enters the subendothelial space, it is more vulnerable. When vitamin E is present in adequate concentrations, it serves as a crucial line of defense, preventing oxidative damage and mitigating monocyte recruitment, thereby reducing the likelihood of inflammatory plaque formation. Vitamin C, plasma antioxidant endothelial protector. Vitamin C, as a water-soluble antioxidant, serves as a primary defense mechanism within the circulatory system. Evidence suggests that vitamin C supplementation enhances endothelial function, which is central to maintaining vascular integrity and preventing the inflammatory processes associated with atherosclerosis. Beyond its direct antioxidant role, vitamin C contributes to cardiovascular protection by preserving the function of vitamin E and intracellular glutathione. It has been shown to regenerate oxidized vitamin E, thereby prolonging its antioxidative activity. Additionally, vitamin C confers direct protection against LDL oxidation both within the plasma and the subendothelial space, reinforcing its critical role in vascular health. Glutathione, the master intracellular antioxidant. Glutathione is a powerful endogenous antioxidant found in all cells, particularly those surrounding the subendothelial space. Research indicates that individuals with coronary artery disease exhibit lower intracellular glutathione levels compared to those with healthy vasculature. Given its extensive role in cellular detoxification and oxidative stress reduction, glutathione is a key component in the body's overall antioxidant defense system. Enhancing glutathione synthesis through nutritional precursors such as selenium, vitamin B2, riboflavin, niacin, and N-acetyl-L-cysteine can significantly bolster intracellular antioxidant capacity. This, in turn, improves the body's ability to counteract oxidative damage and inflammatory signaling within the arterial wall. Bioflavonoids, polyphenolic antioxidants in cardiovascular protection. Bioflavonoids are a diverse group of polyphenolic compounds present in fruits, vegetables, and other plant-based foods. These compounds exert potent antioxidant, anti-inflammatory, and endothelial protective effects. A well-recognized subclass, polyphenols found in red wine and grape juice, have been demonstrated to reduce LDL oxidation and enhance endothelial function. Similarly, grapeseed extract has been identified as one of the most effective bioflavonoid antioxidants, particularly in mitigating chronic inflammatory responses implicated in cardiovascular disease. Conclusion: the cumulative evidence underscores the critical role of antioxidants in modulating cardiovascular inflammation and oxidative stress. Ensuring adequate intake of key antioxidants, including vitamin E, vitamin C, glutathione precursors, and bioflavonoids, presents a viable strategy for reducing the risk of atherosclerosis and enhancing vascular health. As research continues to evolve, a more comprehensive understanding of these mechanisms will further refine preventative strategies in cardiovascular medicine. Nutritional medicine, the key to true prevention. Emerging research increasingly points to inflammation driven by oxidative stress as the fundamental cause of cardiovascular disease. While this insight is groundbreaking, the challenge now falls on practicing physicians, clinicians like myself, to translate these findings into meaningful evidence-based recommendations for patient care. A fundamental issue in nutritional research is the tendency to evaluate individual nutrients in isolation, much like pharmaceutical agents. Clinical trials frequently assess the impact of one nutrient at a time, vitamin E in one study, vitamin C in another, and beta-carotene in yet another. When a given nutrient does not show a statistically significant benefit in isolation, skepticism arises, leading to the controversy often seen in both the medical literature and the media. Physicians are trained to demand irrefutable proof before endorsing any therapeutic intervention, but in doing so, they often overlook the synergistic nature of nutritional medicine. The synergy of antioxidants and cellular nutrition. Antioxidants do not work in isolation. To effectively neutralize oxidative stress, the body requires a comprehensive network of antioxidants along with their essential cofactors. This synergy is paramount in mitigating inflammation and preventing vascular damage. In my clinical practice, I emphasize the need to provide optimal levels of key nutrients to the cells and tissues long before oxidative damage takes hold. For example, vitamin E must be present in sufficient quantities within LDL cholesterol to prevent its oxidation, a critical factor in atherosclerosis. Vitamin C is essential for maintaining endothelial integrity, reducing LDL oxidation, and regenerating both vitamin E and glutathione. Beta-carotene and other carotenoids play a crucial role in slowing oxidative damage. Beyond these, glutathione, the body's master antioxidant, must be continuously replenished. To achieve this, I focus on providing its precursors, including selenium, vitamin B2, N-acetyl-L-cysteine, NAC, and niacin. Additionally, as we will explore in the next chapter, the B-complex vitamins, folic acid, B6, and B12, are critical in reducing cardiovascular risk by regulating homocysteine levels. A comprehensive approach to cardiovascular health. By addressing inflammation at its root through synergistic cellular nutrition, we can significantly reduce the burden of oxidative stress and vascular injury. This approach is not about treating disease after it develops. It is about true prevention. In the next chapter, we will explore a rising concern in cardiovascular medicine, homocysteine, the new kid on the block. Homocysteine, the emerging cardiovascular risk factor, understanding homocysteine and its clinical significance. Have you ever had your homocysteine levels checked? More importantly, has your physician ever recommended a blood test to assess this critical biomarker? Likely not. However, after reviewing the evidence surrounding homocysteine, you may find yourself questioning why this crucial test is not a routine part of cardiovascular risk assessment. While cholesterol has long been the primary focus of cardiovascular disease, CVD prevention, emerging research suggests that homocysteine plays an equally significant role in vascular pathology. It is estimated that elevated homocysteine levels contribute to approximately 15% of all myocardial infarctions and cerebrovascular accidents globally. In the United States alone, this accounts for near 225,000 heart attacks and 24,000 strokes annually. Additionally, around 9 million individuals suffer from cardiovascular complications directly linked to hyperhomocystinemia. Given the gravity of these statistics, understanding and managing homocysteine levels is of paramount importance. Fortunately, mitigating this risk is both simple and cost-effective. Adequate intake of B vitamins can effectively regulate homocysteine metabolism and reduce its vascular impact. The biochemical basis of homocysteine. Homocysteine is an intermediate byproduct formed during the metabolism of methionine, an essential amino acid abundant in dietary proteins such as meat, eggs, dairy, and processed foods. Under normal physiological conditions, homocysteine is efficiently metabolized via two primary pathways, remethylation back to methionine or transsulfuration to cysteine. These metabolic conversions require essential cofactors, folic acid, vitamin B9, vitamin B12, and vitamin B6. Deficiencies in these B vitamins lead to impaired homocysteine metabolism, resulting in its accumulation within the bloodstream, a condition known as hyperhomocysteinemia. The clinical implications of hyperhomocysteinemia. Excess homocysteine exerts deleterious effects on vascular health through multiple mechanisms. Endothelial dysfunction. Homocysteine promotes oxidative stress and reduces nitric oxide availability, impairing vasodilation and endothelial integrity. Atherosclerosis acceleration. It induces smooth muscle proliferation and enhances lipid oxidation, contributing to plaque formation and arterial stiffness. Prothrombotic state. Elevated homocysteine levels increase platelet aggregation and fibrin deposition, predisposing individuals to thrombosis. The association between homocysteine and cardiovascular disease was first elucidated by Dr. Kilmer McCulley, a pathologist and researcher at Harvard Medical School in the 1960s. His groundbreaking work linked elevated homocysteine levels to premature atherosclerosis, particularly in children with homocystinuria, a rare genetic disorder causing severe hyperhomocysteinemia. Observing that these children developed arterial damage comparable to that seen in elderly individuals with advanced atherosclerosis, Dr. McCulley hypothesized that even moderate elevations in homocysteine could contribute to cardiovascular pathology over a lifetime. Despite initial skepticism, subsequent epidemiological and clinical studies have validated his findings, establishing homocysteine as an independent risk factor for cardiovascular disease. Addressing homocysteine, the role of B vitamin supplementation. Unlike traditional cardiovascular risk factors such as hypertension and hyperlipidemia, which often require pharmacologic intervention, hyperhomocysteinemia can frequently be managed through dietary modification and targeted supplementation. Studies have demonstrated that supplementation with folic acid, vitamin B12 and vitamin B6 effectively lowers homocysteine levels, thereby reducing associated cardiovascular risk. Furthermore, dietary strategies emphasizing leafy greens, legumes, and fortified cereals can support optimal homocysteine metabolism. The need for clinical awareness and routine screening. Despite compelling evidence, homocysteine screening remains underutilized in routine clinical practice. This gap underscores the need for increased awareness among healthcare professionals regarding the role of homocysteine in cardiovascular risk stratification. Integrating homocysteine testing into standard cardiovascular assessments could provide a more comprehensive evaluation of an individual's risk profile, enabling early intervention and personalized preventive strategies. As research continues to unveil the intricate relationship between homocysteine and vascular health, it is imperative that clinicians and patients alike recognize the importance of this biomarker. By adopting proactive measures, including routine screening and appropriate B vitamin supplementation, we can take a significant step toward reducing the global burden of cardiovascular disease. Right stuff, wrong error. In the late 1960s and early 1970s, Dr. Kilmer McCulley's pioneering work on the role of homocysteine in cardiovascular disease was met with initial enthusiasm within the medical community. His department chief, Dr. Benjamin Castle, recognized the potential significance of his findings and actively promoted his research to esteemed panels of experts. However, as the decade progressed, the tide began to shift. Following Dr. Castle's retirement, the leadership dynamics changed. The new department chair at Harvard Medical School informed Dr. McCulley that continued institutional support was contingent on his ability to secure independent funding. His laboratory was relegated to the basement, signaling a clear decline in institutional endorsement. Despite his persistent efforts to sustain his work, financial and administrative barriers ultimately prevailed. In 1979, Harvard terminated Dr. McCulley's position, citing a lack of definitive proof for his homocysteine hypothesis. The repercussions were swift and severe. With his appointments at both Harvard Medical School and Massachusetts General Hospital intrinsically linked, Dr. McCulley lost both positions simultaneously. His hypothesis faced outright dismissal, with a former Harvard classmate, then the director of MIT's Arteriosclerosis Center, publicly denouncing his work as errant nonsense and a hoax being perpetrated on the public. The Massachusetts General Hospital's Director of Public Affairs went so far as to request that McCulley cease any association between his homocysteine research and the institution. Effectively, his voice in the scientific community was silenced. The question remains, why such resistance toward a researcher dedicated to uncovering potential contributors to cardiovascular disease? Was it simply scientific skepticism, or were external influences at play? At the time, the cholesterol-centric model of heart disease was gaining substantial traction, supported by extensive research funding. Dr. McCulley's hypothesis directly challenged this prevailing narrative. Dr. Thomas James, a cardiologist, former president of the University of Texas Medical Branch and president of the American Heart Association 1979 to 1980, later acknowledged the difficulty of securing research funding for ideas that diverged from the cholesterol paradigm. You couldn't get ideas funded that went in other directions than cholesterol, he remarked. You were intentionally discouraged from pursuing alternative questions. I've never dealt with a subject in my life that elicited such an immediate hostile response. With competing hypotheses suppressed, the cholesterol theory dominated the field. Pharmaceutical companies capitalized on this momentum, developing cholesterol-lowering medications that would generate billions in revenue. The narrative became entrenched, shaping both medical practice and public perception. In hindsight, one must ask, was the rapid, unwavering acceptance of the cholesterol theory truly grounded in unbiased scientific inquiry, or was it a carefully curated consensus? Renewed interest in homocysteine. The role of homocysteine in cardiovascular disease gained renewed attention in 1990 when Dr. Meyer Stampfer, a professor of epidemiology and nutrition at the Harvard School of Public Health, revisited Dr. Kilmer McCulley's original hypothesis. Dr. Stampfer analyzed homocysteine levels in a cohort of 15,000 physicians participating in a large-scale health study and identified a significant association between even mildly elevated homocysteine levels and an increased risk of cardiovascular disease. Notably, individuals in the highest quartile of homocysteine levels exhibited a threefold increase in myocardial infarction risk compared to those with the lowest levels. This study was among the first to substantiate homocysteine as a potential independent risk factor for coronary artery disease. Further reinforcing these findings, Dr. Jacob Seller published a pivotal study in the New England Journal of Medicine in February 1995, demonstrating a direct correlation between elevated plasma homocysteine and an increased prevalence of carotid artery stenosis, a critical risk factor for ischemic stroke. Moreover, Drs. Selhub noted a concomitant deficiency in folic acid, vitamin B12 and vitamin B6 among individuals with hyperhomocystinemia, highlighting a potential avenue for therapeutic intervention. The European Concerted Action Project, another large-scale case control study, further validated these associations, revealing a dose-dependent relationship between homocysteine levels and myocardial infarction risk. Previously accepted thresholds for normal homocysteine concentrations were now being re-evaluated as potentially hazardous. More concerning was the observation that elevated homocysteine compounded the deleterious effects of other major cardiovascular risk factors, such as hypertension, hypercholesterolemia, and smoking, resulting in a multiplicative increase in vascular disease risk. These findings reinforce the notion that optimizing homocysteine levels may serve as a critical component of cardiovascular risk reduction. Despite initial skepticism, the medical community gradually embraced homocysteine as a credible, independent risk factor for atherosclerotic disease. Even staunch proponents of traditional lipid-centric models, such as Dr. Claude L'Enfant, then director of the National Heart, Lung and Blood Institute, acknowledged its significance, stating, even if the risk of elevated homocysteine is not entirely proven, it remains an extremely important area of research. Today, the evidence is unequivocal. Elevated homocysteine plays a contributory role in coronary artery disease, cerebrovascular disease, and peripheral arterial disease. Given its modifiable nature, primarily through dietary and pharmacologic intervention targeting B vitamin status, homocysteine reduction represents an important yet underutilized strategy in cardiovascular prevention and management. Show me the money, the economic powers of medicine. The reality of modern medicine is often shaped as much by economic forces as by scientific discovery. Consider the striking fact that over half of individuals who suffer heart attacks have normal cholesterol levels. Why did it take a quarter of a century for the medical community to acknowledge Dr. Kilmer McCulley's hypothesis on homocysteine as a cardiovascular risk factor? The delay was not due to a lack of evidence, but rather a lack of financial incentive. Dr. Charles Hennekens, a renowned professor at Harvard Medical School and chief of preventive medicine at Brigham and Women's Hospital, provides a pertinent analogy. He notes that despite overwhelming evidence supporting aspirin's role in preventing recurrent heart attacks, it remains underutilized. As he wryly observed at an FDA advisory committee meeting, if aspirin were half as effective, 10 times as expensive and available only by prescription, maybe people would take it more seriously. Pharmaceutical companies certainly would. The parallels with homocysteine-lowering therapies are striking. Just as aspirin costs mere pennies a day, yet is often overlooked in favor of costly alternatives, vitamin B supplements, effective in reducing homocysteine levels, suffer from a lack of commercial interest. As Dr. Maya Stampfer, a leading epidemiologist, aptly states, there's just not the commercial interest for supporting research in homocysteine because nobody's going to make money on it. Contrast this with the enormous financial success of cholesterol-lowering medications. Statins generate billions of dollars annually, bolstered by aggressive marketing campaigns. Have you ever considered who educated you about the dangers of high cholesterol? The full-page ads in national newspapers and primetime television commercials are funded by pharmaceutical companies with vested interests in cholesterol management. Meanwhile, public awareness of homocysteine remains minimal, not because the science is lacking, but because the financial incentives are. Simply put, there is far less profit in selling vitamin B12, vitamin B6 and folic acid than in marketing patented lipid-lowering drugs. This economic reality has profound consequences. Dr. McCulley himself faced professional repercussions, losing research funding and his position at Harvard, possibly because his findings threatened the prevailing medical paradigm and the lucrative industry built around cholesterol management. Dr. McCulley offers a sobering perspective. The most dramatic improvements in longevity over the last couple of hundred years have been through public health, not through medicine. But public health is notoriously unprofitable. People don't make a profit preventing disease. They make a profit through medicine, treating critical advanced stages of disease. The economics of medicine influence not only which treatments are promoted, but also which scientific discoveries receive attention. Understanding this dynamic is crucial for both healthcare professionals and patients seeking the best preventive strategies for long-term health. Is there an optimal level of homocysteine? Unlike cholesterol, which serves essential physiological functions such as hormone production and cell membrane integrity, homocysteine confers no known health benefits. Rather, elevated homocysteine levels correlate with an increased risk of cardiovascular disease. The prevailing medical consensus is that lower homocysteine levels are preferable, with no established threshold below which it becomes inconsequential. In essence, the goal should be to maintain homocysteine at the lowest possible level. Laboratory reference ranges typically define homocysteine levels as normal between 5 and 15 micromoles per litre. However, emerging evidence suggests that cardiovascular risk begins to rise when levels exceed approximately 7 micromoles per litre. Ideally, individuals should aim for homocysteine levels below 7 micromoles per litre. Levels exceeding 12 micromole per litre indicate a significantly increased risk and warrant immediate intervention. It is important to recognize that laboratory reference ranges often lag behind advances in medical research. This has historically been the case with lipid profiles and is now evident with homocysteine. As a result, a clinician may reassure patients that a homocysteine level of 10 or 11 micromoles per litre is within normal limits, yet this does not equate to optimal cardiovascular health. Patients without cardiovascular disease should strive for levels below 9 micromole, while those with established disease or additional risk factors should aim for levels below 7 micromolar. Proactive management through dietary modifications, targeted supplementation, and appropriate medical intervention is essential in mitigating cardiovascular risk associated with elevated homocysteine. How to effectively lower your homocysteine levels, a physician's perspective. Elevated homocysteine levels have been implicated in cardiovascular disease, neurodegenerative conditions, and other chronic health issues. Addressing this issue requires a two-pronged approach, reducing dietary methionine intake and ensuring optimal levels of key B vitamins to facilitate proper homocysteine metabolism. Dietary considerations. Homocysteine is a byproduct of methionine metabolism. Methionine is an essential amino acid found predominantly in animal-based foods such as meat, dairy, and eggs. While necessary for various physiological functions, excessive intake can contribute to elevated homocysteine levels, placing undue stress on metabolic pathways. To mitigate this, I advise patients to moderate their consumption of high methionine foods, particularly red meat and full-fat dairy products. Instead, incorporating plant-based proteins such as legumes, nuts, seeds, and soy-based products can provide adequate protein while reducing methionine load. A diet rich in fruits and vegetables not only helps balance amino acid intake, but also provides crucial micronutrients that support cardiovascular and neurological health. The role of B vitamins in homocysteine metabolism. Homocysteine is metabolized primarily via two pathways, remethylation and transsulfuration. Both processes require specific B vitamins as cofactors. Folic acid, vitamin B9, essential for the remethylation of homocysteine back into methionine. Folic acid plays a crucial role in keeping homocysteine levels within a healthy range. Vitamin B12, cobalamin, works synergistically with folic acid in homocysteine metabolism. Deficiencies in B12 can lead to the accumulation of homocysteine due to impaired methylation. Vitamin B6, pyridoxine, necessary for the transsulfuration pathway which converts homocysteine into cysteine and ultimately glutathione, a key antioxidant. Several studies have consistently demonstrated that individuals with elevated homocysteine levels tend to have suboptimal levels of these B vitamins. To optimize homocysteine metabolism, I recommend the following supplementation regimen for my patients. Folic acid, 1,000 milligrams, 1 milligrams daily. Vitamin B12, 50 to 150 grams daily. Vitamin B6, 25 to 50 milligrams daily. These dosages have been clinically effective in reducing homocysteine levels by 15 to 75% in most patients. Monitoring and individualized care. Ideally, homocysteine levels should be maintained below 7 mmol. In my practice, when a patient presents with a homocysteine level above 9 mmol, I initiate B vitamin supplementation and schedule a follow-up test within 6 to 8 weeks to assess progress. However, not all individuals respond adequately to B vitamin therapy alone. A subset of patients exhibits persistent hyperhomocysteemia due to impaired methylation capacity. In such cases, additional interventions such as optimizing methyl donors, e.g. betaine, SAMe, or addressing underlying metabolic dysfunctions may be required. Conclusion: lowering homocysteine levels is an essential strategy for cardiovascular and neurological health. Through dietary modifications and targeted supplementation, most patients can achieve optimal homocysteine levels, reducing their risk of associated health complications. As always, individualized assessment and monitoring are key to ensuring effective management. Methylation deficiency, clinical implications and therapeutic considerations. Methylation deficiency is a critical factor not only in the elevation of homocysteine levels, but also in the pathophysiology of several chronic degenerative diseases, including certain malignancies and neurodegenerative disorders such as Alzheimer's dementia. Emerging research continues to underscore the significance of methylation in disease progression, and recent findings have further solidified its role in cognitive decline. A newly developed diagnostic test aimed at identifying individuals at higher risk for Alzheimer's dementia has just been published. The key biomarker? Elevated homocysteine levels. This is a validation of what many functional medicine practitioners have recognized for years. Homocysteine is not merely a marker of vitamin B deficiency, but also a critical indicator of impaired methylation capacity. Methyl donors play a pivotal role in reducing homocysteine levels and supporting essential biochemical pathways, particularly those necessary for cognitive function and neuronal integrity. One of the most cost-effective and clinically effective methyl donors is betaine, also known as trimethylglycine (TMG). In cases where homocysteine remains elevated despite optimized B vitamin supplementation, the addition of 1 to 5 grams of TMG daily can provide significant metabolic support. Given the expanding body of evidence linking methylation efficiency to long-term health outcomes, proactive monitoring and targeted intervention remain essential components of preventive and therapeutic strategies in clinical practice. Dr. Kilmacully. The conclusion. On August 10, 1997, the New York Times Magazine published an article titled The Fall and Rise of Kilmacully, chronicling the trajectory of his career and the broader implications of his research. This account provides a compelling perspective on the challenges faced by medical innovators and the systemic barriers that can impede scientific progress. Reflecting on his career, Macaulay recounted a poignant moment from a reunion at Massachusetts General Hospital. Last October, the pathology department at Massung General had a reunion and invited me, and I saw one of the people involved in my leaving the department. "Well," he said to me, "it looks like you were right after all. It's 20 years later, my career is almost over. There's really not much that can be done about 20 lost years, is there?" This admission underscores the professional and scientific setbacks Macaulay endured. His pioneering work on homocysteine as a risk factor for cardiovascular disease was met with skepticism and institutional resistance, delaying its widespread acceptance. More concerning is the likelihood that the forces that sidelined his research decades ago remain at play today, potentially stifling other critical scientific advancements. A 1997 New England Journal of Medicine article, "The Messenger Under Attack: Intimidation of Researchers by Special Interest Groups," highlighted multiple cases in which advocacy organizations, medical associations, and industry-affiliated consultants targeted researchers whose findings conflicted with prevailing commercial interests. The article warned of the increasing frequency and intensity of such pressures, a concern that remains relevant as financial and political influences continue to shape research funding and dissemination. Macaulay's findings on homocysteine's role in cardiovascular disease and the potential benefits of B vitamin supplementation presented a paradigm shift in our understanding of vascular health. Despite the compelling evidence supporting homocysteine as a significant, if not superior, risk factor compared to cholesterol, the medical community has been slow to integrate routine homocysteine screening into clinical practice. This raises critical questions. Why do many physicians still neglect homocysteine testing in their cardiovascular risk assessments? Why is B vitamin supplementation an inexpensive and safe intervention not more widely recommended? As we advance in precision medicine, the reluctance to acknowledge and act on Macaulay's insights represents a missed opportunity for prevention and early intervention. Physicians have an ethical obligation to remain open to emerging evidence and to prioritize patient outcomes over outdated paradigms. The cost of inaction is clear. Failure to address homocysteine as a major cardiovascular risk factor may have dire consequences for countless patients. What remains unknown or ignored can indeed be life-threatening. The new advances in cardiovascular risk assessment. As the medical understanding of coronary artery disease evolves, it has become increasingly clear that inflammation, rather than solely cholesterol, plays a pivotal role in its pathogenesis. In light of this, recent clinical studies have focused on identifying biomarkers that offer a more precise evaluation of cardiovascular risk. Below are 3 essential tests that provide valuable insights into arterial health and disease prediction. Ultrasensitive C-reactive protein, HSS-CRP. One of the most clinically significant markers of inflammation is high-sensitivity C-reactive protein, HSCRP. This blood test serves as a direct measure of systemic and arterial inflammation, offering superior predictive value for cardiovascular disease. compared to traditional cholesterol measurements. The ability of HSCRP to identify individuals at risk, even those with normal lipid profiles, makes it an indispensable tool in cardiovascular risk stratification. Given its predictive superiority, HSCRP testing should be incorporated into routine cardiovascular assessments, particularly in patients with risk factors or a family history of heart disease. Homocysteine levels. Fasting homocysteine levels have emerged as another crucial marker in cardiovascular risk assessment. Elevated homocysteine has been linked to endothelial dysfunction and increased arterial plaque formation, making it an important parameter to evaluate. While standardization across laboratories remains an area of ongoing improvement, the affordability and accessibility of this test continue to expand. At present, costs range from $45 to $150, but its clinical utility in guiding early interventions makes it a worthwhile consideration for patients at heightened risk. Coronary artery calcium
Scoring.
advancements in imaging have allowed for the widespread use of coronary artery calcium scoring via computed tomography (CT) scans. This non-invasive test quantifies arterial calcification, providing a direct measure of atherosclerotic burden. With costs ranging from $250 to $600, CA scoring is particularly valuable for individuals with significant cardiovascular risk factors or a strong family history of heart disease. The presence and extent of calcifications help physicians tailor treatment strategies, ranging from lifestyle modifications to pharmacologic interventions. Given that sudden cardiac events are often the first clinical manifestation of heart disease, the ability to preemptively assess and mitigate risk is invaluable. Clinical implications and call to action. These advanced diagnostic tools, HSCRP, homocysteine levels and CAS scoring, complement traditional lipid panels and chemistry profiles in providing a more comprehensive assessment of cardiovascular risk. Patients are encouraged to discuss these evaluations with their physicians and verify insurance coverage as part of a proactive approach to cardiovascular health. Prevention remains the cornerstone of cardiology, and early detection enables timely interventions that can significantly reduce morbidity and mortality. A patient-centered approach should always prioritize strategies that minimize the need for invasive cardiac procedures. Integrating these tests into routine practice represents a critical step in the ongoing effort to redefine cardiovascular disease prevention and management. Cardiomyopathy, new hope for a cure. Cardiomyopathy remains one of the most challenging conditions in cardiovascular medicine, often leading to heart failure and the necessity of advanced therapeutic interventions such as heart transplantation. However, evolving research and clinical experience suggest that alternative adjunctive therapies may offer significant benefits to affected patients. Case study, a personal perspective. One midsummer day, a longtime friend and former competitive athlete, Wayne, presented to my office with complaints of profound fatigue, dyspnea, and palpitations. Despite a history of exceptional physical conditioning, he described a persistent decline in his stamina since a severe viral illness 3 months prior. His symptoms were debilitating to the extent that he struggled to maintain his professional responsibilities. Clinical examination revealed signs concerning for significant cardiac dysfunction, including tachyarrhythmia and an auscultatory finding akin to a washing machine murmur. Given the severity of his presentation, he was immediately referred for hospitalization and cardiology evaluation. Diagnostic evaluation and initial management. Hospital investigations included a chest radiograph demonstrating marked cardiomegaly. Subsequent echocardiography revealed a severely reduced ejection fraction of 17%, consistent with a diagnosis of dilated cardiomyopathy. Atrial fibrillation with intracardiac thrombi was also noted, necessitating anticoagulation therapy with warfarin. Further evaluation via cardiac catheterization ruled out ischemic heart disease, but endomyocardial biopsy confirmed a post-viral myocarditis etiology. Despite optimal medical therapy, including anticoagulation, rate control, and standard heart failure management, his prognosis remained guarded. With an ejection fraction persisting below 30%, he was considered for heart transplantation. Integrative approach, coenzyme Q10 supplementation. Given the limitations of conventional treatment, a novel adjunctive approach was considered. Research conducted by Dr. Peter Langshone had demonstrated significant improvement in patients with cardiomyopathy following supplementation with coenzyme Q10, CoQ10, a critical cofactor in mitochondrial energy production and cardiac bioenergetics. After a thorough review of the literature, Wayne was initiated on a regimen of CoQ10 in conjunction with his existing pharmacologic therapy. Over the following months, he reported a remarkable improvement in functional status with a progressive return to daily physical activities, including cycling and light running. Objective improvement and clinical implications. A repeat echocardiogram at 4 months post-supplementation demonstrated a dramatic increase in ejection fraction to 51%, which subsequently improved to 58% on a separate evaluation. This unexpected recovery challenged conventional prognostic expectations, prompting further discussions within the cardiology community regarding the potential role of CoQ10 in the management of cardiomyopathy. Conclusion and future perspectives. While Wayne's cardiomyopathy persists, his clinical improvement underscores the potential role of metabolic therapies in enhancing myocardial function. CoQ10 supplementation appears to provide a viable adjunct to standard heart failure management, warranting further large-scale clinical trials to establish definitive guidelines. This case serves as a compelling reminder that innovative approaches combined with evidence-based medicine may offer new hope for patients facing dire prognoses. Wayne's journey highlights the importance of ongoing research into metabolic therapies and their potential to transform the landscape of cardiomyopathy management. Diseases of the heart, muscle. The heart, while structurally intricate, functions primarily as a highly specialized muscle responsible for maintaining systemic circulation. Its continuous contraction and relaxation cycle ensures the efficient delivery of oxygen and nutrients to tissues throughout the body. While prior chapters have focused on the coronary arteries that supply oxygenated blood to the myocardium, this section will examine the intrinsic diseases that directly affect the heart muscle itself. Two major categories of myocardial disease include congestive heart failure, CHF, and cardiomyopathy. The myocardial function and pathophysiology. The heart's contraction is governed by an intricate electrical conduction system, ensuring synchronized and efficient myocardial contraction. Coordinated opening and closing of the cardiac valves facilitate unidirectional blood flow through its 4 chambers. Given the heart's relentless workload, it possesses exceptionally high metabolic and oxygen demands. Any disruption in its functional integrity can precipitate significant hemodynamic compromise. Congestive heart failure and cardiomyopathy arise from various etiologies, including chronic hypertension, ischemic insults such as repeated myocardial infarctions, viral myocarditis, and infiltrative diseases, e.g. systemic lupus erythematosus, scleroderma, or amyloidosis. Regardless of the underlying cause, these conditions compromise myocardial contractility, leading to an inadequate ejection of blood from the ventricles. In response, the heart undergoes compensatory adaptations, ventricular dilation, and increased heart rate to maintain cardiac output. However, these mechanisms ultimately fail, leading to fluid retention and congestion. Clinical manifestations. In congestive heart failure, the progressive decline in myocardial efficiency results in pulmonary congestion due to left ventricular dysfunction. Fluid accumulation in the alveolar spaces leads to dyspnea, orthopnea, and, in severe cases, acute pulmonary edema. Conversely, when failure predominantly affects the right ventricle, venous congestion ensues, leading to hepatic engorgement, peripheral edema, and ascites. When myocardial dysfunction progresses to a severe and dilated state, as seen in cases like Wayne's, the condition is classified as cardiomyopathy, a more advanced and debilitating form of heart failure. A hallmark feature of cardiomyopathy is significant ventricular dilatation with impaired systolic function, often resulting in a markedly enlarged cardiac silhouette on imaging. Early recognition and appropriate management of these conditions are critical to optimizing patient outcomes, mitigating complications, and improving quality of life. Coenzyme Q10, an essential mitochondrial cofactor. Coenzyme Q10, CoQ10, also known as ubiquinone, is a fat-soluble vitamin-like compound that plays a pivotal role in cellular bioenergetics and serves as a potent antioxidant. While trace amounts of CoQ10 are present in dietary sources such as organ meats, beef, soy oil, sardines, mackerel, and peanuts, endogenous synthesis remains the primary source for maintaining adequate levels. However, this biosynthetic process is highly complex, requiring the involvement of at least 8 vitamins and several trace minerals. A deficiency in any of these essential cofactors can compromise CoQ10 synthesis, potentially leading to suboptimal mitochondrial function. CoQ10 functions as a critical coenzyme for mitochondrial enzymes involved in oxidative phosphorylation, particularly within the electron transport chain. As the powerhouse of the cell, mitochondria are responsible for generating adenosine triphosphate, ATP, the fundamental energy currency required for virtually all physiological processes. Specifically, CoQ10 facilitates electron transfer between complex 1 NADH dehydrogenase and complex 3 cytochrome BC1 complex, as well as between complex 2 succinate dehydrogenase and complex 3. This process is essential for ATP synthesis, ensuring cellular energy demands are met efficiently. Beyond its role in ATP production, CoQ10 exerts significant antioxidant properties, mitigating oxidative stress by neutralizing reactive oxygen species, ROS, generated during mitochondrial respiration. This function is particularly critical in high-energy demand tissues such as the myocardium, skeletal muscle, and brain, where oxidative damage can contribute to pathophysiological processes, including neurodegenerative disorders, cardiovascular diseases, and metabolic dysfunction. Historically, CoQ10 was first isolated from bovine cardiac mitochondria by Dr. Frederick Crane in 1957. The following year, Dr. Carl Folkers and his team at Merck elucidated its precise chemical structure and successfully synthesized the compound. By the mid-1970s, Japanese researchers had refined the production process, enabling large-scale synthesis of pure CoQ10, which is now widely available for both clinical and supplemental use. Given its integral role in cellular energy metabolism and redox balance, CoQ10 continues to be a subject of extensive research, particularly in the context of cardiovascular health, neuroprotection, and age-related mitochondrial dysfunction. CoQ10 deficiency and heart failure. Numerous investigations have established reference ranges for normal blood levels of coenzyme Q10, CoQ10, and compelling evidence suggests a direct correlation between CoQ10 depletion and the severity of heart failure. Markedly reduced CoQ10 levels have been documented in various pathological conditions, including periodontal disease, cancer, cardiovascular disease, and diabetes. However, the most well-defined deficiency has been observed in patients with congestive heart failure and cardiomyopathy. CoQ10 deficiency can arise from multiple factors, including inadequate dietary intake, impaired endogenous biosynthesis, and excessive physiological utilization. Given CoQ10's critical role in mitochondrial bioenergetics and antioxidant defense, its depletion may contribute to progressive myocardial dysfunction. Since the early 1980s, clinical trials have explored the therapeutic benefits of CoQ10 supplementation in patients with heart failure. Over the past 2 decades, interest in CoQ10 has grown significantly, leading to multiple controlled studies evaluating its efficacy in cardiomyopathy and CHF. To date, at least 9 placebo-controlled trials have been conducted globally, and 8 international symposia have reviewed its biomedical and clinical applications, with researchers from 18 countries presenting more than 300 scientific papers on the topic. Among these, the largest and most influential study remains the Italian multi-center trial conducted by Baggio et al., involving 2,664 patients with heart failure. This trial demonstrated that nearly 80% of participants experienced clinical improvement following CoQ10 supplementation, with 54% showing significant enhancement across 3 primary symptom domains. These findings reinforce the role of CoQ10 as a valuable adjunctive therapy in heart failure management. While CoQ10 is not a definitive cure, accumulating clinical data supports its potential to attenuate disease progression and improve quality of life in affected patients. Treating patients with cardiomyopathy, a clinical perspective. Cardiomyopathy remains a significant clinical challenge, with heart transplantation often being the definitive treatment for end-stage disease. However, the demand for donor hearts far exceeds availability. More than 20,000 patients under the age of 65 remain on the transplant waiting list, while thousands over 65 are ineligible due to age-related restrictions. Despite optimal medical management, many of these patients continue to experience debilitating symptoms, with the majority ultimately succumbing to their disease. Only 1 in 10 eligible patients successfully undergoes transplantation, leaving the remainder with limited therapeutic options. Furthermore, the burden of congestive heart failure affects hundreds of thousands more individuals, amplifying the need for adjunctive therapies. The role of coenzyme Q10 in cardiomyopathy management. In 1992, Drs. Fokers and Langsion published a pivotal study demonstrating the therapeutic potential of coenzyme Q10, CoQ10, in patients with severe heart failure. This study included 11 heart transplant candidates who were administered CoQ10 supplementation. The results were compelling. 3 patients improved from New York Heart Association NYHA Class 4 to Class 1. 4 patients transitioned from Class 3-4 to Class 2. 2 patients advanced from Class 3 to Class New York Heart Association Functional Classification. Class No limitations, ordinary activity does not provoke symptoms. Class 2, mild limitation, comfortable at rest, but symptoms occur with ordinary physical activity. Class 3, marked limitation, comfortable at rest, but minimal exertion leads to symptoms. Class 4, severe limitation, symptoms present at rest and worsen with any activity. These findings, reinforced by extensive clinical literature, highlight CoQ10 as a safe and effective adjunct in the management of end-stage heart failure. This essential nutrient plays a critical role in mitochondrial energy production, and its depletion is observed in advanced heart failure states. By supplementing CoQ10, myocardial bioenergetics can be restored, improving cardiac function and symptomatology. Integrating CoQ10 into standard heart failure therapy. It is crucial to emphasize that CoQ10 supplementation should complement rather than replace conventional heart failure therapies. This approach aligns with the principles of integrative medicine, enhancing standard pharmacologic treatment rather than serving as an alternative modality. While some patients in the study experienced significant clinical improvement to the extent that they could reduce their pharmacologic burden, it is imperative to recognize that CoQ10 does not reverse the underlying pathophysiology of cardiomyopathy. Long-term adherence to CoQ10 supplementation is essential for sustaining its therapeutic benefits. Clinical studies indicate that discontinuation leads to gradual depletion of myocardial CoQ10 levels, resulting in a decline in cardiac function. Conversely, a 6-year longitudinal study by Dr. Langsion demonstrated that patients maintaining CoQ10 therapy sustained their functional gains over time. Conclusion. The incorporation of CoQ10 into the management of cardiomyopathy represents a compelling example of evidence-based nutritional intervention. As clinicians, it is our responsibility to integrate adjunctive therapies with established medical protocols to optimize patient outcomes. Given the profound impact of CoQ10 on cardiac function and patient quality of life, its role in heart failure management warrants further exploration and broader clinical implementation. Why don't physicians recommend CoQ10? Coenzyme Q10, CoQ10, has been extensively studied for its potential benefits in patients with cardiomyopathy and congestive heart failure. Research suggests that it may significantly improve cardiac function, with many patients experiencing marked improvement within 4 months of supplementation. Despite its affordability, approximately $1 per day, CoQ10 remains largely overlooked by the medical community, even though it presents a cost-effective alternative to expensive interventions such as heart transplantation, which can exceed $250,000. The reluctance of physicians to recommend CoQ10 be attributed to several key factors: lack of awareness and education. Physicians are extensively trained in pharmacological therapies, often with little emphasis on nutritional or supplemental interventions. Medical education primarily focuses on evidence-based pharmaceutical treatments, leaving many healthcare providers unaware of the potential benefits of CoQ10. Discussions regarding its use in clinical settings are rare, even at professional conferences or among cardiology peers. Absence of strong pharmaceutical backing. Unlike synthetic drugs, CoQ10 is a naturally occurring compound and cannot be patented. As a result, pharmaceutical companies have little financial incentive to invest in large-scale clinical trials or to fund the costly FDA approval process, which can exceed $350 million. Consequently, CoQ10 does not receive the aggressive marketing and promotional efforts that prescription medications enjoy. Physicians, who rely heavily on pharmaceutical representatives for information on new treatments, are seldom presented with data supporting CoQ10's efficacy. Economic and regulatory barriers. The National Institutes of Health, NIH, has funded several studies on CoQ10, but without substantial financial incentives from pharmaceutical companies, its widespread adoption remains unlikely. The cost of promoting a medication to physicians is substantial, and without commercial backing, CoQ10 is unlikely to gain traction within mainstream medical practice. The influence of pharmaceutical marketing. The pharmaceutical industry plays a significant role in shaping physician prescribing habits. Daily interactions with pharmaceutical sales representatives ensure that clinicians are continually updated on the latest drug therapies, yet natural supplements like CoQ10 are rarely, if ever, included in these discussions. This lack of exposure further contributes to its underutilization. The hesitancy to integrate CoQ10 into standard cardiology practice is not due to a lack of efficacy, but rather systemic barriers within the medical and pharmaceutical industries. Given the compelling evidence supporting its role in cardiac health, increased awareness and education are essential to ensuring that patients receive the most comprehensive and effective treatment options available. Emma's story. A case study in integrative cardiology. Emma, a remarkable woman in her early 80s, first came to me after being diagnosed with cardiomyopathy approximately 4 years ago. At the time of her diagnosis, her ejection fraction measured a concerning 20%, significantly compromising her daily life. Her cardiologist prescribed multiple medications, including amiodarone, marketed as Cordarone, to manage her arrhythmia. Unfortunately, Emma experienced severe adverse effects, including profound gastrointestinal distress, substantial weight loss, and ultimately complete thyroid failure. Although thyroid hormone replacement was initiated, she remained critically ill. Due to her advanced age, she was deemed ineligible for heart transplantation, leaving her with limited conventional treatment options. Emma's condition deteriorated under traditional management, and with no viable alternatives, she sought my care after hearing about my approach to complex cardiovascular cases. Upon thorough evaluation, it became evident that her symptoms were largely driven by an adverse reaction to amiodarone. Emma expressed a strong desire to discontinue the medication, a decision I supported after carefully assessing the risk-benefit profile. Based on her clinical presentation, I was concerned that continued use of amiodarone could have significantly shortened her life expectancy, perhaps to just a few months. After carefully tapering Emma off amiodarone, I introduced a regimen centered on 300 milligrams of coenzyme Q10, CoQ10, daily. CoQ10 plays a pivotal role in mitochondrial function and has demonstrated efficacy in supporting cardiac performance in patients with heart failure and cardiomyopathy. The results were remarkable. Within weeks, Emma's appetite and strength improved, and her dyspnea markedly subsided. As her functional capacity returned, her quality of life dramatically improved. 4 months into this integrative approach, a follow-up echocardiogram revealed a significant improvement in her ejection fraction, which had risen to 42%. Today, Emma remains active and independent, with her primary medical concern shifting from heart failure to arthritis management. She has even undergone successful total knee replacement surgery, a remarkable outcome for someone once considered to have a terminal prognosis. The role of integrative and complementary medicine in cardiomyopathy. Physicians have a duty to act as advocates for their patients, continually expanding their knowledge of both conventional and complementary treatment modalities. The key principle in integrative medicine is to support the body's natural physiological functions, enhancing its capacity to heal and maintain homeostasis. For patients with cardiomyopathy, conventional pharmacotherapy remains essential. However, the strategic incorporation of targeted nutritional support, particularly high-dose CoQ10 300 to 500 milligrams daily, in conjunction with a well-balanced antioxidant and mineral regimen, can profoundly enhance cardiac function and overall well-being. By embracing a more comprehensive approach to patient care, we empower individuals like Emma to achieve not only longevity, but also an improved quality of life. Chemoprevention and cancer, a physician's perspective. Delivering a cancer diagnosis remains one of the most challenging responsibilities of my profession. Despite advancements in medical science, oncologists and primary care physicians across the country continue to deliver this devastating news far too frequently. This year alone, more than 1.3 million new cancer cases will be diagnosed in the United States, with approximately 550,000 individuals succumbing to the disease before the year's end. In light of the $25 billion invested in cancer research over the past 2 decades, it is deeply concerning that cancer mortality rates have not declined as expected. This alarming trend underscores the urgent need to reevaluate our approach to cancer prevention and treatment. Advances in cancer research progress and limitations. While significant progress has been made in early detection, such as mammography for breast cancer and PSA screening for prostate cancer, these advancements primarily focus on identifying cancer at earlier stages rather than preventing its onset. The question arises, is early detection the best we can achieve? The answer is a resounding no. Emerging research suggests that cancer prevention, particularly through chemoprevention, holds immense potential in reducing cancer incidence and mortality. In this chapter, we will explore recent breakthroughs in cancer research and how individuals may proactively lower their cancer risk. Understanding cancer and its causes. The modern era has heightened awareness of potential carcinogens in our environment. Prolonged exposure to ultraviolet radiation increases the likelihood of skin cancer, while occupational hazards, such as asbestos exposure, significantly elevate the risk of mesothelioma. Tobacco use and secondhand smoke remain the leading culprits behind lung cancer mortality. Additionally, dietary factors, including high-fat consumption, charred meats, artificial sweeteners, and exposure to pesticides, have all been implicated as potential contributors to carcinogenesis. Historical observations have provided critical insights into cancer etiology. The seminal discovery that chimney sweeps exhibited a higher incidence of scrotal cancer due to chronic exposure to soot was among the first epidemiological links between environmental carcinogens and malignancy. In today's industrialized world, humans encounter a broader spectrum of chemical exposures than any previous generation. A fundamental unifying mechanism among these carcinogens is their ability to induce oxidative stress, a key driver of cellular damage and malignant transformation. Understanding oxidative stress and its role in cancer pathogenesis is essential for developing effective preventive strategies. The future of cancer prevention, chemoprevention strategies. The concept of chemoprevention, the use of natural or synthetic agents to inhibit, delay, or reverse carcinogenesis, has gained significant traction in recent years. Scientific evidence suggests that certain pharmacologic agents, dietary compounds, and lifestyle modifications may reduce cancer risk by mitigating oxidative stress and inflammation. In the subsequent sections, we will examine the latest research on chemopreventive agents, their mechanisms of action, and practical recommendations for incorporating these strategies into clinical practice. By shifting our focus from solely detecting cancer to actively preventing its development, we have the opportunity to change the trajectory of this disease. Through continued research and public health initiatives, we can move toward a future where cancer diagnoses become increasingly rare and patients receive proactive, evidence-based strategies to safeguard their health. Oxidative stress as a fundamental driver of carcinogenesis. The etiology of cancer has long been a subject of extensive research and debate, with numerous theories proposed to explain its development. However, no single hypothesis has successfully unified the diverse aspects of cancer pathogenesis within the human body. In an effort to address this complexity, Dr. Peter Kovacic published a seminal review in Current Medicinal Chemistry 2001, wherein he posited, of the numerous theories that have been advanced, oxidative stress is the most comprehensive, and it has stood the test of time. It can rationalize and correlate most aspects associated with carcinogenesis. This assertion aligns with a growing body of evidence implicating oxidative stress as a central mechanism in oncogenesis. Oxidative stress arises from an imbalance between reactive oxygen species, ROS, and the body's ability to neutralize them through antioxidant defenses. When excessive ROS accumulate in proximity to the cell nucleus, they inflict substantial oxidative damage upon nuclear DNA. This vulnerability is particularly pronounced during cellular division as the DNA double helix undergoes unwinding and replication, rendering it more susceptible to strand breaks and mutagenic alterations. Advances in molecular biology have not only confirmed the capacity of free radicals to damage nuclear DNA, but have also elucidated specific genomic regions most frequently affected. Under normal physiological conditions, the body employs robust DNA repair mechanisms to counteract such insults. However, when oxidative stress surpasses the reparative capacity of these systems, cumulative DNA damage can result in genomic instability and mutagenesis. This disruption facilitates aberrant cellular proliferation, a hallmark of malignant transformation. Moreover, oxidative stress can induce additional genetic modifications that further drive tumor progression, including enhanced survival signaling, evasion of apoptosis, and increased metastatic potential. Once a cancerous cell emerges, continued oxidative stress can exacerbate genomic instability, promoting aggressive tumor behavior and metastasis. This cascade of events underscores the critical role of oxidative stress in cancer initiation, progression, and therapeutic resistance. Consequently, targeted interventions aimed at mitigating oxidative damage, whether through dietary antioxidants, pharmacologic agents, or lifestyle modifications, represent a compelling avenue for cancer prevention and adjunctive treatment strategies. A multi-stage process. Dr. Donald Malins, a distinguished biochemist from Seattle, pioneered an innovative technique for identifying structural alterations in DNA within breast tissue. Utilizing infrared spectroscopy in conjunction with advanced computational analysis, Dr. Malins was able to trace the progressive structural damage inflicted on DNA by free radicals. The prevailing consensus among researchers aligns with Dr. Malins' assertion that cancer development is a multi-stage process, typically unfolding over several decades. In adults, the progression from an initial DNA mutation to clinically manifest malignancy may span 20 to 30 years. However, in pediatric populations, this process often accelerates due to higher rates of cellular turnover. Through his investigations, Dr. Malins identified distinct and progressive structural modifications in DNA as breast tissue transitioned from a normal state to metastatic cancer. He attributed these alterations primarily to oxidative stress, which he proposed as the fundamental driver of DNA damage and subsequent oncogenesis. Contrary to the widely held view that cancer is primarily a consequence of inherited genetic defects, Dr. Malins posited that it is, in large part, the result of accumulated genetic damage induced by highly reactive free radicals. For the past quarter century, the predominant oncological paradigm has centered on the role of aberrant genes as the primary instigators of malignancy. However, emerging research suggests a paradigm shift. Rather than being directly caused by defective genes, cancer susceptibility may instead be linked to an individual's genetic predisposition to oxidative stress. This hypothesis provides a compelling explanation for the observed familial clustering of many cancer types, emphasizing the role of environmental and metabolic influences in modulating genetic vulnerability. A decade late and $1 short. The unfortunate reality of cancer diagnosis is that it often comes far too late. By the time malignancies become symptomatic or radiographically detectable, they have frequently been evolving for a decade or more. In response, we deploy our most aggressive interventions, surgical resection, cytotoxic chemotherapy, and radiation, only to realize that, more often than not, these measures yield minimal benefit in terms of long-term survival. I recall a patient of mine who was recently diagnosed with lung cancer. His oncologist recommended chemotherapy, citing a 40% chance of inducing remission. The patient, initially encouraged by this figure, asked for clarification on what remission actually entailed. The response was sobering. If successful, remission may extend life by approximately 3 months. The optimism he had briefly held vanished, replaced by the harsh reality that, despite medical intervention, his prognosis remained grim. My own mother's experience with cancer underscores this tragic dilemma. Diagnosed with a high-grade glioma, she was offered radiation therapy with an estimated 1% chance of prolonging survival. Against my better judgment, she chose to proceed with treatment. Over the following 6 months, she endured not only the relentless progression of her disease, but also the debilitating effects of therapy, which left her weak, nauseated, and profoundly fatigued. In many cases, the modest extension of life afforded by aggressive treatment comes at a cost that is both physically and emotionally devastating. The sobering truth is that we are losing the war on cancer, not for lack of effort, but because we continue to fight it at the wrong stage. The paradigm must shift toward early intervention and, more importantly, prevention. The emerging understanding of oxidative stress and its role in carcinogenesis offers a promising frontier. By focusing on mitigating these biochemical processes before malignancy takes hold, we may finally move from reactive treatment to proactive disease prevention. The hope for real progress lies not in catching cancer late, but in preventing it from ever taking root. Prevention of cancer, chemoprevention. As our understanding of the underlying mechanisms of cancer continues to evolve, so too do our therapeutic and preventive strategies. Cancer is a complex, multi-stage process that unfolds over years, presenting multiple opportunities for early intervention and prevention. At the initial stages of carcinogenesis, DNA damage occurs due to oxidative stress and free radical attacks. These genetic mutations, once embedded within the DNA, propagate through subsequent cellular replication cycles. Over time, cumulative damage results in the formation of precancerous lesions. This stage represents a clinically significant window for intervention before malignant transformation occurs, at which point cancer gains the ability to metastasize. Unlike conventional cancer treatments aimed at eradicating established malignancies, chemoprevention seeks to intercept the disease at its earliest stages. This approach hinges on maintaining cellular homeostasis through a robust antioxidant defense system. Oxidative stress is a key driver of DNA damage, but a well-balanced presence of antioxidants can mitigate its effects. Conceptually, this can be likened to the role of a fireplace screen in preventing stray embers from igniting a fire. Additionally, chemoprevention aims not only to prevent carcinogenesis, but also to facilitate the reversal of pre-existing cellular damage. The body's innate repair mechanisms are remarkably effective when provided with optimal nutritional support and a conducive biochemical environment. A strategic approach to chemoprevention consists of 3 critical phases, each playing a pivotal role in reducing cancer risk and supporting cellular integrity. Chemoprevention Phase 1: Risk Reduction. The primary objective in cancer prevention is the elimination or minimization of exposure to known carcinogens. While straightforward in principle, this step requires proactive effort and adherence to well-established preventive measures. Smoking cessation. Tobacco smoke remains one of the most potent carcinogens, significantly increasing oxidative stress and free radical burden. Both primary and secondary smoke exposure contribute to heightened cancer risk, underscoring the necessity of complete cessation. Ultraviolet protection. Chronic exposure to UVA and UVB radiation is a well-documented cause of skin malignancies. Broad-spectrum sunscreen use and protective clothing are essential preventive measures. Dietary modifications. Excessive dietary fat intake, particularly in the absence of sufficient antioxidants, exacerbates oxidative stress. A high-fiber, plant-based diet comprising at least 7 servings of fruits and vegetables daily, along with 35 grams of dietary fiber, has been shown to substantially reduce cancer risk.
Environmental awareness.
Reducing exposure to environmental carcinogens such as radiation, pesticides, asbestos, and industrial pollutants is a crucial preventive strategy. By systematically addressing these risk factors, the generation of free radicals is minimized, thereby decreasing the oncogenic burden on the body. Chemoprevention Phase 2. Enhancing antioxidant and immune defenses. Given the inescapable presence of environmental toxins and oxidative stressors, the most effective strategy is to bolster endogenous antioxidant defenses and immune function. Numerous epidemiological studies underscore the protective effects of a nutrient-rich diet. Research by Dr. Gladys Block, analyzing 172 global studies on diet and cancer, revealed a consistent inverse correlation between fruit and vegetable intake and cancer risk. Individuals consuming the highest quantities of these foods exhibited a 2- to 3-fold reduction in cancer incidence compared to those with the lowest intake. Similarly, studies led by Dr. Bruce Ames corroborated these findings, indicating that diets deficient in antioxidants substantially elevate cancer susceptibility. Beyond dietary sources, targeted antioxidant supplementation has demonstrated efficacy in mitigating oxidative DNA damage. Clinical studies have revealed that supplementation with vitamin C, vitamin E, and beta-carotene significantly reduces oxidative stress markers in both smokers and non-smokers. Furthermore, vitamin E has been shown to protect against exercise-induced DNA damage, highlighting its role in cellular resilience. Chemoprevention Phase 3. Optimizing cellular repair mechanisms. In addition to preventive strategies, enhancing the body's inherent ability to repair DNA damage is fundamental to cancer mitigation. Studies examining precancerous lesions such as leukoplakia, a tobacco-related oral lesion, and cervical dysplasia provide compelling evidence supporting the role of antioxidants in cellular repair and disease reversal. Dr. Harinder Garawal's research on the impact of antioxidants on oral and cervical precancerous lesions presents significant findings. Vitamin A and beta-carotene, India study, complete remission of leukoplakia occurred at a rate 10 times higher in the intervention group compared to placebo. Beta-carotene supplementation pilot study, a 71% reversal rate of leukoplakia to normal cells was observed. Combination therapy US study. Patients receiving beta-carotene, vitamin C, and vitamin E exhibited a 60% regression rate of precancerous cells to normal tissue. Beta-carotene monotherapy, multi-institutional US trial, achieved a 56% response rate in leukoplakia regression. Antioxidant synergy animal model, a combination of beta-carotene, vitamin E, glutathione, and vitamin C demonstrated superior efficacy compared to individual antioxidants alone, suggesting a synergistic effect. Similarly, epidemiological data indicate a strong association between low levels of beta-carotene, vitamin C, and vitamin E and an increased risk of cervical dysplasia. Women with the lowest beta-carotene levels exhibited a 2- to 3-fold increased risk, while those with inadequate vitamin C intake faced a 10-fold greater risk of cervical dysplasia progression. Importantly, beta-carotene supplementation has been shown not only to prevent the progression of cervical dysplasia to invasive cancer, but also to induce partial regression of precancerous lesions. Conclusions and clinical implications. Despite ongoing efforts to identify a singular magic bullet for cancer prevention, clinical evidence suggests that a multifaceted approach involving a spectrum of antioxidants, essential minerals, selenium, zinc, copper, manganese, and B-complex vitamins yields the most favorable outcomes. These nutrients work in concert to enhance cellular protection, immune surveillance, and DNA repair capacity. The body's intrinsic ability to counteract oxidative stress and repair genetic damage is a testament to its remarkable resilience. While ongoing clinical trials will continue to refine our understanding of chemoprevention, existing data strongly support the proactive use of dietary and supplemental antioxidants to reduce cancer risk. Given the compelling evidence demonstrating the efficacy of nutritional interventions reversing precancerous lesions, it is imperative that clinicians incorporate these principles into comprehensive cancer prevention strategies. What if I already have cancer? While chemoprevention strategies exist for individuals who have not yet developed cancer, the reality for those already diagnosed is far more complex. Standard oncologic treatment, including surgery when feasible, chemotherapy and radiation, remains the foundation for managing solid tumours such as those found in the lung, breast and colon. However, despite continuous advancements in medical research, these modalities have reached a therapeutic plateau in many cases. Moreover, while there have been significant improvements in cure rates for conditions such as Hodgkin's lymphoma, childhood leukemia and testicular cancer, concerns persist regarding long-term complications. Chief among these concerns is the heightened risk of secondary malignancies and other treatment-related toxicities that emerge as a consequence of aggressive therapeutic interventions. Encouragingly, emerging research supports the potential role of adjunctive supplementation with antioxidants and other supportive nutrients. When used judiciously, these compounds may enhance the efficacy of conventional chemotherapy and radiation while simultaneously mitigating collateral damage to healthy cells. This evolving approach underscores the importance of an integrative treatment strategy, aiming not only for improved oncologic outcomes, but also for enhanced overall patient resilience and quality of life. Kimberly's story, a case study in young-onset ovarian cancer. Kimberly, a 21-year-old female in her final year at Westmont College in Santa Barbara, California, presented with progressive abdominal discomfort and urinary symptoms. Initially evaluated by a campus physician, she was diagnosed with a urinary tract infection and prescribed a course of antibiotics. However, her symptoms persisted and worsened, including escalating abdominal pain, nausea, and vomiting. Upon self-palpation, Kimberly noted a distinct abdominal mass, prompting her to seek further medical evaluation. On re-examination, her physician detected a palpable mass, approximately the size of a grapefruit, in the lower abdomen. Given the concerning findings, a serum CA-125 test was ordered, revealing markedly elevated levels consistent with a potential gynecological malignancy. Immediate surgical intervention was planned. Histopathological analysis confirmed the diagnosis of ovarian cancer, an uncommon malignancy in young women. The diagnosis was unexpected and profoundly impacted both Kimberly and her family. Her surgical team was optimistic about achieving complete resection, yet given her age and the aggressive nature of the disease, adjuvant chemotherapy was strongly recommended by her oncologist to minimize the risk of recurrence. During this period, Kimberly sought additional guidance regarding nutritional supplementation to optimize her overall health and resilience during chemotherapy. A structured nutritional support regimen was implemented in conjunction with her standard oncological treatment. Remarkably, despite undergoing intensive chemotherapy, Kimberly exhibited an exceptional tolerance to treatment. She maintained full academic enrollment, a testament to her resilience and the potential adjunctive benefits of her comprehensive care approach. Both her oncologist and surgeon noted her remarkable physical condition and absence of significant adverse effects typically associated with chemotherapy. Alopecia was observed, however, she experienced minimal gastrointestinal distress, which was notably distinct from the experiences of her fellow patients. Her oncologist, recognizing the atypical nature of her treatment response, inquired directly about her supplemental regimen. Now more than 3 years post-treatment, Kimberly remains in remission. Her CA-125 levels have remained within normal limits, and her monitoring has been reduced to biannual assessments. She has experienced no signs of recurrence, and her overall health and quality of life remain excellent. Kimberly's case underscores the importance of a multidisciplinary approach to oncologic care, incorporating surgical intervention, systemic therapy, and supportive nutritional strategies. While more research is necessary to define the precise role of an adjunctive nutritional support in cancer treatment, her experience highlights the potential benefits of a holistic, patient-centered approach to oncology.
Why they work?
The role of antioxidants in cancer therapy. Oncologists and radiation oncologists frequently advise against the use of antioxidant supplementation in patients undergoing cancer treatment. The prevailing concern is that antioxidants may fortify the antioxidant defense mechanisms within cancer cells, thereby diminishing the efficacy of treatments designed to induce oxidative stress and selectively destroy malignant cells. While this hypothesis is reasonable, a critical evaluation of the medical literature does not substantiate this position. The scientific evidence. A comprehensive review conducted by Dr. Kedar Prasad, Arun Kumar, and their colleagues at the University of Colorado Medical School's Department of Radiology analyzed over 70 studies to assess this concern. Their findings, published in the Journal of the American College of Nutrition under the title High Doses of Multiple Antioxidant Vitamins, Essential Ingredients in Improving the Efficacy of Standard Cancer Therapy, highlight an important distinction. While some isolated studies indicate that certain single antioxidants may interfere with specific chemotherapeutic agents, the overwhelming body of evidence suggests that high doses of multiple antioxidants, when used in combination, enhance the effectiveness of cancer treatments rather than impede them. Antioxidants and cancer cell vulnerability. Emerging research demonstrates that cancer cells absorb antioxidants differently than normal cells. Unlike healthy cells, which regulate antioxidant uptake to maintain physiological balance, cancer cells lack this regulatory control and continue to accumulate antioxidants in an unregulated manner. This paradoxically increases their susceptibility to oxidative damage and programmed cell death, apoptosis, particularly in the presence of cytotoxic therapies. Furthermore, antioxidants support the integrity and function of normal cells, mitigating the collateral damage induced by chemotherapy and radiation. These treatments generate significant oxidative stress, which is the primary cause of their adverse effects on healthy tissues. When administered in high doses, antioxidants bolster the defense mechanisms of normal cells, allowing them to withstand treatment-related toxicity while simultaneously facilitating tumor cell destruction. Clinical implications. The protective role of antioxidants in normal tissue is well documented. Vitamin E mitigates damage to the lungs, liver, kidneys, hearts, and skin caused by various chemotherapeutic agents. Coenzyme Q10, CoQ10, has demonstrated protective effects against cardiotoxicity induced by anthracycline-based chemotherapy, e.g. adriamycin. Beta-carotene and vitamin A have been shown to reduce adverse effects associated with radiation therapy and specific chemotherapeutic drugs. Additionally, these antioxidants contribute to preserving DNA integrity in normal cells, counteracting the mutagenic effects of conventional cancer therapies. Conclusion: the integration of high-dose multi-antioxidant supplementation in cancer treatment protocols presents a compelling opportunity to enhance therapeutic efficacy while reducing treatment-associated morbidity. Current evidence suggests that rather than shielding cancer cells, antioxidants render them more vulnerable to cytotoxic therapies while concurrently fortifying normal cells against oxidative injury. These findings warrant a reassessment of conventional recommendations regarding antioxidant use in oncology, with a more nuanced approach that accounts for the differential effects on cancerous versus healthy tissues. Michelle's story, a case of neuroblastoma and integrative oncology. Michelle was a vibrant and energetic 4-year-old, living a life filled with laughter and love. However, her carefree existence was abruptly interrupted when she began experiencing persistent abdominal and back discomfort. A comprehensive medical evaluation led to a devastating diagnosis: neuroblastoma, an aggressive pediatric cancer originating in the adrenal glands. Initial diagnosis and treatment challenges. Following her diagnosis, Michelle underwent an exploratory laparotomy. The findings were grave. The tumor had extensively infiltrated the retroperitoneal space, encasing vital structures including the bowel, major abdominal vessels, and extending up to the diaphragm. The surgical team determined that complete resection was unfeasible at that stage. Given the advanced nature of her disease, Michelle's oncology team initiated an aggressive chemotherapeutic regimen. However, the prognosis remained guarded due to the tumor's extensive involvement and the systemic burden of the disease. It was at this critical juncture that Michelle's mother sought my consultation, seeking strategies to mitigate treatment-related toxicities and optimize her daughter's resilience during therapy. Adjunctive nutritional support in oncology. Despite initial resistance from her oncology team, we implemented a structured integrative approach, incorporating targeted nutritional supplementation to bolster Michelle's immune function, support cellular repair mechanisms, and reduce oxidative stress. Michelle's adherence to this regimen was commendable. As anticipated, she encountered significant adverse effects from the chemotherapy. However, despite the intensity of the treatment, she demonstrated remarkable tolerance and stability, exceeding expectations in her ability to withstand the cytotoxic effects of her regimen. Encouraged by her positive response, her oncologists reconsidered surgical intervention. A second-look surgery was performed, and this time the outcome was favorable. The surgical team successfully resected the residual tumor. Post-operative assessments indicated a significant reduction in disease burden with no gross residual malignancy. Bone marrow transplant and multimodal support. Following surgical success, Michelle's care team recommended high-dose chemotherapy with autologous bone marrow transplantation to eradicate any microscopic residual disease. This posed a pivotal decision for her family. While they recognized the necessity of the procedure, they insisted on continuing nutritional supplementation throughout the transplant process. Initially, the oncology team hesitated, citing theoretical concerns regarding potential interactions between the supplements and chemotherapy. However, Michelle's father, an emergency medicine physician, challenged this stance, requesting empirical evidence substantiating the objections. Upon thorough review by the oncology pharmacologist, no contraindications were identified and the supplements were permitted. Michelle endured the rigors of bone marrow transplantation, yet her recovery was unexpectedly swift. Her oncologist remarked that she had never observed such a rapid post-transplant recuperation in a pediatric patient, highlighting the potential role of supportive nutritional strategies in enhancing treatment outcomes. Long-term outcomes and reflections. Michelle's resilience was evident when she reached a milestone she and her family had fervently prayed for, starting kindergarten on time with her peers. Now, at 7 years old, she thrives, engaging in the joys of childhood from biking to playing with friends, a testament to the efficacy of an integrative treatment approach. The role of nutritional science in oncology. The integration of evidence-based nutritional strategies alongside conventional cancer treatments represents a paradigm shift in oncologic care. Scientific literature supports the adjunctive use of natural antioxidants and micronutrients in the following capacities: reducing oxidative stress induced by chemotherapy and radiation therapy, enhancing DNA repair mechanisms to mitigate treatment-related cellular damage, inhibiting cancer cell proliferation and supporting apoptosis in malignant cells, augmenting immune function, critical in post-chemotherapy recovery, improving overall treatment tolerance, thereby optimizing therapeutic outcomes. Despite advancements in oncology, conventional cancer therapies have reached a therapeutic plateau. It is imperative that oncologists, radiation therapists, and allied health professionals adopt a more integrative perspective, leveraging the benefits of adjunctive nutritional interventions. As ongoing research continues to validate the role of targeted supplementation in cancer care, future treatment protocols may evolve to incorporate these strategies as standard practice. Michelle's story underscores a compelling narrative. When conventional oncology and integrative medicine converge, patient outcomes can be significantly enhanced. Her case serves as an exemplar of how a holistic approach to cancer treatment may offer renewed hope in the fight against pediatric malignancies. Oxidative stress and ocular health, understanding the role of antioxidants in preserving vision. Oxidative stress is a well-established factor in the pathogenesis of numerous ocular diseases, including age-related macular degeneration, AMD. The human eye, particular macula, is highly susceptible to oxidative damage due to its high metabolic activity, exposure to light, and rich vascular supply. Understanding the mechanisms underlying oxidative stress and implementing appropriate preventive strategies can be instrumental in preserving visual function and delaying disease progression. Oxidative stress and retinal health. Oxidative stress occurs when there is an imbalance between the production of reactive oxygen species, ROS, and the body's ability to neutralize them with antioxidants. In the retina, excessive ROS can damage cellular structures, including proteins, lipids, and DNA. Over time, this damage contributes to the degeneration of photoreceptors and retinal pigment epithelial (RPE) cells, which play a critical role in maintaining retinal function. The macula, responsible for central vision and detailed visual tasks, is particularly vulnerable. Oxidative stress exacerbates the accumulation of lipofuscin and drusen, both hallmark features of AMD, leading to progressive vision loss. The role of antioxidants in ocular protection. Antioxidants neutralize ROS, reducing oxidative damage and supporting cellular repair mechanisms. Several key antioxidants have been shown to be beneficial in retinal health. Vitamin C and vitamin E. These essential vitamins scavenge free radicals and prevent lipid peroxidation within retinal cells. Lutein and zeaxanthin. These carotenoids found in high concentrations in the macula filter harmful blue light and reduce oxidative damage. Zinc and copper. These trace minerals contribute to enzymatic antioxidant defense systems, protecting against cellular degeneration. Grapeseed extract and resveratrol. These polyphenols possess potent antioxidant and anti-inflammatory properties, which may aid in retinal protection. Clinical implications and patient management. For patients diagnosed with early-stage AMD or those at risk of developing the condition, lifestyle modifications and targeted supplementation can play a crucial role in mitigating disease progression. The Age-Related Eye Disease Study, AREDS and AREDS-2 trials provide evidence supporting the use of specific antioxidant formulations in reducing the risk of advanced AMD. In clinical practice, patients should be advised to adopt an antioxidant-rich diet, encourage the consumption of leafy greens, colourful vegetables, and omega-3 fatty acid-rich foods. Consider nutritional supplementation. Patients with intermediate to advanced AMD may benefit from AREDS-2-based supplementation. Reduce oxidative stressors. Smoking cessation, UV protection, and maintaining systemic vascular health are essential strategies. Conclusion: the impact of oxidative stress on vision loss, particularly in conditions such as AMD, underscores the importance of proactive ocular care. By integrating evidence-based antioxidant therapies and lifestyle interventions, we can provide patients with valuable strategies to preserve their vision and enhance their quality of life. Continued research and patient education will remain pivotal in advancing the field of ocular health and oxidative stress management. The problems eyes have. The role of oxidative stress in ocular degeneration. Oxidative stress has been increasingly recognized as a key contributor to degenerative changes in ocular tissues. This has generated significant interest in the potential role of antioxidant vitamins and minerals in both the prevention and treatment of age-related eye diseases. Presently, no fewer than 6 large, multi-centered clinical trials are underway to evaluate the efficacy of various nutritional supplements in ocular pathologies. Cataracts. Cataract surgery remains the most commonly performed surgical procedure in individuals over the age of 60. The economic impact of cataract-related healthcare expenditures in the United States is substantial, with approximately 1.3 million cataract surgeries performed annually at an estimated cost exceeding $3.5 billion. It has been postulated that delaying cataract onset by just 10 years could reduce the need for nearly half of these procedures. The crystalline lens functions to collect and focus light onto the retina, a process requiring lifelong transparency. However, age-related oxidative damage to lens proteins and lipids leads to a pacification and subsequent cataract formation. Research suggests that ensuring adequate levels of antioxidant nutrients may mitigate oxidative damage and preserve lens function. Studies have demonstrated that oxidative stress, primarily from ultraviolet UV radiation exposure, contributes significantly to cataractogenesis. Endogenous antioxidants such as glutathione peroxidase, catalase, and superoxide dismutase form the primary defense system of the lens. However, these defenses are often insufficient in preventing oxidative damage over time. Epidemiological evidence indicates that antioxidant supplementation may confer a protective effect. The aqueous humour which bathes the lens is rich in antioxidants such as vitamin C, vitamin E, alpha-lipoic acid, and beta-carotene, which collectively combat oxidative damage. Clinical studies have demonstrated an inverse relationship between plasma levels of these antioxidants and the risk of cataract formation. A Finnish case-controlled study found that individuals with the alleles with the lowest levels of vitamin E and beta-carotene exhibited a 4 to 5-fold increased likelihood of requiring cataract surgery. Furthermore, individuals who regularly consumed supplemental antioxidants demonstrated at least a 50% reduction in cataract incidence. Given the substantial body of evidence supporting the protective role of antioxidants, there is a compelling rationale for incorporating these nutrients into early preventive strategies. Alpha-lipoic acid, in particular, has shown promise in enhancing the efficacy of other antioxidants and in regenerating intracellular glutathione, a key molecule in cellular defense mechanisms. Ongoing clinical trials will further elucidate optimal supplementation strategies. However, current data strongly support the recommendation of antioxidant supplementation as an economical and effective measure in reducing cataract prevalence. Age-related macular degeneration, RMD. RMD is the leading cause of blindness in individuals over the age of 60 in the United States. This progressive condition primarily affects the macula, the region of the retina responsible for high-acuity central vision. As macular degeneration advances, individuals experience a gradual loss of central vision, often rendering tasks such as reading and facial recognition difficult. Peripheral vision typically remains intact. RMD manifests in two primary forms, dry, atrophic, and wet, neovascular. The dry form, which accounts for approximately 90% of cases, is characterized by the gradual breakdown of macular cells. Approximately 10% of these cases progress to the wet form, in which aberrant neovascularization leads to fluid leakage, hemorrhage, and rapid vision loss. Currently, no proven treatment exists for dry RMD, while wet RMD may be managed with laser photocoagulation to reduce neovascular proliferation. However, despite intervention, visual deterioration often continues. Epidemiological studies underscore the increasing prevalence of RMD. Prevent Blindness America estimates that approximately 14 million Americans exhibit some degree of RMD, with data from the Beaver Dam Eye study indicating that 30% of individuals over the age of 75 are affected. Furthermore, 23% of those without the disease at age 75 will develop RMD within 5 years. Given the profound implications of RMD on visual function and quality of life, identifying preventive strategies remains a public health priority. Antioxidant supplementation, along with dietary and lifestyle modifications, may play a crucial role in mitigating disease progression. Continued clinical research will be instrumental in refining evidence-based recommendations for RMD prevention and management. Mechanism of retinal injury in age-related macular degeneration, ARMD. Recent advancements in ophthalmic research have provided compelling insights into the pathophysiology of age-related macular degeneration, ARMD. One prevailing hypothesis implicates oxidative stress as a primary mechanism underlying photoreceptor damage. Specifically, visible light entering the eye is focused onto the macula, where it generates substantial free radicals within the outer segments of the photoreceptors. In the absence of sufficient antioxidant defense mechanisms, these free radicals initiate oxidative damage to critical cellular components, including the high concentration of polyunsaturated fatty acids, PUFAs, present in the outer retina and photoreceptors. A well-documented consequence of PUFA oxidation is the formation of lipofusin, a complex of oxidized lipid and protein aggregates that accumulate within the retinal pigment epithelium, RPE. The presence of lipofusin exacerbates oxidative stress, further compromising cellular integrity and leading to progressive photoreceptor dysfunction. Current evidence suggests that lipofusin accumulation is a pivotal contributor to RPE degeneration and subsequent photoreceptor cell loss. Over time, these cellular byproducts are expelled as drusen, extracellular deposits that serve as a hallmark of RMD. The accumulation of drusen between the RPE and the underlying choroidal vasculature impairs nutrient exchange and disrupts the metabolic support necessary for photoreceptor viability. This obstruction results in localized atrophy of the retina, manifesting clinically as central vision loss, photoreceptor damage, and visual impairment. The progressive accumulation of drusen leads to the detachment of photoreceptors from their essential blood supply, ultimately resulting in irreversible visual deficits. The geographic atrophy observed in advanced ARMD underscores the critical role of oxidative stress and metabolic dysfunction in retinal degeneration. Further investigations into targeted antioxidant therapies and interventions to mitigate oxidative damage remain imperative for the development of effective management strategies. The generation of free radicals in the retina. The process of light absorption by the retinal pigment epithelium and photoreceptors is inherently associated with the generation of free radicals. This phenomenon is particularly pronounced with exposure to high-energy ultraviolet, UV, and visible blue light, which are potent inducers of oxidative stress within the retinal environment. Prolonged exposure to these wavelengths significantly increases the risk of developing age-related macular degeneration, ARMD, a leading cause of vision loss in aging populations. Scientific evidence suggests that the body's endogenous antioxidant defense mechanisms, which counteract free radical-induced retinal damage, decline with age. This disruption in the equilibrium between oxidative stress and antioxidant protection contributes to cumulative retinal injury and the progression of degenerative retinal disorders. Several clinical studies have identified a correlation between ARMD and decreased systemic levels of key antioxidants, including zinc, selenium, vitamin C, vitamin E, and carotenoids. Research has further explored whether supplementation with these nutrients can mitigate the risk of ARMD or slow its progression. Carotenoids and retinal protection. Historically, beta-carotene found in carrots was widely recognized for its role in supporting vision, particularly night vision. However, more recent research has highlighted the greater importance of other carotenoids, specifically lutein and zeaxanthin, found in green leafy vegetables, corn, and collard greens. Lutein and zeaxanthin are yellow pigments that selectively absorb blue light, which is the most energetic and potentially damaging portion of the visible spectrum. By filtering blue light before it reaches the retina, these carotenoids function as an intrinsic protective mechanism akin to natural internal sunglasses. In addition to their role as optical filters, they exhibit potent antioxidant properties, neutralizing free radicals generated within the photoreceptor cells. This dual function, light filtration and oxidative stress mitigation, underscores their critical role in maintaining retinal health and reducing the risk of ARMD progression. Given the growing body of evidence supporting the protective role of these nutrients, optimizing dietary intake or supplementation of lutein and zeaxanthin may be a valuable strategy in retinal preservation and ARMD prevention. Further research continues to refine our understanding of their precise mechanistic benefits and optimal dosing strategies for clinical application. Studies demonstrate the protective role of lutein in ocular health. Research has consistently shown that lutein and zeaxanthin supplementation not only enhances serum levels of these carotenoids, but also significantly increases their concentration within ocular tissues. Macular pigment density, which serves as a critical protective factor for the retina, has been observed to rise by 20 to 40% in clinical studies. Concurrently, the transmission of blue light to macular photoreceptors is reduced by nearly 40%, effectively mitigating oxidative stress-induced damage. A landmark study, published in the Journal of the American Medical Association, November 9, 1994, highlighted a 43% reduction in the risk of age-related macular degeneration, ARMD, among individuals with the highest dietary intake of lutein and zeaxanthin, compared to those with the lowest intake. Notably, this protective effect was not observed with beta-carotene, reinforcing the unique role of lutein and zeaxanthin as the only carotenoids specifically deposited within the macula. While beta-carotene remains a beneficial dietary component, it does not confer the same protective advantage against ARMD. Vitamin C and ocular protection. Low systemic levels of vitamin C have been associated with an increased risk of ARMD. This essential nutrient is highly concentrated in the aqueous humor and plays a pivotal role as an antioxidant within the retina. Supplementation with vitamin C has been shown to decelerate RMD progression, in part due to its ability to regenerate vitamin E and intracellular glutathione, both critical components of the ocular antioxidant defense system. Vitamin E and retinal defense patients with RMD often exhibit reduced levels of vitamin E within the macula, a region particularly susceptible to oxidative stress due to high energy light exposure. While not the predominant antioxidant in ocular tissues, vitamin E remains an essential contributor to retinal protection. Supplementation with vitamin E may provide a defense against RMD progression by mitigating oxidative damage within the macula. Coenzyme Q10 and retinal health. Coenzyme Q10, a lipid-soluble antioxidant, has demonstrated significant protective effects on lipid-rich tissues, including the retina. Studies indicate that patients with ARMD frequently present with depleted CoQ10 levels, which may compromise their ability to counteract oxidative damage. Emerging evidence suggests that maintaining optimal CoQ10 levels enhances the retina's resilience against oxidative stress, offering promising implications for RMD management. Glutathione, a critical intracellular antioxidant. Glutathione is an essential intracellular antioxidant present in high concentrations within the lens, retinal pigment epithelium, and photoreceptors. Age-related declines in glutathione levels are strongly correlated with an increased incidence of ocular diseases. Despite its critical role, oral glutathione supplementation has limited bioavailability. Instead, enhancing endogenous glutathione synthesis through precursor nutrients such as selenium, vitamin B6, N-acetyl L-cysteine, and niacin is a more effective strategy. Additionally, alpha-lipoic acid and vitamin C facilitate glutathione recycling, further supporting cellular antioxidant capacity. Zinc and selenium, essential minerals for ocular antioxidant defense. Zinc and selenium are integral to the body's endogenous antioxidant systems. Zinc is a cofactor for catalase, while selenium is a crucial component of the glutathione peroxidase system. Both minerals play essential roles in counteracting oxidative stress within ocular tissues. Clinical studies have demonstrated that supplementation with these micronutrients, particularly zinc, can stabilize and even improve our RMD outcomes. Conclusion. The accumulation of evidence underscores the significance of targeted nutritional interventions in preserving ocular health and mitigating the progression of RMD. Lutein, zeaxanthin, vitamin C and E, CoQ10, glutathione precursors, zinc, and selenium collectively contribute to the maintenance of retinal integrity by enhancing antioxidant defenses and reducing oxidative damage. Physicians should consider these evidence-based nutritional strategies as adjunctive measures in the comprehensive management of RMD and overall ocular health. Phase story. A case of macular degeneration management. During a routine visit, one of my long-standing patients, Faye, accompanied her husband for his checkup. During our conversation, she disclosed that she had recently been diagnosed with macular degeneration. Her symptoms first became apparent while traveling to Texas to visit family. She noticed a progressive decline in her ability to see clearly, frequently removing and cleaning her glasses, only to find no improvement in her vision. Assuming she needed an updated prescription, she scheduled an appointment with her local optometrist upon returning home. However, despite a thorough examination, no definitive cause for her visual disturbances was identified. Over the subsequent weeks, Faye's vision continued to deteriorate. She struggled to recognize faces, particularly during church services, where she could no longer distinguish the members of the choir. Concerned, she sought consultation with a retinal specialist. Following a comprehensive ophthalmologic evaluation, she was diagnosed with wet age-related macular degeneration, AMD, with significant vision loss already present in her left eye. Given the progressive nature of wet AMD, her ophthalmologist advised close monitoring and the possibility of laser intervention if warranted. As part of my ongoing commitment to evidence-based medicine, I had extensively researched nutritional interventions for macular degeneration. Several of my patients had experienced notable visual improvements through targeted supplementation. After discussing this approach with Faye, she expressed strong interest in exploring this adjunctive therapy. I initiated her on a structured regimen of antioxidants and other key nutrients, as outlined in Chapter 17. Within 2 months, Faye reported remarkable improvement. Her vision had significantly recovered, allowing her to once again recognize individual faces in the choir. This positive trajectory has persisted over the past 5 years. By maintaining her nutritional regimen and adhering to regular ophthalmologic evaluations, she has successfully stabilized her condition without requiring laser treatment. Her ophthalmologist continues to monitor her closely and frequently remarks on the exceptional health of her eyes. Faye's case highlights the potential role of nutritional support in the management of macular degeneration. While ongoing research is essential to further validate these interventions, her experience underscores the importance of a comprehensive, patient-centered approach to preserving visual function in AMD. Protecting your eyes against cataracts and age-related macular degeneration. As a physician dedicated to optimizing ocular health, I have shared an extensive amount of technical information to provide you with the medical evidence necessary for making informed decisions about nutritional supplements and preventive measures against eye diseases. These recommendations are equally relevant for individuals already diagnosed with cataracts or macular degeneration who wish to slow disease progression. You may now be wondering, how can this information be applied practically? In my clinical practice, I take an assertive approach in managing patients with macular degeneration with the goal of mitigating oxidative damage and potentially reversing its effects. I have personally overseen more than a dozen cases where ophthalmologists have documented measurable visual improvement following these recommendations. The role of sunlight and oxidative stress. One of the most crucial steps in protecting ocular health is minimizing exposure to harmful high-energy sun rays, a primary driver of oxidative stress in the eyes. In a young, healthy adult, the cornea and lens serve as protective barriers absorbing most UV light. However, they do not effectively block high-energy visible blue light. As we age, the lens loses its ability to filter out ultraviolet rays, exposing the retina to increased oxidative damage. To counteract this, reducing oxidative stress is paramount. Investing in high-quality sunglasses that offer complete UV and blue light protection is essential. This proactive step decreases the burden on the body's antioxidant defense mechanisms, reducing the number of free radicals that need to be neutralized. Clinical research has consistently demonstrated that when the antioxidant defense system is overwhelmed, oxidative stress leads to cellular damage, increasing the risk of cataracts and macular degeneration. It is vital to take measures such as wearing protective eyewear and shading the eyes from direct sunlight, particularly for individuals with outdoor occupations or those engaged in high-exposure activities. The role of antioxidant supplementation. The second critical component in preserving vision is fortifying the body's natural antioxidant defenses. Numerous studies support the role of nutritional supplementation in enhancing ocular health. For instance, one study involving 192 patients with macular degeneration found that after 6 months of antioxidant supplementation, 87.5% of patients maintained or improved their visual acuity. In contrast, only 59% of the control group, who did not receive supplements, experienced similar stability or improvement. Clinical impact and real-world observations. The profound impact of these recommendations was highlighted in an encounter with a local ophthalmologist. He approached me in a restaurant parking lot and asked, "What nutritional regimen are you prescribing to your macular degeneration patients?" I just examined a patient whose vision remarkably improved from 20/100 to 20/40 in both eyes, something I have never observed before in macular degeneration cases. After briefly summarizing the principles outlined in this chapter, he responded with a knowing smile. "You can assist as many macular degeneration patients as you like, but don't help too many cataract patients. We surgeons need something to operate on." While his remark was light-hearted, it underscored the growing recognition of the impact of nutritional supplementation on eye health. Given that oxidative stress is the underlying mechanism behind both cataracts and macular degeneration, an aggressive approach to supplementation is justified. There is no definitive medical treatment for age-related macular degeneration, and many patients could potentially avoid cataract surgery altogether by adopting these preventive measures. When such a simple and effective intervention is available, it becomes a compelling strategy for lifelong ocular health preservation. Autoimmune diseases, a clinical perspective. Mark, the youngest of 6 children, exhibited a natural resilience and competitive spirit from an early age. As a healthy and active child, he thrived in multiple sports, with soccer being his particular passion. However, at the age of 12, his life took an unexpected turn. During an intense soccer practice, Mark experienced severe abdominal cramping, followed by persistent diarrhea and vomiting. When over-the-counter medications failed to provide relief, his parents brought him to the emergency department, where he was diagnosed with acute appendicitis. An emergent appendectomy was performed, and he was discharged following an uncomplicated recovery period. Within 24 hours of discharge, Mark's symptoms escalated dramatically. He presented with worsening abdominal pain, hematochezia, and intractable vomiting, prompting immediate readmission. The severity of his condition puzzled the local medical team, who then referred him to the pediatric gastroenterology service at Loma Linda University Medical Center. Upon admission to the Pediatric Intensive Care Unit (PICU), Mark underwent an urgent colonoscopy with biopsy. Endoscopic visualization revealed an extensively ulcerated, inflamed mucosa with a cobblestone appearance, classic findings consistent with Crohn's disease. Additionally, stool studies confirmed a secondary Clostridium difficile infection, compounding his condition. Given the severity of inflammation and risk of perforation, Mark's management was aggressive. He was initiated on high-dose corticosteroid therapy, prednisone 200 mg daily, broad-spectrum antibiotics, and opioid analgesia for pain control. A multidisciplinary team, including pediatric gastroenterologists and surgeons, convened daily to assess whether surgical resection of the affected bowel segments would be necessary. Fortunately, his condition gradually improved with medical management alone, and repeat colonoscopy demonstrated resolution of the C. difficile infection, unmasking the underlying ulcerative pathology characteristic of Crohn's disease. Autoimmune diseases such as Crohn's disease arise when the body's immune system erroneously targets its own tissues, leading to chronic inflammation and tissue destruction. In Mark's case, his immune system initiated an inflammatory response against the gastrointestinal tract, resulting in extensive mucosal damage. Immunosuppressive therapy, including corticosteroids and azathioprine Imuran, was prescribed to attenuate this aberrant immune response. However, immune suppression presents its own challenges. Mark became increasingly susceptible to opportunistic infections, requiring multiple hospital admissions for respiratory and gastrointestinal infections. Over the course of the following year, he was hospitalized 7 times due to complications stemming from his compromised immune defenses. At this juncture, Mark's father sought additional medical advice. In my assessment, I emphasized the importance of bolstering his antioxidant defenses. I recommended a regimen of potent antioxidant and mineral supplementation, including high-dose grapeseed extract, coenzyme Q10, CoQ10, and essential fatty acids from either flaxseed or fish oil. These interventions aim to mitigate oxidative stress and enhance immune modulation. With time, Mark demonstrated clinical improvement. His physicians successfully weaned him off corticosteroids, though he remained on azathioprine. Concerned about the long-term adverse effects of immunosuppressive therapy, his parents pursued a second opinion from a private pediatric gastroenterologist. Given his stabilized condition, the new specialist initiated a gradual withdrawal of azathioprine. Concurrently, a psychologist employed cognitive behavioral strategies and relaxation techniques to assist Mark in managing his pain without pharmacologic intervention. Eventually, Mark was entirely medication-free and reported a significant improvement in his quality of life. Currently, at 15 years of age, Mark remains asymptomatic and maintains a normal diet. Remarkably, he has not experienced a Crohn's disease flare-up in over 2.5 years. His case underscores the complexity of autoimmune pathophysiology, the necessity of a tailored therapeutic approach, and the potential benefits of adjunctive nutritional and lifestyle modifications.
the autoimmune enigma.
Mark's case highlights a fundamental question in autoimmune disease research. Why does the immune system, designed to protect against external pathogens, instead launch an attack against self-tissues? Understanding the mechanisms underlying immune dysregulation is essential in developing targeted therapies and improving patient outcomes. In the following sections, we will delve deeper into the intricacies of the immune system's function and explore the pathogenesis of autoimmune diseases. The immune system, our great protector. The immune system serves as the body's primary defense mechanism against pathogenic organisms, foreign proteins, and aberrant cellular growth such as cancer. This complex and highly coordinated network of immune cells operates in a dynamic interplay to maintain homeostasis and protect against disease. While an exhaustive discussion of immunological function is beyond the scope of this text, it is imperative to outline the key cellular constituents of the immune response and their respective roles. Key components of the immune system. Macrophages, phagocytes. These are large, specialized white blood cells that function as the first line of defense. They exhibit phagocytic activity, engulfing and digesting pathogenic organisms, cellular debris, and foreign particles. However, macrophages must discern between self and non-self to prevent autoimmune reactions. In uncertain cases, they recruit T helper cells for further assessment. T helper cells, CD4+ lymphocytes. These lymphocytes play a pivotal role in immune regulation. Upon engaging with a macrophage, a T helper cell assesses the nature of the engulfed entity. If identified as pathogenic, T helper cells release cytokines, potent signaling molecules that amplify the immune response. These cytokines initiate a cascade that recruits additional immune cells and activates B cells for antibody production. B cells. These adaptive immune cells are responsible for humoral immunity. Upon activation, B cells differentiate into plasma cells that produce antigen-specific antibodies. These antibodies neutralize pathogens and facilitate their removal. Furthermore, memory B cells ensure a rapid and robust response upon future exposure to the same antigen. Natural killer NK cells. These cytotoxic lymphocytes function as part of the innate immune system, targeting virally infected cells and malignancies. NK cells employ a mechanism of targeted apoptosis, releasing cytotoxic granules to eliminate aberrant cells without prior sensitization, thereby serving as a crucial component in immune surveillance. T suppressor regulatory T cells. These cells modulate the immune response, preventing excessive inflammation and autoimmune reactions. By downregulating immune activation following pathogen clearance, regulatory T cells mitigate collateral damage to healthy tissues and maintain immune tolerance. The role of nutritional support in immune function. Optimal immune function is contingent upon adequate nutritional status. Antioxidant micronutrients, including vitamins C and E, selenium and zinc, are essential for modulating oxidative stress and enhancing immune resilience. Dr. Karl-Heinz Schmidt aptly stated, "The optimal function of the host defense system depends upon an adequate supply of antioxidant micronutrients." Ensuring sufficient intake of these nutrients fortifies the immune system, enabling it to perform its protective functions effectively. By understanding the fundamental components of immune defense and supporting them with appropriate nutrition, we can optimize our body's innate ability to ward off disease and maintain overall health. Nutrients and our immune system. A review of the medical literature provides valuable insights into the critical role individual nutrients play in modulating immune function. Below, we examine the impact of several key micronutrients on immune response and overall health. Vitamin E. Macrophages deficient in vitamin E exhibit increased production of free radicals and reduced lifespan. The immune system utilizes controlled oxidative stress to eliminate foreign invaders. However, an excess can be detrimental. Vitamin E deficiency disrupts T-cell differentiation in the thymus, leading to an imbalance between T helper and T suppressor cells. Inadequate T suppressor cell production contributes to unchecked inflammatory responses, a factor implicated in autoimmune pathologies. Studies indicate that vitamin E supplementation mitigates these immune deficiencies and enhances infection clearance. Clinical trials have further demonstrated that these benefits are particularly pronounced in elderly individuals and those with malabsorption syndromes. Additionally, vitamin E protects against the immunosuppressive effects of cortisol, which is elevated during stress responses. Carotenoids. Carotenoids serve as protective agents against immune-mediated tissue damage by modulating inflammatory responses. Supplementation has been associated with increased numbers and improved function of T helper and natural killer cells, thereby enhancing the immune system's ability to detect and eliminate malignant cells. This heightened tumor surveillance underscores the potential of carotenoids in oncological defense. Vitamin C. The pioneering work of Dr. Linus Pauling highlighted vitamin C's role in immune enhancement. While debate persists regarding its efficacy in preventing the common cold, its immunomodulatory properties are well documented. Vitamin C augments macrophage function, reinforcing the first line of defense against bacterial pathogens. Routine daily intake of vitamin C, rather than sporadic high-dose consumption during illness, has been shown to significantly enhance immune function. Clinical evidence supports the administration of 1 gram per day for at least 2 months to achieve optimal immunological benefits. Furthermore, vitamin C facilitates the regeneration of vitamin E and neutralizes free radicals in plasma, thereby amplifying its protective effects. Glutathione. Glutathione, a crucial intracellular antioxidant, is essential for immune system function. Supplementation with its precursors, N-acetyl-L-cysteine, selenium, niacin, and vitamin B2, has demonstrated significant immunostimulatory effects, even in immunocompromised individuals such as those with HIV.
Coenzyme Q10!
Aging is associated with declining levels of coenzyme Q10, which compromises mitochondrial function and renders immune cells more susceptible to oxidative damage. As a pivotal component in cellular energy production, CoQ10 is indispensable for optimal immune function. Supplementation has been shown to restore immune efficiency and enhance resistance to infections. Zinc. Zinc is integral to nearly every facet of immune function. Deficiency results in lymphocyte depletion, impaired white cell activity, and reduced thymic hormone production, all of which compromise immune defenses. Short-term zinc supplementation, particularly via lozenges taken every 2 hours during an upper respiratory infection, has been shown to reduce the duration of colds. The underlying mechanism likely involves both immune enhancement and direct inhibition of viral replication. However, prolonged dose zinc intake may paradoxically suppress immune function, necessitating careful dosage considerations. Conclusion. Optimizing immune function through targeted nutritional supplementation offers profound health benefits. Research indicates that children can achieve enhanced immune responses within 6 months of supplementation, whereas elderly individuals may require up to a year for full immunological optimization. Given that respiratory infections are among the leading causes of mortality in the elderly, these findings underscore the importance of micronutrient sufficiency. A study published in The Lancet demonstrated that elderly patients receiving optimal nutritional supplementation exhibited significant immune enhancements and experienced fewer, less severe infections compared to placebo recipients. These findings reinforce the interdependence of immune function and micronutrient status, highlighting the necessity of comprehensive nutritional strategies to support long-term health and disease resistance. The inflammatory response, a clinical perspective. Inflammation is a fundamental biological response, yet when dysregulated, it becomes a significant driver of chronic disease. As we have explored throughout this book, inflammation is not merely a symptom, but a root cause of many modern health concerns. Cardiovascular disease, for instance, is increasingly recognized as an inflammatory condition rather than a simple disorder of lipid metabolism. Similarly, inflammatory bowel diseases, such as Crohn's disease and ulcerative colitis, exemplify the destructive consequences of unchecked inflammation in the gastrointestinal tract. The same pathological mechanism underlies arthritis, asthma, and numerous autoimmune conditions. In essence, chronic systemic inflammation is a pervasive issue in modern medicine. Addressing this imbalance is paramount, and targeted nutritional interventions play a crucial role in modulating the inflammatory response. The biochemical cascade of inflammation. The inflammatory response is a highly intricate process involving a cascade of immune mediators. The activation of immune cells leads to the release of free radicals, proteolytic enzymes, and pro-inflammatory cytokines such as tumor necrosis factor alpha TNF-5, interleukin-6 IL-6, and interleukin-1 beta IL-1 beta. While these molecules are essential for host defense, their chronic activation leads to tissue damage, oxidative stress, and systemic dysfunction. Antioxidant supplementation is a powerful tool in mitigating excessive inflammation. By neutralizing reactive oxygen species, ROS, antioxidants enhance immune regulation, suppress inflammatory pathways, and protect cellular integrity. However, an equally critical, yet often overlooked component of inflammation regulation lies in the body's endogenous anti-inflammatory systems. Endogenous anti-inflammatory pathways. Many individuals rely on non-steroidal anti-inflammatory drugs, NSAIDs, to manage inflammation-related discomfort. Yet the body possesses its own intrinsic mechanisms to counteract excessive inflammatory responses. These mechanisms include the production of specialized lipid mediators derived from essential fatty acids, particularly omega-3 and omega-6 fatty acids. The role of essential fatty acids in inflammation modulation. Essential fatty acids, EFAs, are indispensable for cellular function and must be obtained through diet. These fats serve as precursors for eicosanoids, a class of signaling molecules that regulate inflammation. Omega-3 fatty acids, alpha-linolenic acid, ALA, found in flaxseed, chia seeds, walnuts, and cold water fish, e.g. salmon, sardines, and mackerel. Omega-3 fatty acids are converted into anti-inflammatory eicosanoids, specifically prostaglandins PGE3 and resolvins. These compounds help resolve inflammation and promote cellular homeostasis. Omega-6 fatty acids, linoleic acid, LA, abundant in vegetable oils, dairy, and processed foods. Omega-6 fatty acids are precursors to pro-inflammatory eicosanoids, PGE2. While necessary for immune function and wound healing, excessive intake can drive chronic inflammation. The omega-6 to omega-3 ratio, a critical balance. The optimal dietary ratio of omega-6 to omega-3 fatty acids is approximately 4:1. However, the modern Western diet often skews heavily toward omega-6 dominance, with ratios reaching 21 or higher. This imbalance promotes systemic inflammation and contributes to a myriad of chronic diseases. To restore homeostasis, increasing dietary intake of omega-3 fatty acids, either through whole food sources or supplementation, is essential. High-quality fish oil and flaxseed oil supplements can help shift the balance toward an anti-inflammatory state, reducing disease risk and improving clinical outcomes in conditions such as rheumatoid arthritis, cardiovascular disease, and autoimmune disorders. Essential fatty acids and cardiometabolic health. Beyond their role in inflammation, omega-3 fatty acids exert cardioprotective effects by modulating lipid metabolism. Research demonstrates that supplementation with omega-3s can lower total cholesterol and low-density lipoprotein, LDL, cholesterol levels, increase high-density lipoprotein, HDL, cholesterol, reduce triglyceride levels, enhance endothelial function, decrease the risk of thrombosis. Clinical implications and therapeutic strategies. Given the extensive evidence supporting the benefits of essential fatty acids, clinicians should consider incorporating dietary and supplemental omega-3 strategies as part of an integrative approach to inflammation management. By addressing dietary imbalances and enhancing endogenous anti-inflammatory pathways, we can significantly reduce the burden of chronic inflammatory diseases. As we continue our exploration of immune function, we must also examine the most severe consequence of immune dysregulation, the onset of autoimmune diseases, in which the immune system mistakenly targets the body's own tissues. Understanding this process is critical for developing effective interventions that restore immune balance and prevent long-term damage. Autoimmune diseases. When the body turns against itself, the immune system serves as the body's primary defense against harmful pathogens, distinguishing between self and non-self to maintain homeostasis. However, in the case of autoimmune diseases, this finely tuned system becomes dysregulated, leading to the immune-mediated destruction of normal tissues. The clinical manifestations vary depending on the targeted organs. Rheumatoid arthritis affects the joints, multiple sclerosis attacks the myelin sheath of nerves, and systemic lupus erythematosus involves widespread connective tissue damage, among others. Pathophysiology, a case of immune dysregulation. Historically, autoimmune diseases have been attributed to an overactive immune system. However, emerging evidence suggests that immune dysfunction in autoimmunity is more accurately characterized as a loss of self-tolerance rather than simple hyperactivity. This breakdown in immune regulation leads to aberrant immune responses against host tissues, resulting in chronic inflammation and progressive tissue damage. While the precise etiology remains elusive, oxidative stress has been implicated as a key contributor to autoimmune pathogenesis. Oxidative stress occurs when there is an imbalance between reactive oxygen species, ROS production, and the body's ability to neutralize them with antioxidants. Elevated oxidative stress has been observed in patients with rheumatoid arthritis, lupus, multiple sclerosis, and inflammatory bowel diseases, particularly during disease exacerbations. Furthermore, reduced antioxidant levels have been correlated with an increased risk of developing autoimmune conditions. Ha! The role of antioxidant therapy. Given the strong association between oxidative stress and autoimmunity, antioxidant supplementation has been proposed as a potential therapeutic strategy. Antioxidants can mitigate oxidative damage, modulate inflammatory pathways, and support immune homeostasis. While conventional treatments such as immunosuppressive therapy and biologics remain the cornerstone of autoimmune disease management, adjunctive antioxidant therapy may enhance clinical outcomes by reducing oxidative burden and inflammation. Further research is needed to elucidate the precise mechanisms by which oxidative stress influences immune dysregulation and to determine the optimal antioxidant regimens for different autoimmune diseases. Nonetheless, targeting oxidative stress represents a promising avenue for improving disease control and patient quality of life. Matt's story, a case study in autoimmune management. Matt, a high-achieving attorney in the Chicago area, spent years dedicating himself to his profession while balancing his responsibilities to his wife and family. With no prior history of significant illness, he had little reason to consider his health beyond routine care until the fall of 1996. While attending a wedding, Matt developed acute abdominal discomfort. Given his demanding workload in the preceding weeks, he initially attributed his symptoms to a viral illness. However, his condition rapidly worsened. Within days, he experienced profound fatigue, myalgias, and progressive pain, describing the sensation as being hit by a Mack truck. Concerned about the severity of his symptoms, Matt sought medical attention. His evaluation included comprehensive imaging, CT scans, ultrasounds, and radiographs, along with extensive laboratory testing. Despite exhaustive diagnostics, no definitive etiology was identified, and he was discharged with symptomatic management, including analgesics. His symptoms, however, persisted. In an effort to take control of his health, Matt began an intensive nutritional supplementation regimen focusing on antioxidants and minerals. Despite these measures, his condition remained largely unchanged, marked by systemic aches and profound fatigue. He ultimately consulted a specialist who ordered an anti-nuclear antibody (ANA) test, a key marker for autoimmune disorders. The results were striking. An ANA titer of 16640 with normal values typically 140, strongly indicative of systemic lupus erythematosus, SLE. SLE is a chronic autoimmune disease characterized by widespread inflammation and immune dysregulation, leading to tissue and organ damage. Given his diagnosis, conventional treatment would typically include corticosteroids and immunosuppressive agents such as hydroxychloroquine or, in severe cases, cytotoxic therapy. Instead, Matt opted to intensify his nutritional strategy, incorporating 350 milligrams of grapeseed extract in addition to his existing antioxidant regimen. Over time, he noted gradual improvement with decreased reliance on analgesics and a reduction in symptom severity. By January, he was able to resume work, maintaining a demanding schedule without significant relapse. During a subsequent follow-up, his specialist, anticipating the need for immunosuppressive therapy, was astounded by Matt's laboratory results. His ANA titer had normalized to 140. Given this unexpected improvement, his physician deferred pharmaceutical intervention and encouraged him to maintain his current regimen. Remarkably, Matt remained asymptomatic for over 5 years, with serial ANA tests continuing to show negative or near-normal results. Clinical insights and implications. Matt's case highlights several key considerations in autoimmune disease management. Early intervention. The initiation of an aggressive supplementation regimen early in his disease course may have played a role in immune modulation and symptom mitigation. Non-pharmacologic strategies. While conventional medical therapy remains the mainstay of autoimmune disease management, complementary approaches, such as targeted nutritional support, warrant further exploration. Individualized treatment plans. Autoimmune disorders exhibit heterogeneous presentations, and response to treatment varies widely. Matt's experience underscores the importance of patient-centered care and the need for ongoing research into adjunctive therapies. It is critical to acknowledge that while Matt's case is compelling, it does not constitute a generalizable treatment model for SLE. Standard medical therapies remain essential for most patients, particularly those with organ involvement or severe disease manifestations. However, his experience raises important questions regarding the potential role of nutritional optimization in autoimmune conditions. Further studies are needed to elucidate the mechanisms by which dietary supplements may influence immune regulation and disease progression. Matt's journey serves as both a cautionary and an inspiring narrative, emphasizing the necessity of proactive health management while recognizing the value of integrative approaches in chronic disease care. Arthritis and osteoporosis, a clinical perspective. As the old saying goes, there are two certainties in life, death and taxes. However, for the majority of individuals over the age of 50, a third inevitability emerges, arthritis. Osteoarthritis, OA, the most prevalent form of arthritis, affects approximately 70 to 80% of adults in this age group. It is a chronic degenerative joint disease that I frequently encounter in my clinical practice. Understanding osteoarthritis. Patients often describe the hallmark symptoms of osteoarthritis: early morning stiffness, mild joint swelling, and progressive joint pain. This condition can affect any joint in the body, including the cervical and lumbar spine, leading to significant discomfort and, in severe cases, disability. Osteoarthritis is primarily characterized by the degeneration of articular cartilage. However, it also involves pathological changes in the synovial lining and subchondral bone. As the protective cartilage erodes, increased mechanical stress is placed on the underlying bone. In response, the bone undergoes sclerosis and may develop osteophytes, bone spurs, which can further contribute to pain and reduce joint mobility. The progression and risk factors. A common phrase among patients considering joint replacement surgery is that they have bone on bone. This term reflects the complete loss of cartilage, resulting in direct articulation of bone surfaces, which exacerbates pain and restricts movement. Several risk factors contribute to the development and progression of osteoarthritis. The most significant include age. The prevalence of OA increases with advancing age due to cumulative wear and tear. Obesity, excessive body weight places additional stress on weight-bearing joints, accelerating cartilage deterioration. Previous joint trauma, injuries, including fractures and ligamentous damage, predispose individuals to early-onset osteoarthritis. Repetitive mechanical stress, occupational and recreational activities that involve repetitive joint use can hasten cartilage breakdown. Osteoporosis, a silent comorbidity. Closely linked to osteoarthritis, particularly in aging populations, is osteoporosis. This condition is characterized by decreased bone density and increased fracture risk. While osteoarthritis results in subchondral bone sclerosis, osteoporosis leads to skeletal fragility, predisposing individuals to fractures, particularly in the hip, spine, and wrist. Osteoporotic fractures can significantly impair mobility and quality of life, making early detection and management crucial. Risk factors for osteoporosis include advanced age, hormonal changes, particularly postmenopausal estrogen deficiency, chronic glucocorticoid use, and inadequate calcium vitamin D intake. Clinical approach and management. The management of osteoarthritis and osteoporosis requires a comprehensive, multidisciplinary approach. For osteoarthritis, treatment strategies focus on symptom relief and functional preservation. These include pharmacologic therapy, NSAIDs, intra-articular corticosteroids, and hyaluronic acid injections for pain management. Physical therapy, strengthening exercises, weight management, and joint protection techniques. Surgical intervention, total joint arthroplasty remains a viable option for severe refractory cases. For osteoporosis, preventive strategies and treatment modalities aim to reduce fracture risk. Calcium and vitamin D supplementation, essential for maintaining bone mineral density. Weight-bearing exercise encourages bone remodeling and strength. Pharmacologic therapy, bisphosphonates, denosumab, and selective estrogen receptor modulators, as indicated. Conclusion: both osteoarthritis and osteoporosis represent significant musculoskeletal challenges in aging populations. While their pathophysiology differs, their impact on mobility and quality of life necessitates proactive management. As clinicians, our role is to provide early intervention, patient education, and individualized treatment plans to optimize musculoskeletal health and prevent long-term disability. How is the joint actually damaged? Articular cartilage serves as the smooth, protective covering at the ends of bones within a joint. In high load-bearing joints such as the knees, additional cartilage structures such as the menisci provide further cushioning and stability. Cartilage is primarily composed of collagen fibers, glycoproteins, and proteoglycans, forming a resilient matrix that allows for frictionless movement. Under normal physiological conditions, cartilage undergoes a continuous cycle of synthesis and degradation, maintaining a delicate balance necessary for joint health. When this equilibrium is disrupted, either through accelerated breakdown or insufficient regeneration, progressive joint degeneration occurs, leading to osteoarthritis. Osteoarthritis is now recognized as a chronic inflammatory disease rather than a simple wear and tear condition. Clinically, the inflammatory component is evident in patients with arthritic hands, where joints appear swollen, erythematous, and tender. But what precisely drives this inflammatory process, and how does it contribute to cartilage degradation? The pathophysiology is complex and multifactorial, involving mechanical stress, cytokine-mediated inflammation, enzymatic degradation, and immune system dysregulation. Several inflammatory mediators, including interleukin-1 beta, IL-1 beta, tumor necrosis factor alpha, TNF-FR, and matrix metalloproteinases, play pivotal roles in cartilage destruction by disrupting chondrocyte function and degrading the extracellular matrix. The interplay of these factors ultimately leads to progressive loss of cartilage integrity, subchondral bone remodeling, and joint dysfunction. Understanding the molecular mechanisms behind joint damage is critical for developing targeted therapeutic interventions that not only alleviate symptoms, but also modify disease progression. Causes of inflammation in the joints. Joint inflammation is a complex pathological process driven by multiple biochemical and cellular mechanisms. The key mediators involved in this process include cytokines, proteases, neutrophils, and oxidative stress. Cytokines, the primary drivers of inflammatory signaling. Cytokines play a pivotal role in initiating and sustaining joint inflammation. These signaling proteins modulate immune responses and are central to inflammatory pathways. Among most critical cytokines implicated in joint pathology are tumor necrosis factor alpha, TNF-FR, and interleukin-1 beta, IL-1 beta. These pro-inflammatory mediators are highly concentrated in the synovial fluid of individuals with osteoarthritis and other inflammatory joint disorders, contributing to cartilage degradation and synovial inflammation. Proteases, enzymatic contributors to cartilage breakdown. Proteases, a class of enzymes responsible for protein degradation, are tightly regulated by cytokines within the joint environment. While some proteases exhibit anti-inflammatory properties, others promote inflammation and tissue destruction. In arthritic conditions, the balance shifts in favor of pro-inflammatory proteases, leading to the breakdown of articular cartilage and progressive joint damage. Neutrophils and the paradox of inflammatory defense. Neutrophils, a type of phagocytic immune cell, are recruited to inflame joints as part of the body's natural defense mechanism. While their primary role is to clear cellular debris and pathogens, Excessive neutrophil infiltration can exacerbate joint inflammation. The release of proteolytic enzymes and reactive oxygen species, ROS, by activated neutrophils can contribute to further synovial irritation and cartilage deterioration. Ischemia, reperfusion injury, and oxidative stress. Weight-bearing joints, such as the hips and knees, experience cyclical episodes of ischemia, restricted blood flow, and reperfusion, restored blood flow during physical activity. This physiological process can inadvertently contribute to oxidative stress within the joint. During ischemia, oxygen supply is limited, and upon reperfusion, a surge in oxygen availability triggers the production of free radicals. These highly reactive molecules overwhelm the antioxidant defense system, resulting in oxidative damage to the cartilage and synovial lining. The consequences of oxidative stress on joint integrity. When oxidative stress surpasses the body's ability to neutralize free radicals, it leads to structural damage within the joint. The degradation of cartilage and synovial tissue accelerates, outpacing the body's reparative capacity. Over time, this imbalance contributes to progressive joint deterioration, chronic inflammation, and functional impairment. Understanding these fundamental mechanisms is critical in developing targeted therapeutic strategies to mitigate joint inflammation, preserve cartilage integrity, and improve long-term joint health. Rheumatoid arthritis, a distinct pathophysiology. Rheumatoid arthritis, RA, is a systemic autoimmune disorder characterized by chronic inflammation targeting the synovial lining and cartilage of the joints, see Chapter 10. This dysregulated immune response initiates an unrestrained inflammatory cascade, leading to progressive joint destruction. A key pathological hallmark of RA is the excessive production of pro-inflammatory cytokines, particularly tumor necrosis factor alpha TNFR, which plays a central role in sustaining the inflammatory process. Clinical research has consistently demonstrated elevated TNFR levels in the plasma of RA patients. Additionally, oxidative stress is markedly amplified in RA, with studies indicating that free radical production is up to 5 times higher in affected individuals compared to those with healthy joints. This excessive oxidative burden perpetuates tissue damage and accelerates joint deterioration. The clinical manifestations of RA are often severe, with patients experiencing significant pain, joint deformity, and functional impairment. While oxidative stress is a shared mechanism between RA and osteoarthritis OA, the autoimmune-driven inflammation in RA distinguishes it from the degenerative pathology of OA. Understanding these underlying mechanisms is essential when evaluating conventional therapeutic strategies aimed at mitigating joint damage and preserving function in RA patients. Traditional treatment of arthritis, a physician's perspective. The conventional management of osteoarthritis, OA, and rheumatoid arthritis, RA, primarily relies on non-steroidal anti-inflammatory drugs, NSAIDs, and aspirin. These medications effectively mitigate inflammation and provide symptomatic relief. However, their long-term use is associated with significant adverse effects, most notably gastrointestinal GI complications. NSAID-induced upper GI bleeding accounts for over 100,000 hospital admissions and approximately 16,000 deaths annually in the United States. To address these concerns, pharmaceutical advancements led to the development of selective cyclooxygenase 2, COX-2 inhibitors. These agents were introduced with the expectation of reducing GI toxicity while maintaining anti-inflammatory efficacy. Although COX-2 inhibitors demonstrate a lower incidence of upper GI complications compared to traditional NSAIDs, they are not without risk. Adverse effects, including GI perforation and cardiovascular concerns, have tempered their initial enthusiasm and necessitate cautious prescribing. A fundamental limitation of NSAID therapy is that it primarily provides symptomatic relief rather than addressing the underlying pathophysiology of arthritis, namely oxidative stress and immune dysregulation. In patients with severe RA, treatment often escalates to more potent immunosuppressive and anti-inflammatory agents, such as corticosteroids, e.g. prednisone, disease-modifying anti-rheumatic drugs, DMARDs, like methotrexate and azathioprine, Imuran, and even gold therapy in select cases. While these interventions may slow disease progression, their potential toxicity underscores the need for a more targeted and holistic approach to arthritis management. Peggy's story, a case study in degenerative arthritis management. Peggy is a vibrant and determined woman whom I have had the privilege of knowing for several years. When I first met her, she was experiencing significant physical challenges due to severe degenerative arthritis in her right knee. The degree of deterioration was so advanced that her lower leg had developed an outward angulation, affecting not only her knee but also her right hip due to compensatory gait mechanics. Upon further discussion, Peggy shared the history of her condition. As a teenager, she sustained a skiing injury that resulted in substantial cartilage damage. Unfortunately, a subsequent re-injury exacerbated the condition, ultimately necessitating surgical intervention. The orthopedic surgeon was forced to remove a substantial portion of the severely damaged cartilage. Despite the best possible surgical outcome at the time, Peggy's physician cautioned her that she would likely experience progressive degenerative changes in her knee over time. To manage her condition post-surgery, Peggy was prescribed a knee brace to provide structural support, particularly during physical activity. Her specialist also recommended conservative management, including the use of non-steroidal anti-inflammatory drugs, NSAIDs, to control pain and inflammation. Given the lifespan of prosthetic knee replacements, typically ranging from 8 to 12 years, Peggy was advised to defer surgical intervention as long as possible. However, she faced a dilemma, balancing her current pain and mobility limitations against the potential benefits and drawbacks of early joint replacement. A proactive approach to joint health. Understanding the progressive nature of osteoarthritis, Peggy took a proactive stance in managing her condition. Rather than resigning herself to an imminent knee replacement, she sought alternative strategies to improve her quality of life and potentially delay surgical intervention. Her research into nutritional medicine led her to implement an evidence-based supplement regimen, which included a comprehensive antioxidant and mineral formulation, grapeseed extract for its anti-inflammatory and vascular support properties, essential fatty acids to mitigate inflammatory processes, calcium and magnesium to support musculoskeletal health, 2,000 milligrams of glucosamine sulfate daily to promote cartilage regeneration. In conjunction with her supplement regimen, Peggy adhered to structured physical therapy protocols, maintained a balanced diet, and engaged in controlled physical activity. Within months, she noticed tangible improvements, reduced reliance on NSAIDs, increased mobility, and enhanced overall function. Her newfound confidence even led her to return to skiing, an activity she had previously avoided due to her condition. Objective. Evidence of improvement. Perhaps the most compelling validation of Peggy's approach came during a follow-up evaluation with her physician. Comparative radiographic imaging revealed a remarkable finding. Her knee alignment had improved, and there was increased joint space between the femur and tibia, suggesting potential cartilage regeneration. These findings were consistent with Peggy's clinical improvements and provided objective evidence supporting the efficacy of her integrative approach to osteoarthritis management. Key takeaways: a model for managing degenerative joint disease. Peggy's case underscores the importance of a comprehensive and proactive approach to degenerative arthritis. Her success can be attributed to three critical factors. 1. Understanding the pathophysiology. Peggy took the initiative to educate herself on the cellular and molecular mechanisms underlying osteoarthritis, equipping herself with the knowledge needed to make informed decisions. 2. Exploring all available options. Rather than relying solely on conventional medical management, she explored adjunctive therapies with a strong scientific foundation. 3. Implementing a multifaceted strategy. By integrating targeted nutritional support, structured rehabilitation and lifestyle modifications, Peggy optimized her musculoskeletal health and delayed surgical intervention while maintaining an active lifestyle. Peggy's story serves as an inspiring example of how informed decision-making and a strategic multidisciplinary approach can yield significant improvements in musculoskeletal health. Her journey highlights the potential benefits of personalized, integrative management for individuals facing similar orthopedic challenges. Antioxidant supplements and arthritis management. Patients suffering from degenerative arthritis require a comprehensive and well-balanced regimen of antioxidants and essential minerals. Clinical evidence strongly suggests that individuals with arthritis often exhibit deficiencies in key antioxidants and supportive nutrients, including vitamin D, vitamin C, vitamin E, boron, and vitamin B3. Addressing these deficiencies through targeted supplementation can play a crucial role in mitigating oxidative stress and slowing disease progression. One such patient, Peggy, adhered to a supplementation regimen that included these essential nutrients along with an additional critical component, glucosamine sulfate. Glucosamine sulfate, a cornerstone of cartilage regeneration. Glucosamine is a fundamental nutrient required for cartilage synthesis. As an amino sugar, it serves as the primary building block of proteoglycans, molecules essential for cartilage elasticity and resilience. Unlike NSAIDs and aspirin, which merely alleviate pain, glucosamine actively contributes to cartilage repair and maintenance. Early clinical investigations demonstrated short-term symptomatic relief with glucosamine sulfate. However, initial physician reception remained lukewarm. The turning point came in 1999, when a landmark 3-year, randomized, placebo-controlled, double-blind clinical trial was presented at the annual meeting of the American College of Rheumatology. The study confirmed that glucosamine not only reduced pain and inflammation, but also halted cartilage deterioration. Most notably, the trial provided compelling evidence of cartilage regrowth, a finding corroborated by patient outcomes, including Peggy's case. Conversely, patients in the placebo group who relied on traditional NSAIDs continued to experience progressive joint degeneration. Subsequent research has reinforced the therapeutic benefits of glucosamine sulfate supplementation, particularly at dosages of 1,500 to 2,000 milligrams per day. Importantly, glucosamine sulfate is well tolerated, with an excellent safety profile and minimal adverse effects. A particularly noteworthy observation from clinical trials was that, even after discontinuation, symptom relief persisted for weeks or even months, unlike NSAIDs, which require continuous use and pose significant risks, including gastrointestinal bleeding, ulcer formation, and potential hepatotoxicity. Despite the widespread prescription of NSAIDs, their failure to halt or reverse cartilage damage raises critical concerns. Encouragingly, an increasing number of physicians are advocating for glucosamine sulfate as a viable alternative. In my own clinical practice, I routinely recommend glucosamine to arthritis patients. While NSAIDs may provide immediate symptom relief, I have found that patients who commit to glucosamine supplementation gradually reduce or even eliminate their NSAID use. Additionally, those who integrate antioxidants, essential minerals, omega-3 fatty acids, and grapeseed extract into their regimen experience even greater improvements. Orthopedic specialists have also recognized the value of glucosamine, acknowledging that delaying joint replacement surgeries is often in the patient's best interest. Chondroitin sulfate, an adjunctive therapy. Chondroitin sulfate is frequently combined with glucosamine sulfate to enhance therapeutic outcomes. As a key component of proteoglycans, chondroitin attracts water into the cartilage matrix, improving its pliability and shock-absorbing capacity. Deficiencies in chondroitin lead to drier, more fragile cartilage, exacerbating joint deterioration. While chondroitin sulfate shows promise, further large-scale, controlled studies are needed to definitively establish its efficacy. In my clinical experience, glucosamine sulfate remains the cornerstone of arthritis supplementation. However, I have observed positive responses in patients who incorporate methylsulfonylmethane, MSM, a natural anti-inflammatory compound, into their regimen. Future research should focus on elucidating the precise role of MSM and chondroitin in cartilage preservation and joint health. Conclusion: the integration of glucosamine sulfate, chondroitin sulfate, and a robust antioxidant regimen presents a compelling approach to managing degenerative arthritis. As evidence continues to mount in favor of these interventions, it is imperative for the medical community to consider these therapeutic options as part of a comprehensive, patient-centered treatment strategy. chondroitin sulfate and osteoarthritis management. Multiple clinical studies have reported symptomatic improvement in patients with osteoarthritis receiving supplemental chondroitin sulfate. However, many of these positive findings are associated with intravenous administration, raising concerns about the bioavailability and efficacy of orally ingested chondroitin. Some researchers postulate that chondroitin undergoes gastrointestinal degradation before absorption, followed by reassembly within the joint cartilage. Further rigorous studies are necessary to delineate the precise role of chondroitin sulfate in osteoarthritis management and to determine whether oral supplementation provides significant therapeutic benefits. Osteoporosis, a public health crisis. Osteoporosis remains a major public health concern in the United States, affecting over 25 million individuals and contributing to more than 1.2 million fractures annually. The economic burden of osteoporosis is estimated at approximately $14 billion per year. The clinical manifestations of osteoporosis include spontaneous compression fractures of the vertebrae and atraumatic hip fractures, which result in significant morbidity and diminished quality of life. I have personally encountered patients who sustained hip fractures merely while walking, without any preceding trauma. Historically, osteoporosis has been primarily managed with estrogen replacement therapy, ERT, and calcium supplementation. However, emerging evidence has raised concerns regarding the safety of long-term hormonal therapy. A 1997 review published in the New England Journal of Medicine highlighted an alarming 40% increase in breast cancer incidence among women receiving estrogen therapy for over 5 to 10 years. Despite pharmaceutical industry advocacy emphasizing the cardioprotective effects of hormone replacement therapy, HRT, subsequent large-scale studies such as the Heart and Estrogen Progestin Replacement Study, HERS, and the Women's Health Initiative, WHI, have failed to demonstrate cardiovascular benefits. Paradoxically, these studies indicated a potential increase in myocardial infarction risk, particularly within the first year of HRT initiation. Although HRT is known to modulate lipid profiles by lowering LDL cholesterol and raising HDL cholesterol, its pro-inflammatory effects may explain the observed increase in cardiovascular events. Specifically, studies have shown that synthetic HRT significantly elevates C-reactive protein, CRP, a marker of systemic inflammation and a stronger predictor of cardiovascular events than cholesterol levels. Given that cardiovascular disease is fundamentally an inflammatory process, these findings suggest that HRT may have deleterious effects despite its lipid-modifying properties. Given the risks associated with prolonged HRT use, including increased thromboembolic events and gallbladder disease, many clinicians now favor alternative pharmacologic interventions for osteoporosis. Agents such as bisphosphonates, e.g. alendronate, Fosamax, risedronate, Actonel, selective estrogen receptor modulators, e.g. raloxifene, Evista, and calcitonin have demonstrated efficacy in increasing bone mineral density and reducing fracture risk. Short-term clinical trials have shown that these agents significantly decrease both primary and recurrent fractures, making them a preferable choice over HRT in many cases. For a comprehensive discussion on the challenges faced by menopausal women, including osteoporosis management and hormonal therapy concerns, I recommend The Wisdom of Menopause by Dr. Christiane Northrup. Not just calcium, bones are living tissue. Bones are far more than a static framework of calcium deposits. They are dynamic, living tissues that undergo continuous remodeling. This process involves osteoblastic activity, bone formation, and osteoclastic activity, bone resorption, both of which rely on a complex interplay of biochemical reactions, micronutrients, and enzymatic systems. The role of nutrition in bone health. A diet deficient in essential nutrients significantly contributes to bone-related diseases such as osteoporosis. The modern Western diet, rich in processed foods, refined sugars, and saturated fats, lacks critical nutrients while simultaneously promoting excessive phosphorus intake through high meat and soda consumption. This imbalance impairs calcium absorption and negatively affects bone integrity. Essential nutrients for bone health. While calcium is fundamental to bone strength, it is not the sole determinant of skeletal health. A comprehensive approach incorporating multiple micronutrients is necessary to enhance bone density, maintain protein matrix integrity, and optimize the bone's self-repair mechanisms. Calcium. Calcium deficiency is a well-recognized contributor to osteoporosis. However, research indicates that only 25% of postmenopausal women experience skeletal calcium depletion. While calcium supplementation has been shown to increase bone mass in deficient individuals, it does not significantly impact those with adequate calcium levels. Moreover, calcium supplementation alone does not prevent osteoporosis, but may slow its progression and reduce fracture risk. Recommended intake: adults 800 to 500 milligrams per day, depending on dietary intake. Children 800 to 200 milligrams a day to enhance bone density pre-puberty. Optimal absorption occurs when calcium is taken with food and vitamin D. Magnesium. Magnesium plays a crucial role in bone formation by activating alkaline phosphatase, an enzyme essential for mineralization. Additionally, magnesium is required for the conversion of vitamin D to its active form, and deficiency may contribute to vitamin D resistance. Alarmingly, 80 to 85% of Americans consume inadequate dietary magnesium. Vitamin D is essential for calcium absorption. Although it is synthesized in the skin upon sun exposure, aging and limited sun exposure frequently result in deficiency. Oral intake from fortified foods is often inadequate due to impaired conversion into its biologically active form, vitamin D3. A Massachusetts General Hospital study found that 93% of hospitalized patients had vitamin D deficiency, even among those taking multivitamins. Given its critical role in calcium absorption, supplementation with 500 to 800 IU of vitamin D3 daily is recommended to mitigate osteoporosis risk. Vitamin K. Vitamin K facilitates the synthesis of osteocalcin, a key protein involved in bone remodeling. Clinical trials have demonstrated that vitamin K supplementation reduces urinary calcium loss by 18 to 50%, thereby enhancing calcium retention and bone integrity. Manganese. Manganese is essential for connective tissue synthesis in bone and cartilage. Processed foods significantly reduce dietary manganese intake, and studies indicate that osteoporotic women have manganese levels only 25% of those in healthy controls. Folic acid, vitamin B6, and vitamin B12. These B vitamins regulate homocysteine metabolism. Elevated homocysteine levels correlate with both cardiovascular disease and osteoporosis. Postmenopausal women experience a significant rise in homocysteine levels, which may contribute to increased bone fragility. Boron. Boron reduces urinary calcium excretion by approximately 40%, enhances magnesium levels, and lowers phosphorus concentrations. A daily intake of 3 milligrams boron has been found beneficial for bone health. Silicon. Silicon strengthens the connective tissue matrix and is particularly beneficial for patients with osteoporosis, as it facilitates new bone formation and enhances structural integrity. Zinc. Zinc is essential for vitamin D function and bone metabolism. Osteoporotic patients commonly exhibit reduced serum and bone zinc levels, highlighting its importance in maintaining bone density. Conclusion. A multifaceted nutritional approach is imperative for optimal bone health. While calcium is foundational, it is insufficient as a standalone intervention for osteoporosis prevention. Adequate intake of magnesium, vitamin D, vitamin K, manganese, B vitamins, boron, silicon, and zinc is essential for preserving bone mass, maintaining structural integrity, and minimizing fracture risk. A well-balanced diet, supplemented as necessary, remains the cornerstone of skeletal health throughout life. Prevention of osteoporosis, a comprehensive approach. Osteoporosis is a debilitating and painful condition, often leading to frequent fractures, particularly of the spine, and prolonged suffering. As a physician who has treated numerous patients with severe osteoporosis, I can affirm that prevention is far preferable to treatment. The multifactorial nature of osteoporosis. Osteoporosis is not simply the result of calcium and estrogen deficiency. Bone remodeling and maintenance require multiple nutrients, including magnesium, boron, silicon, and vitamin D. Additionally, oxidative stress has been identified as a contributing factor to decreased bone density. Research suggests that individuals with lower bone density often exhibit higher oxidative stress, highlighting the importance of antioxidant support. Essential strategies for prevention. 1. Targeted nutritional supplementation. I strongly encourage both men and women, preferably before the age of 40, to begin a regimen that includes high-quality antioxidant and mineral supplementation, adequate intake of calcium, magnesium, boron, and silicon, sufficient vitamin D levels for optimal calcium absorption. 2. Diet and lifestyle modifications. A balanced, nutrient-rich diet is essential for bone health. Foods rich in calcium, vitamin K2, and omega-3 fatty acids contribute significantly to bone strength. Avoiding excessive processed foods, sugar, and alcohol is equally crucial. 3. Weight-bearing and resistance exercises. Exercise plays a pivotal role in bone health. While walking benefits the lower extremities, it has limited impact on the spine and hips. A comprehensive program should include weight-bearing exercises, e.g. walking, jogging, dancing, resistance training, e.g. lifting weights, bodyweight exercises, functional movements that enhance balance and coordination, reducing fall risk. Managing osteopenia and early bone loss. When patients present with osteopenia, early-stage bone thinning, I prioritize lifestyle interventions before prescribing pharmacologic treatments. High-quality supplementation, improved diet, and a structured weight-bearing exercise regimen can often stabilize or even improve bone density. I closely monitor my patients with annual DEXA scans. If their bone density remains stable or improves, I continue their regimen without initiating medications. However, if bone loss progresses despite these measures, pharmacologic intervention with agents such as bisphosphonates, Fosamax, Actonel, selective estrogen receptor modulators, Evista, or calcitonin may be necessary. The role of cellular nutrition in prevention. Preventing osteoporosis and other degenerative bone conditions hinges on comprehensive cellular nutrition. While calcium and estrogen play roles in bone health, they are merely pieces of a broader puzzle. Strategic nutritional supplementation, coupled with a healthy lifestyle, forms the foundation for long-term skeletal integrity. By taking proactive steps early in life, individuals can significantly reduce their risk of osteoporosis, maintaining strong, resilient bones well into their later years. The key is a holistic approach, integrating targeted nutrition, exercise, and ongoing medical assessment to preserve bone health and overall well-being. Lung disease, a case study in severe asthma management. The young mother sleepily opened the door to her toddler's bedroom for a final check before bed. As she bent down to kiss her 2-year-old son, Christian, sheer terror overtook her. His skin was cyanotic and he was not breathing. Emergency medical services were summoned immediately, and as she initiated resuscitation efforts, paramedics arrived and took over. Christian's heart had stopped beating, requiring continued cardiopulmonary resuscitation, CPR, en route to the emergency department, ED. Only upon arrival did emergency physicians successfully restore spontaneous circulation and respiration. Christian was diagnosed with severe asthma and admitted for intensive monitoring and intervention. Initial management and chronic disease progression. Once stabilized, Christian was started on theophylline, a bronchodilator aimed at reducing airway constriction. His parents, though relieved by his survival, were alarmed at the gravity of his condition, unaware that asthma could present with such life-threatening severity. Determined to ensure strict adherence to treatment, they diligently managed his medication regimen upon discharge. Despite their efforts, Christian's childhood was profoundly impacted by his limited pulmonary reserve. Physical activity was curtailed, and escalating pharmacological interventions became necessary as his pulmonary function continued to decline. At age 15, a second catastrophic exacerbation occurred. Christian suffered respiratory arrest at home, necessitating another emergency resuscitation and hospitalization. This event marked a pivotal moment in his treatment, leading to the long-term administration of prednisone, a corticosteroid with significant systemic effects for the next 14 years. Declining pulmonary function and pharmacologic burden. By the age of 27, Christian's pulmonary function was critically compromised. Pulmonary function tests, PFTs, revealed that his large airways operated at only 17% of normal capacity, with his small airways performing at a mere 8%. Despite a complex regimen involving 9 different medications, his quality of life was severely restricted. Physical exertion was nearly impossible, and he lived in constant anticipation of another acute exacerbation. His reliance on inhalers and rescue medications was absolute, dictating every aspect of his daily life. Adjunctive nutritional support and functional improvement. Faced with diminishing therapeutic options, Christian opted to incorporate a structured micronutrient supplementation program into his regimen. He initiated a regimen of antioxidant and mineral supplementation, including vitamin C, calcium, magnesium, and grapeseed extract. Within 90 days, he noted subjective improvements in respiratory function, prompting further adherence to this nutritional strategy. Over the next 20 months, serial PFTs demonstrated sustained improvement in lung function, leading to the gradual withdrawal of prednisone under physician supervision. At the 2-year mark, Christian's large airway function had improved to 87% of normal, while small airway function increased to 56%. Concurrently, his medication burden was significantly reduced, tapering from 9 to 3 pharmacologic agents. Notably, his reliance on albuterol inhalers diminished dramatically, with usage dropping from monthly to semi-annual intervals. Conclusion. Christian's case underscores the complexity of severe treatment-resistant asthma and highlights the potential for adjunctive strategies in optimizing pulmonary function. While pharmacologic therapy remains the cornerstone of asthma management, emerging evidence suggests that targeted nutritional interventions may offer complementary benefits in selected cases. Christian's journey from respiratory failure to functional restoration serves as a compelling testament to the multifaceted approach required in the management of chronic lung disease. Lungs and air pollution, an expert perspective. When evaluating the primary sources of oxidative stress within the body, it is evident that the most significant and harmful contributors gain entry through the respiratory system. This exposure begins at the nasal passageways and extends to the delicate alveolar membranes of the lungs. Modern air quality is burdened with a complex mix of pollutants, including ozone, nitrogen oxides, fuel emissions, and secondhand smoke. With each breath, we inhale a cocktail of environmental toxins, often leading to respiratory distress and systemic oxidative damage. My first-hand experience with the impact of air pollution occurred during my journey to San Diego, where I was beginning my medical internship at Mercy Hospital. En route, I stopped to visit friends in Azusa, California. Having grown up in the clean air of South Dakota, I was unprepared for the dense smog that engulfed the region. The following morning, my friend invited me outside to appreciate the scenic San Bernardino Mountains. However, despite his enthusiasm, the mountains were obscured by a thick haze. As he inhaled deeply and extolled the freshness of the morning air, I attempted to do the same, only to be met with an uncontrollable coughing fit. Later that day, while playing golf, I found myself persistently coughing with each breath, ultimately forcing me to abandon my game by the 7th hole. Those who know my passion for golf understand the severity of the situation. Only a significant health impediment could compel me to leave the course mid-round. Locals in Azusa frequently jested about not trusting air they could not see. Yet, this casual humour belied a stark reality. The air pollution levels I encountered that day were classified merely as moderate. The long-term consequences of such environmental exposure are profound. Chronic inhalation of air pollutants triggers persistent oxidative stress within the respiratory tract, exacerbating inflammation and increasing susceptibility to pulmonary diseases such as chronic obstructive pulmonary disease, COPD, and asthma. When compounded with cigarette smoking, the most potent source of oxidative damage, the respiratory system endures relentless insult. Despite these challenges, the human body possesses an intricate and highly effective defense mechanism against airborne toxins. The mucociliary clearance system, alveolar macrophages, and antioxidant enzymes work in concert to mitigate damage and maintain pulmonary integrity. However, continuous exposure to environmental pollutants can overwhelm these protective systems, emphasizing the critical need for air quality regulation, smoking cessation, and proactive respiratory health measures. As physicians, we must advocate for both individual and public health initiatives to reduce exposure to air pollution and reinforce lung health. Encouraging patients to avoid high-pollution areas, utilize air filtration systems, and adopt antioxidant-rich diets can support their respiratory defenses. Moreover, robust policies aimed at reducing emissions and improving air quality are essential to safeguarding public health for future generations. The natural protection of the lung. The human respiratory system is continuously exposed to a wide array of airborne toxins, pathogens, and environmental pollutants. To counteract these threats, the lungs are equipped with a sophisticated and highly effective defense mechanism, beginning with the epithelial lining fluids, LFs. This fluid layer, rich in antioxidants and immune-modulating compounds, serves as the first line of defense against oxidative stress and microbial invasion. The respiratory tract from the nasal passages to the distal alveoli is coated with a protective mucus layer secreted by epithelial cells. This mucus barrier not only traps inhaled foreign particles, but also contains an array of antioxidants, such as vitamin C, vitamin E, and glutathione, that neutralize pro-oxidants, including ozone, nitrogen dioxide, and airborne hydrocarbons. Embedded within this mucus layer are ciliated epithelial cells, which generate a coordinated sweeping motion that propels trapped pollutants and pathogens toward the oropharynx for clearance, thereby preventing direct contact with the delicate lung parenchyma. Beyond its mechanical and chemical barriers, the respiratory system employs a dynamic immune response to further protect pulmonary structures. When pollutant exposure or microbial infiltration exceeds the neutralizing capacity of the LFs, a robust inflammatory immune response is activated. This response involves the recruitment of leukocytes, particularly neutrophils and macrophages, which release proteolytic enzymes and reactive oxygen species, ROS, to eliminate the invading pathogens. However, excessive or prolonged inflammation can disrupt pulmonary homeostasis, leading to epithelial injury and chronic inflammatory states. The balance between effective immune defense and controlled inflammation is critical for maintaining lung integrity. Unresolved or dysregulated inflammation can result in persistent epithelial damage, fibrosis, and progressive deterioration of pulmonary function. Conditions such as chronic obstructive pulmonary disease, COPD, asthma, and interstitial lung disease often stem from this maladaptive immune response, underscoring the importance of optimizing antioxidant defenses and minimizing chronic exposure to respiratory hazards. In summary, the lungs possess an intricate and highly effective protective system that relies on the interplay between mechanical clearance, antioxidant neutralization, and immune surveillance. Understanding these mechanisms not only highlights the remarkable resilience of the respiratory system, but also reinforces the importance of reducing environmental toxin exposure and supporting pulmonary health through optimal nutrition and lifestyle interventions. Asthma, a chronic inflammatory airway disease. Asthma is a chronic inflammatory condition of the airways characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. This persistent inflammation leads to significant fatigue and immune system compromise, making affected individuals, particularly children, more susceptible to recurrent infections and reduced energy levels compared to their peers with healthy pulmonary function. Evolution of understanding and treatment. When I began my clinical practice in the early 1970s, asthma was primarily considered a disorder of bronchospasm, an acute constriction of the bronchial smooth muscle leading to airway narrowing. The standard therapeutic approach involved bronchodilators such as theophylline and albuterol, which provided symptomatic relief by relaxing the airway muscles. In severe cases requiring hospitalization, systemic corticosteroids such as prednisone were employed to mitigate inflammation. However, subsequent research fundamentally shifted our understanding of asthma pathophysiology. By the late 20th century, asthma was increasingly recognized as a chronic inflammatory disease rather than merely a bronchospastic disorder. This paradigm shift led to a transition in treatment strategy, prioritizing anti-inflammatory agents including inhaled corticosteroids, ICS, and mast cell stabilizers like cromolyn sodium, Intol, as first-line therapies. These medications were designed to reduce airway inflammation and prevent exacerbations, rather than simply treating acute bronchoconstriction. The role of oxidative stress in asthma pathogenesis. Emerging research over the past 2 decades has further refined our understanding implicating oxidative stress as a central driver of asthma pathogenesis. Oxidative stress results from an imbalance between the production of reactive oxygen species, ROS, and the body's ability to neutralize them with antioxidants. This imbalance leads to persistent airway inflammation, hyperreactivity, and structural airway remodeling. Multiple studies have demonstrated that individuals with asthma exhibit significantly reduced levels of key antioxidants, including vitamin C, vitamin E, and beta-carotene in the epithelial lining fluid of the lungs, even during asymptomatic periods. Concurrently, these patients exhibit elevated biomarkers indicative of oxidative damage and inflammatory activation. Such findings suggest that oxidative stress not only contributes to the inflammatory cascade, but also exacerbates airway sensitivity and dysfunction. Rising prevalence and environmental influences. Asthma prevalence has surged in recent decades, particularly among children in industrialized nations. Pediatric physical education instructors have noted a dramatic increase in students requiring inhalers for routine activities. This alarming trend is mirrored in global epidemiological data, with reports from Europe and North America highlighting a marked rise in pediatric asthma severity. A major contributing factor appears to be heightened exposure to airborne pollutants, including particulate matter, ozone, and industrial toxins. These environmental stressors exacerbate oxidative stress within the airways, further intensifying inflammation and airway hyperreactivity. Additionally, dietary changes, reduced physical activity, and altered microbiome composition may contribute to the increasing burden of pediatric asthma. Future directions in asthma management. While current therapeutic strategies focus on reducing inflammation and alleviating bronchospasm, a significant gap remains in addressing the root cause, oxidative stress. Future research must explore novel antioxidant-based therapies and lifestyle interventions aimed at enhancing endogenous antioxidant defenses. By integrating oxidative stress mitigation strategies with conventional asthma management, we may improve long-term outcomes and reduce disease burden in affected individuals. In conclusion, asthma remains a complex and evolving disease that demands a multifaceted approach encompassing pharmacologic intervention, environmental modification, and novel therapeutic advancements targeting oxidative stress. Continued research and clinical innovation will be paramount in optimizing care for individuals with this chronic respiratory condition. Adam's story, a case study in pediatric asthma management and nutritional intervention. Adam was diagnosed with severe bronchial asthma at the age of 3, presenting with frequent exacerbations and significant limitations in physical activity. His parents, deeply concerned about his respiratory distress, sought medical intervention. He was prescribed a regimen that included multiple pharmacologic agents, notably albuterol via nebulization, to manage acute bronchospasms. However, he exhibited poor tolerance to these medications, experiencing side effects such as tachycardia and insomnia, which further compromised his quality of life. Despite adherence to standard asthma management protocols, Adam remained highly susceptible to recurrent respiratory infections and required frequent emergency department visits for acute exacerbations. His condition reached a critical juncture on his 4th birthday when he developed a febrile illness, progressing to pneumonia with a recorded temperature of 105 degrees Fahrenheit. A chest radiograph confirmed severe pneumonic consolidation alongside uncontrolled asthma. This life-threatening episode underscored the gravity of his condition and the persistent challenges in achieving optimal disease control. While conventional medical therapies were maximized, Adam's father explored adjunctive interventions that could potentially enhance his son's respiratory resilience. During early summer, Adam was introduced to a high-potency chewable multivitamin supplement. His initial physical capabilities were markedly limited. He hesitated to engage in routine activities, including swimming. However, within 60 days of incorporating the nutritional supplement into his regimen, Adam exhibited a striking improvement in endurance and pulmonary function. By the end of the summer, he was swimming unassisted across the pool, a feat previously inconceivable given his respiratory limitations. Over the following months, Adam's physical capacity continued to expand. He successfully engaged in competitive sports, initially participating in baseball and eventually qualifying for a travelling soccer team. Given the high aerobic demand of soccer, this achievement was particularly notable in the context of his asthmatic history. With improved pulmonary resilience, Adam was able to discontinue most of his daily medications, requiring his rescue inhaler only on rare occasions. Now, at 13 years old, Adam remains highly active, having transitioned from soccer to baseball while maintaining an exceptional level of physical performance. His parents attribute much of his transformation to continued nutritional support, which now includes grapeseed extract and additional vitamin C. From a clinical perspective, his case highlights the potential role of micronutrient supplementation in supporting immune function and overall respiratory health in pediatric asthma patients. While nutritional strategies should not replace conventional medical treatments, Adam's remarkable progress warrants further exploration into adjunctive therapies that may enhance disease management and patient outcomes. The profound improvement in Adam's quality of life serves as a compelling example of how a comprehensive, multifaceted approach to asthma management can yield transformative results. This case underscores the importance of individualized patient care, the exploration of complementary interventions, and the ongoing need for research into the intersection of nutrition and respiratory health. By asthma and nutrition, a complementary approach. As a physician, I have observed a common pattern among children presenting with severe allergic asthma or hay fever. By the time they arrive at my office, they have been enduring chronic inflammation in their respiratory tract for an extended period, often leading to a state of heightened allergic sensitivity. These children frequently exhibit telltale signs such as periorbital dark circles, persistent fatigue, and dependency on multiple medications to manage their symptoms. A critical component of my therapeutic approach involves addressing the underlying immune and antioxidant deficiencies. To this end, I initiate a regimen that includes a potent antioxidant and mineral supplement. Additionally, I incorporate essential fatty acids, typically from cold-pressed flaxseed oil or high-quality fish oil, due to their crucial role in the body's endogenous production of anti-inflammatory mediators, which assist in restoring immune homeostasis. Grapeseed extract is another key supplement in my protocol. Beyond its robust antioxidant properties, it also possesses anti-allergenic benefits. For pediatric patients with asthma, I recommend a dosage of 1 to 2 milligrams per pound of body weight. Furthermore, calcium and magnesium supplementation plays an essential role in my strategy. Magnesium, in particular, has demonstrated efficacy in relaxing bronchial smooth muscle, thereby mitigating bronchospasms and facilitating improved airway patency. I emphasize to parents that nutritional interventions require time to exert their full effect, typically a period of 6 months. When initiating therapy in the spring, I set expectations that notable improvements will be evident by the fall. My clinical experience has consistently demonstrated positive outcomes, ranging from modest symptomatic relief to remarkable transformations akin to those seen in cases like Adam's. Importantly, I never advocate for the discontinuation of prescribed asthma medications. Nutritional supplementation is not an alternative to conventional pharmacotherapy, but rather a complementary modality that enhances overall patient outcomes. My clinical practice has reinforced the remarkable responsiveness of children with severe allergies to targeted nutritional support. A particularly memorable case involved a 5-year-old girl who, prior to supplementation, required her inhaler for even minimal exertion, especially in cold weather. Her mother, accustomed to standing by with medication, was astonished when her daughter spent an entire morning sledding without experiencing an asthma attack. This phenomenon extends beyond pediatric patients. Adults with asthma can also achieve substantial benefits through nutritional interventions. My wife, Liz, who struggled with chronic fatigue and fibromyalgia, experienced debilitating asthma and hay fever that necessitated extensive pharmacologic management. Her symptoms were so severe that she could not enter a barn without donning a high-grade respiratory mask. However, following the initiation of a comprehensive supplement regimen, her respiratory symptoms significantly improved, allowing her to discontinue most medications and engage in activities she once prohibitive. The growing burden of environmental allergens and toxins places unprecedented stress on immune function, necessitating proactive measures. Despite compelling clinical evidence supporting the role of nutritional supplementation in asthma management, the medical community remains hesitant to integrate these strategies into standard care. This reluctance is perplexing, given the clear benefits observed in both pediatric and adult patients. As we continue to refine our understanding of asthma pathophysiology, it is imperative that we adopt a more integrative approach, one that acknowledges the indispensable role of nutritional medicine in optimizing patient health. Air pollution and chronic obstructive pulmonary disease. Few clinical scenarios are more distressing than witnessing patients, both young and old, struggle for each breath, many requiring continuous supplemental oxygen to sustain even minimal activity. This is the harsh reality for individuals with chronic obstructive pulmonary disease, COPD, an umbrella term encompassing emphysema, chronic bronchitis, and bronchiolitis. For these patients, even the simplest exertion can be profoundly limiting, diminishing not only their physical function, but also their overall quality of life. While not all individuals have the ability to control their environmental exposures, prevention remains paramount. The emphasis must shift from merely extending life expectancy to optimizing the quality of years lived. This necessitates proactive measures to protect and, when possible, restore pulmonary health. Among the most significant environmental contributors to COPD is air pollution. Extensive research has established that inhaled toxins, most notably cigarette smoke and airborne pollutants, trigger oxidative stress, a central mechanism driving COPD pathogenesis. The chronic inflammation induced by these inhaled irritants exacerbates oxidative damage, progressively impairing delicate pulmonary tissues. Over time, this results in a decline in lung function as the structural integrity of alveolar membranes deteriorates, ultimately compromising the efficient exchange of oxygen into the bloodstream. A concerted effort to mitigate air pollution and reduce exposure to harmful particulates is essential in curbing the burden of COPD. Interventions at both individual and policy levels are critical to preserving lung health and improving outcomes for those affected by this debilitating condition. Oxidative stress as a central mechanism in COPD pathogenesis. Chronic obstructive pulmonary disease, COPD, is a progressive respiratory condition with significant morbidity and mortality. While the primary risk factor remains cigarette smoking, growing evidence suggests that oxidative stress plays a pivotal role in disease onset and progression. W. McNee, in his seminal work published in Chest and presented at the Novartis Foundation Symposium, highlighted the extensive scientific evidence implicating oxidative stress as a fundamental driver of COPD. His research demonstrated that patients with COPD exhibit marked depletion of antioxidants in lung tissue, likely due to both increased oxidative burden and potential dietary deficiencies. McNee emphasized that antioxidants with high bioavailability, those efficiently utilized by pulmonary tissues, may serve as therapeutic agents. These compounds could mitigate oxidative injury while potentially modifying key pathogenic mechanisms underlying COPD progression. The challenge of traditional COPD management. Despite advances in pharmacologic management, COPD remains relatively resistant to conventional treatments, including corticosteroids. Smoking cessation remains the cornerstone of intervention. However, it is often one of the most challenging behavioral changes for patients. Clinically, achieving sustained smoking cessation is frequently more difficult than managing alcohol or opioid dependence. Yet the benefits are unequivocal. Halting further exposure to oxidative stressors is paramount in slowing disease progression. A guiding principle in disease management, particularly in conditions characterized by oxidative injury, is the necessity of minimizing exposure to oxidative stressors while concurrently enhancing the body's antioxidant defense systems. This principle extends beyond COPD to other chronic pulmonary conditions, including asthma and interstitial lung diseases. The role of nutritional intervention in COPD. For individuals with COPD who have never smoked or who have already ceased smoking, targeted nutritional supplementation may represent a crucial strategy in slowing disease progression. Emerging data suggests that an aggressive and early intervention approach, leveraging antioxidants and other micronutrients, may improve clinical outcomes. However, once significant structural lung damage has occurred, reversing functional decline becomes exceedingly difficult, as many former smokers with advanced COPD have discovered. In summary, recognizing oxidative stress as a primary pathophysiological mechanism in COPD underscores the need for a comprehensive therapeutic strategy. This should integrate smoking cessation, pharmacologic management, and nutritional support to optimize lung health and mitigate disease progression. Cystic fibrosis, pathophysiology, nutritional deficiencies, and therapeutic implications. Cystic fibrosis, CF, is a life-limiting autosomal recessive disorder characterized by exocrine gland dysfunction, leading to significant pulmonary and gastrointestinal morbidity. The hallmark of CF is chronic pulmonary infections and progressive respiratory failure, largely attributable to defective epithelial chloride transport, resulting in thickened mucus secretions and impaired mucociliary clearance. Additionally, CF is associated with severe digestive malabsorption due to pancreatic exocrine insufficiency, which prevents adequate enzymatic breakdown and absorption of essential nutrients. A key factor in the pathogenesis of CF is the persistent oxidative stress and chronic inflammation within the respiratory epithelium. Studies have demonstrated that CF patients exhibit profound deficiencies in critical antioxidants, including vitamin E, selenium, beta-carotene, and glutathione, an essential intracellular antioxidant that plays a crucial role in protecting epithelial cells from oxidative damage. The chronic inflammatory response inherent to CF rapidly depletes these antioxidants, further exacerbating lung damage and impairing immune function. Due to the malabsorption syndrome associated with CF, oral nutritional intake alone is often insufficient to restore optimal antioxidant levels, compounding disease progression. Emerging clinical evidence suggests that targeted nutritional interventions may help mitigate disease severity. Studies have shown that supplementation with pancreatic enzymes in conjunction with potent antioxidant therapy can significantly improve nutrient bioavailability. Notably, vitamin E and beta-carotene supplementation has been demonstrated to restore serum levels closer to physiological norms. Furthermore, antioxidant therapy has been associated with reduced oxidative stress markers, improved immune function, and enhanced resistance to chronic infections. Given the compelling evidence supporting the role of antioxidants in CF management, clinicians should consider a multifaceted therapeutic approach incorporating pancreatic enzyme replacement therapy and targeted nutritional supplementation. Optimizing antioxidant status may contribute to slowing disease progression, improving pulmonary function, and enhancing overall patient outcomes. While CF remains a formidable challenge in clinical medicine, advances in nutritional strategies offer promising adjunctive therapies to complement existing pharmacologic and supportive treatments. Charlie's story, a case of resilience in cystic fibrosis management. Charlie is an extraordinary young woman, vibrant, energetic, and seemingly the picture of health. Yet beneath this outward vitality, she engages in a relentless battle for survival. Born with cystic fibrosis CF, Charlie has defied significant statistical odds. Only 30% of individuals with this disease reach adulthood. At 23 years old, she stands as a testament to perseverance and medical resilience. Her mother, Colette, understands this battle intimately. Years earlier, Charlie's sister Lexi succumbed to CF-related complications following a bilateral lung transplant. The bond between the sisters was profound, shaped by shared experiences of chronic illness. Witnessing Lexi's struggle post-transplant reinforced Charlie's resolve to protect her own lung function and seek alternative strategies to combat the disease. At the age of 15, Charlie faced the immense loss of her sister. Concurrently, her own lung function had deteriorated to approximately 35%, prompting her physician to recommend placement on the lung transplant list. However, deeply impacted by Lexi's experience, Charlie opted to explore an aggressive regimen of antioxidant supplementation instead. Her decision was influenced by observations that Lexi had shown notable improvement with nutritional support post-transplant, albeit for a limited time. Charlie committed to a regimen of high-potency antioxidants, mineral supplementation, and targeted nutrients, including vitamin C, calcium, magnesium, and grapeseed extract. The results were remarkable. Her lung function improved to over 50%, exceeding medical expectations. Encouraged by this progress, Charlie resumed physical activity, even participating in sports. Despite episodic pulmonary infections necessitating hospitalizations for intravenous antibiotics, she maintained an active lifestyle, demonstrating a significant enhancement in her quality of life. Her choice to forego immediate lung transplantation in favor of an intensive nutritional intentional intervention marked a pivotal point in her disease management. Her journey provided hope to many within the CF community. However, the challenges of CF remain relentless. 3 years ago, Charlie experienced acute respiratory distress due to a pneumothorax, a complete collapse of one lung. Such a complication would be devastating for any patient, but Charlie approached this setback with characteristic determination. Through rehabilitation and continued adherence to her supplementation and medical therapy, she adapted to life with a single functional lung. A subsequent bout of pneumonia further compromised her respiratory capacity, reducing it to a critical 15%. Yet against all odds, Charlie once again defied expectations, recovering to a lung function of 35%. Her case underscores the dynamic interplay between advanced medical care and complementary nutritional strategies in chronic disease management. Charlie's story serves as a powerful example of resilience supported by an integrative approach combining evidence-based medicine with targeted nutritional support. Her ability to live fully, despite the constraints of a progressive pulmonary disease, highlights the potential of adjunctive therapies in optimizing patient outcomes. As physicians, we must acknowledge the increasing burden of environmental toxins on respiratory health. While the body possesses robust defense mechanisms, chronic exposure to oxidative stress necessitates proactive support. Patients with conditions such as asthma, allergies, and cystic fibrosis often exhibit remarkable improvements when their antioxidant and immune systems are reinforced through appropriate interventions. The cases presented here are both compelling and instructive. Is it possible that optimizing lung health through integrative medical strategies could be a critical adjunct in the management of chronic respiratory diseases? For many patients, this approach represents a transformative addition to conventional treatment paradigms. Neurodegenerative disease, a case study of Carl Moner. Carl Moner, an esteemed artist and actor, celebrated his 80th birthday in August 2001, a milestone acknowledged by art lovers worldwide, particularly in McAllen, Texas. Moner's career spanned decades, beginning in 1941 in Salzburg, Austria. Following a brief hiatus due to the Second World War, he resumed his career in film, starring in over 60 productions, including The Last Bridge and Reefify, both Cannes Film Festival Award winners. However, despite his cinematic success, Moner's greatest passion lay in painting. In 1988, Moner was diagnosed with Parkinson's disease, PD, a progressive neurodegenerative disorder characterized by the depletion of dopaminergic neurons in the substantia nigra. This condition presents with hallmark motor symptoms such as bradykinesia, rigidity, tremor, and postural instability. Despite these challenges, Moner remained dedicated to his art, producing an astonishing volume of work in the years following his diagnosis. Upon retrospective assessment, Moner recognized the presence of early prodromal symptoms, including rigidity and subtle motor impairment, which predated his formal diagnosis. As PD progressed, he experienced increasing difficulty with speech and ambulation. Traditional pharmacologic interventions initially provided symptomatic relief. However, by the mid-1990s, he became wheelchair dependent. In 1999, Moner sought adjunctive therapeutic options, leading to a consultation with me regarding nutritional interventions. A targeted regimen was introduced, including a potent antioxidant and mineral supplement, high-dose grapeseed extract, and coenzyme Q10, CoQ10. These compounds have been investigated for their neuroprotective properties, particularly their roles in mitigating oxidative stress and mitochondrial dysfunction, both key pathological mechanisms in PD. After approximately 6 months of adherence to this regimen, Mona reported improvement in lingual mobility and a modest recovery in ambulatory function. In response to these positive outcomes, his grapeseed extract dosage was increased. He subsequently experienced enhanced mobility, regaining the ability to rise from a seated position and walk short distances multiple times per day. Concurrently, he engaged in physical therapy, which further optimized his functional capacity. Despite the progressive nature of PD, Mona continued to paint prolifically, demonstrating the profound impact of therapeutic interventions that extend beyond conventional pharmacotherapy. His resilience and dedication culminated in significant accolades, including first-place awards at major national art competitions. Mona's story underscores the potential of integrative approaches in managing neurodegenerative diseases. While pharmacologic therapies remain the cornerstone of PD treatment, adjunctive interventions, including targeted nutritional support, structured physical therapy, and engagement in purposeful activities, may enhance quality of life and functional independence. His case exemplifies the potential of multimodal treatment strategies in addressing the complexities of PD, reinforcing the importance of a patient-centered approach in neurodegenerative disease management. The life and work of Carl Mona serve as a testament to both artistic brilliance and medical resilience. As clinicians, we must continue to explore innovative strategies that empower patients to maintain functional capacity and fulfillment despite the challenges imposed by neurodegenerative disorders. Oxidative stress and the brain, a physician's perspective. The human brain is a marvel of biological engineering, enabling complex cognition, memory, and sensory perception. The ability to recall vivid childhood experiences, recognize faces, and interpret the world through binocular vision is a testament to its intricate design. However, this vital organ is highly susceptible to oxidative stress, a process that has been implicated in the pathogenesis of numerous neurodegenerative disorders. Oxidative stress results from an imbalance between reactive oxygen species, ROS production, and the brain's ability to neutralize these free radicals through antioxidant defenses. Given the brain's high metabolic activity and its reliance on oxidative phosphorylation for energy production, it is particularly vulnerable to oxidative damage. Several key factors contribute to this susceptibility. High oxygen consumption. Despite constituting only 2% of body weight, the brain accounts for approximately 20% of total oxygen utilization. This high metabolic demand results in a significant generation of ROS. Neurotransmitter activity. The biochemical processes underlying neurotransmission inherently produce oxidative byproducts. For instance, dopamine metabolism generates hydrogen peroxide, which can lead to neurotoxicity if not adequately detoxified. Limited antioxidant reserves. Compared to other tissues, the brain has relatively lower levels of endogenous antioxidants, such as superoxide dismutase, catalase, and glutathione peroxidase, rendering it more susceptible to oxidative injury. Non-replicative neurons. The central nervous system consists predominantly of postmitotic neurons, meaning that once these cells are damaged, functional recovery is minimal or absent. Structural vulnerability. The brain's delicate microarchitecture, including its synaptic connections and myelinated pathways, can be easily disrupted by oxidative damage, leading to significant functional impairments even with localized injury. Oxidative stress is a common denominator in neurodegenerative diseases, including Alzheimer's disease, Parkinson's disease, amyotrophic lateral sclerosis, ALS, multiple sclerosis, and Huntington's disease. The progressive nature of these conditions underscores the urgency of implementing neuroprotective strategies to mitigate oxidative damage. Strategies for neuroprotection. Protecting the brain from oxidative stress is paramount not only for preventing neurodegenerative diseases, but also for maintaining cognitive function and mental acuity throughout life. Key approaches include antioxidant-rich diet, consumption of polyphenol-rich foods, e.g., berries, dark leafy greens, nuts and seeds, and omega-3 fatty acids has been shown to enhance neuronal resilience. Physical activity. Regular exercise stimulates neurotrophic factors and enhances mitochondrial function, reducing oxidative stress. Cognitive engagement. Intellectual stimulation through reading, problem solving, and social interaction promotes synaptic plasticity and cognitive reserve. Adequate sleep. Sleep facilitates glymphatic clearance of oxidative byproducts and supports neuronal repair mechanisms. Stress management. Chronic stress exacerbates oxidative burden. Mindfulness, meditation, and relaxation techniques contribute to neural homeostasis. In conclusion, the brain is an organ of unparalleled complexity, yet its function is inherently threatened by oxidative stress. Through targeted lifestyle interventions and ongoing research into antioxidant therapies, we can strive to preserve cognitive function and delay the onset of neurodegenerative disorders. As clinicians, our role is not only to treat, but to educate and empower individuals to take proactive steps in safeguarding their most valuable asset, their brain. Aging of the brain, the role of oxidative stress and neurodegeneration. Oxidative stress is a primary driver of the aging process, and its effects on the brain are particularly profound. Extensive scientific research has demonstrated that oxidative damage to mitochondria, the cellular energy centers, and to neuronal DNA can result in functional decline and eventual neuronal cell death. Given that neurons lack significant regenerative capacity, this cumulative damage leads to progressive cognitive impairment, a hallmark of brain aging. Clinically, this manifests as a decline in executive function, memory, and reasoning abilities, collectively termed cognitive decline. The aging brain represents the initial stage of neurodegeneration, which ultimately progresses to more severe conditions such as Alzheimer's disease and Parkinson's disease. These disorders are not sudden occurrences, but rather the result of decades-long accumulations of oxidative stress and neuronal damage. For instance, by the time Parkinson's disease is diagnosed, over 80% of dopaminergic neurons in the substantia nigra have already perished. Similarly, Alzheimer's dementia develops over decades, culminating in the hallmark plaques and tangles that disrupt cognitive function. Alzheimer's dementia. Alzheimer's dementia, affecting over 2 million Americans, is a leading cause of long-term care admissions. The disease profoundly impacts patients and families alike, as it progressively strips individuals of their cognitive faculties, recognition abilities, and independence. The tragedy of Alzheimer's lies not in its mortality rate, but in the prolonged deterioration of quality of life. A wealth of research implicates oxidative stress as a central factor in Alzheimer's pathogenesis. Studies from Case Western Reserve University have demonstrated that increasing oxidative stress with age correlates directly with disease progression. Autopsy findings consistently reveal depleted antioxidant levels and elevated oxidative markers in Alzheimer's patients. The therapeutic potential of antioxidants in slowing disease progression has gained increasing attention. A pivotal study published in the New England Journal of Medicine, April 1997, found that patients receiving 2,000 IU of vitamin E daily experienced a significant delay in disease progression, allowing them to remain in home care for an additional 2 to 3 years. Other antioxidants, including vitamin C and A, zinc, selenium, and bioflavonoids such as rutin, have shown promise in mitigating oxidative stress in Alzheimer's patients. Parkinson's disease, characterized by bradykinesia, rigidity, postural instability, and the hallmark pill-rolling tremor. Parkinson's disease is a progressive neurodegenerative disorder that has gained global awareness, partly due to high-profile individuals like Muhammad Ali. The disease results from oxidative damage-induced neuronal loss in the substantia nigra, leading to dopamine depletion and motor dysfunction. Multiple studies underscore the role of free radicals in Parkinson's pathogenesis. Antioxidant interventions have demonstrated efficacy in slowing disease progression. Patients receiving high doses of vitamin C and E were able to delay the need for pharmacological intervention by approximately 2 years. Additional research suggests that glutathione and N-acetyl-L-cysteine, potent antioxidants, may protect dopaminergic neurons from further oxidative damage. Multiple sclerosis. Unlike Alzheimer's and Parkinson's disease, multiple sclerosis, MS, primarily affects the myelin sheath rather than the neurons themselves. The destruction of myelin, a process known as demyelination, disrupts nerve conduction and leads to the characteristic symptoms of MS, which range from motor deficits to cognitive dysfunction. Emerging research highlights oxidative stress as a key player in MS pathology. A seminal 1992 study by Dr. S. M. Levine proposed that hydroxyl-free radicals within the myelin sheath contribute to disease progression. Subsequent research has confirmed that oxidative stress levels are significantly elevated during MS exacerbations compared to stable disease states. Unlike the irreversible neuronal loss seen in Alzheimer's and Parkinson's disease, MS may offer a greater potential for therapeutic intervention due to the regenerative capacity of myelin. Antioxidant therapy, particularly agents capable of crossing the blood-brain barrier, holds promise in reducing oxidative damage and potentially facilitating remyelination. Challenges and future directions. Despite promising findings, the full potential of antioxidant therapy in neurodegenerative disease remains underutilized due to several key barriers. Delayed diagnosis. By the time neurodegenerative diseases are clinically diagnosed, significant and often irreversible neuronal loss has already occurred. Early intervention strategies are critical. Blood-brain barrier penetration. Antioxidants must be capable of crossing the blood-brain barrier to exert meaningful neuroprotective effects. Current research must focus on optimizing formulations that enhance bioavailability within the central nervous system. Combination therapy approaches. Given the multifactorial nature of neurodegeneration, combining antioxidants with other neuroprotective strategies, including anti-inflammatory agents and mitochondrial support therapies, may yield synergistic benefits. Conclusion. The aging brain is particularly vulnerable to oxidative stress, which plays a central role in the development of neurodegenerative diseases such as Alzheimer's dementia, Parkinson's disease, and multiple sclerosis. While antioxidant therapy presents a promising avenue for neuroprotection, further research is required to refine strategies for early intervention, blood-brain barrier penetration, and combination therapy. As our understanding of neurodegeneration advances, the integration of targeted antioxidant therapies may become a cornerstone in preserving cognitive function and enhancing neurological resilience. The blood-brain barrier, a critical defense mechanism. The human brain requires a highly selective barrier to regulate the passage of substances between the bloodstream and neural tissue, ensuring the precise conditions necessary for complex neuronal signaling. This barrier, known as the blood-brain barrier, BBB, is formed by a specialized layer of tightly packed endothelial cells lining the cerebral capillaries. These endothelial cells possess unique, tight junctions that significantly restrict the passage of molecules, thereby preventing unregulated diffusion into the central nervous system, CNS. Despite this stringent control, the brain still requires essential nutrients for optimal function. Specialized transport proteins facilitate the entry of key substances such as glucose, amino acids, and certain fatty acids, ensuring that neurons receive the necessary metabolic support. At the same time, the BBB serves as a formidable defense, blocking harmful compounds, pathogens, and toxins from infiltrating the brain parenchyma. This selective permeability is akin to a medieval fortress, where access is strictly controlled, allowing only essential molecules to pass, while safeguarding against potential threats. The aging brain and blood-brain barrier dysfunction. A growing body of research suggests that age-related compromise of the BBB plays a significant role in the development of neurodegenerative diseases. A study conducted by the Neurology Department at Rabin Medical Center in Tel Aviv highlights the increasing burden of environmental toxins, including heavy metals, which contribute to oxidative stress within the CNS. Over time, the body's intrinsic antioxidant defense mechanisms may become insufficient to counteract this oxidative burden, resulting in cumulative neuronal damage and increased vulnerability to conditions such as Alzheimer's disease, Parkinson's disease, and other neurodegenerative disorders. Given these findings, researchers emphasize the potential role of exogenous antioxidants in mitigating oxidative stress and preserving BBB integrity. However, they caution that for antioxidants to exert their protective effects, they must possess the ability to effectively cross the BBB and reach neuronal tissue. Evaluating the role of key antioxidants. A critical consideration in neuroprotection is the selection of antioxidants with proven efficacy in penetrating the BBB. In the following sections, we will examine the most effective antioxidants, their mechanisms of action, and their ability to support brain health in the context of aging and neurodegenerative disease. The right antioxidants for brain health: vitamin E. Vitamin E, a fat-soluble antioxidant, plays a crucial role in protecting brain and peripheral nerve cells from oxidative stress. While it is capable of crossing the blood-brain barrier, its transport is somewhat inefficient, necessitating high-dose supplementation to achieve therapeutic levels within neural tissues. Although vitamin E is valuable in neuroprotection, its limited bioavailability in the brain suggests that other antioxidants may offer superior efficacy in this context. Vitamin C. Vitamin C is a powerful water-soluble antioxidant that accumulates at high concentrations in the brain and cerebrospinal fluid, often reaching levels tenfold higher than those in plasma. This ability to penetrate the blood-brain barrier effectively enhances its neuroprotective potential. Additionally, vitamin C plays a key role in regenerating other essential antioxidants such as vitamin E and glutathione, thereby amplifying its protective effects on neural cells. A study conducted by Dr. M.C. Morris demonstrated that supplementation with vitamin C and vitamin E in individuals over 65 years of age correlated with a reduced risk of Alzheimer's dementia. While this was a small-scale study, its findings underscore the need for larger, more comprehensive investigations to validate these observations.
Glutathione?
Glutathione is one of the most critical intracellular antioxidants within the brain, crucial for detoxification and oxidative stress mitigation. However, oral supplementation of glutathione presents challenges due to poor absorption and unclear transport across the blood-brain barrier. Studies investigating intravenous glutathione administration have reported improvements in patients with Parkinson's disease, but these findings remain preliminary and require further validation. Given these challenges, an optimal approach is to support endogenous glutathione synthesis through supplementation with its precursors, such as N-acetyl-L-cysteine, NEC, niacin, selenium, and vitamin B2. Furthermore, antioxidants like vitamin C, alpha-lipoic acid, and coenzyme Q10, CoQ10, aid in regenerating glutathione, ensuring its continued efficacy in cellular defense. Alpha-lipoic acid. Alpha-lipoic acid has garnered increasing recognition for its role as a potent antioxidant in neuroprotection. Its unique dual solubility, both fat and water-soluble, facilitates its ability to cross the blood-brain barrier efficiently. Beyond its direct antioxidant properties, alpha-lipoic acid is instrumental in regenerating vitamin C, vitamin E, glutathione, and CoQ10, reinforcing the overall antioxidant network. A notable function of alpha-lipoic acid is its ability to chelate toxic metals such as mercury, aluminum, cadmium, and lead, which are implicated in neurodegenerative disease pathogenesis. These heavy metals preferentially accumulate in the brain due to its lipid-rich composition, exacerbating oxidative stress and neuronal damage. Given these risks, reducing exposure to sources of heavy metals such as aluminum-based deodorants and cookware is advisable. Coenzyme Q10, CoQ10. CoQ10 is an essential component of the mitochondrial electron transport chain and a powerful antioxidant, particularly relevant in neurodegenerative disorders. Mitochondrial oxidative damage is a significant contributor to conditions such as Alzheimer's disease and Parkinson's disease. Unfortunately, CoQ10 levels decline with age, and its ability to cross the blood-brain barrier remains under investigation. Emerging research suggests that CoQ10 supplementation may offer neuroprotective benefits, but further large-scale clinical trials are necessary to substantiate its role in disease prevention and treatment.
Grapeseed extract?
Grapeseed extract is a highly potent antioxidant that readily crosses the blood-brain barrier, achieving substantial concentrations in neural tissues. This property, coupled with its robust free radical scavenging capacity, makes it an exceptional candidate for neuroprotection. Clinical observations suggest that grapeseed extract significantly benefits patients with neurodegenerative disorders, potentially outperforming other antioxidants in this domain. Given its promising efficacy, grapeseed extract warrants further research to fully elucidate its role in preventing and managing neurodegenerative conditions. Conclusion: antioxidants play a pivotal role in brain health and the prevention of neurodegenerative diseases. While vitamin E, vitamin C, glutathione, alpha-lipoic acid, CoQ10 and grapeseed extract each contribute unique benefits, their combined use may offer a synergistic approach to optimizing neuroprotection. Future research should focus on refining therapeutic strategies that leverage these antioxidants for maximal efficacy in maintaining cognitive function and preventing neurodegeneration. Protecting our most precious asset. The ability to reason and think is one of our most valuable faculties. Among my patients, the fear of losing cognitive function often surpasses even the fear of death. It is not uncommon for individuals to seek medical consultation after experiencing forgetfulness, misplacing keys, struggling to recall names, or momentarily losing their train of thought, concerned that these may be early signs of Alzheimer's dementia. As we age, this concern naturally arises. Personally, I do not fear death due to my faith, as I believe that to be absent from the body is to be present with the Lord. However, after more than 3 decades in medical practice, I have encountered many patients suffering from severe cognitive decline. Witnessing individuals with Alzheimer's dementia who no longer recognize their spouses or children, despite maintaining relatively good physical health, reinforces my concern about the potential of being mentally trapped within a functioning body. A brief walk through a nursing home provides a sobering perspective on the devastating impact of neurodegenerative diseases. From a medical standpoint, the key to cognitive preservation lies in optimizing our body's natural antioxidant defense system. Oxidative stress is a major culprit in neuronal damage, and since neurons are not easily replaced once lost, our approach must center on prevention and protection. To effectively reduce the risk of neurodegenerative conditions, 2 primary principles must be observed. Synergistic antioxidant therapy. Utilizing a combination of antioxidants that can work in concert and, crucially, cross the blood-brain barrier is essential. These compounds help neutralize oxidative damage and support overall brain health. Minimizing exposure to environmental toxins. Heavy metals and other neurotoxic substances in our environment contribute significantly to neuronal degeneration. A balanced approach requires both reducing toxic exposures and bolstering the body's intrinsic defense mechanisms. The comprehensive cellular nutrition program outlined in Chapter 115 is designed to support brain health and longevity. For those with a genetic predisposition to Alzheimer's or who have already noticed cognitive decline, additional nutritional support may be warranted. Specific antioxidants such as grapeseed extract are known for their ability to cross the blood-brain barrier and provide enhanced neuroprotection. Further details on these strategies are provided in Chapter 115. If cognitive health is a particular concern, I encourage you to explore these recommendations in depth and consult with a healthcare professional for a tailored approach to neuroprotection. Ross's story, a case study in multiple sclerosis management. Ross epitomizes the quintessential cowboy embodying the grit and determination of the Old West. His passion for horses is matched only by his skill in the competitive sport of team roping. For years, he was a dominant force in Western competitions, particularly excelling in South Dakota's jackpot events. However, his career took an unexpected turn when he began experiencing progressive numbness in his lower extremities. Initially dismissing the symptoms as transient, Ross became increasingly concerned as the numbness ascended from his legs to his hips and lower back. Recognizing the severity of his condition, he sought medical evaluation. After an extensive diagnostic workup, including MRI imaging and laboratory testing, Ross was diagnosed with multiple sclerosis, MS, a chronic autoimmune disorder affecting the central nervous system. Receiving an MS diagnosis can be life-altering, and for Ross, it was no exception. However, true to his resilient nature, he was unwilling to abandon his passion. Despite significant sensory deficits and impaired balance, he continued to compete, often riding without full proprioceptive awareness of his lower body. In hindsight, Ross acknowledges the risks he took, but at the time, maintaining his lifestyle was paramount. Integrative approach to MS management. It was during this period that Ross began exploring adjunctive therapies to complement his medical treatment. After attending one of my educational seminars on neuroprotection and nutritional support for MS, he initiated a structured supplement regimen tailored to enhance immune modulation and reduce oxidative stress. His regimen included potent antioxidants, essential fatty acids, coenzyme Q10, grapeseed extract, and a comprehensive blend of micronutrients designed to support neuronal integrity and mitochondrial function. Within months, Ross experienced a noticeable improvement in his neurological symptoms. The progression of numbness halted, and over time, sensation and strength in his legs began to return. 3 years later, Ross reports a complete resolution of his sensory deficits and a full restoration of his functional capacity. He has returned to competitive roping, performing at his previous level, much to the chagrin of his competitors. The role of neuroprotect in MS Ross's case is not an isolated phenomenon. Over the years, I've observed several MS patients who have achieved remarkable recoveries, including individuals who transition from wheelchair dependence to independent ambulation. While MS remains a complex, multifactorial disease with an unpredictable trajectory, research underscores the significance of oxidative stress in neurodegeneration. Protecting neurons from oxidative damage is a critical component of MS management. Current pharmacologic therapies, including disease-modifying agents such as interferon beta formulations, e.g. betaseron, Avonex, focus on modulating immune activity. While effective, these treatments are often associated with adverse effects. Nutritional strategies that incorporate bioavailable antioxidants and essential nutrients provide an additional, well-tolerated avenue for mitigating disease progression. Importantly, I always advise patients to maintain their prescribed treatments while integrating evidence-based nutritional support. Future directions in MS care. The medical community continues to explore the intricate relationship between oxidative stress, inflammation, and neurodegeneration. Although longitudinal studies are required to establish definitive clinical guidelines, existing literature supports the role of targeted nutritional interventions in neurological health. Given the limited regenerative capacity of neural tissue, proactive strategies to preserve neuronal function are essential. While further research is warranted, current evidence strongly suggests that optimizing antioxidant intake may serve as a valuable adjunct to conventional MS therapies. As healthcare providers, our goal is to empower patients with safe, effective strategies that enhance their quality of life. Ross's story serves as a compelling testament to the potential benefits of an integrative approach to MS management, one that prioritizes both conventional medical advancements and emerging nutritional science. Diabetes, a silent epidemic you cannot ignore. Warning, do not skip this chapter, even if you have never been diagnosed with diabetes. Diabetes mellitus has emerged as one of the most pervasive chronic diseases worldwide. Over the past 3.5 decades, industrialized nations have witnessed an alarming 5-fold increase in diabetes cases. In the United States alone, an estimated $150 billion is spent annually on diabetes care and its associated complications. Currently, approximately 60 million Americans have diabetes, yet shockingly, nearly half remain unaware of their condition. This is precisely why this chapter is essential reading, even for those who believe they are not diabetic. While diabetes itself is a significant health concern, its complications are even more formidable. 1/3 of all new cases of end-stage kidney disease are directly attributed to diabetes. Moreover, 4 out of 5 diabetic patients ultimately succumb to cardiovascular disease, whether from a heart attack, stroke, or peripheral vascular disease, all of which are exacerbated by diabetes. Consider this. Diabetes is the leading cause of non-traumatic limb amputations and remains one of the primary causes of blindness in the elderly. The rise of type 2 diabetes, a modern epidemic. Diabetes mellitus has reached epidemic proportions, with over 90% of cases classified as type 2 diabetes, formerly known as adult-onset diabetes. This sharp increase raises an urgent question: what has gone wrong? Type 1 diabetes, previously referred to as juvenile diabetes, typically manifests in children as an autoimmune disorder that destroys pancreatic insulin-producing cells. These patients require exogenous insulin for survival. However, our primary focus in this discussion is type 2 diabetes, the form that has escalated dramatically in prevalence. What is driving this surge, and more importantly, can you take steps to reduce your personal risk of developing diabetes? The answer is a resounding yes. A case study, Joe's wake-up call. Joe, a 41-year-old professional, visited my office for a routine annual physical. Feeling healthy with no complaints, he simply sought a comprehensive checkup after several years without one. As part of the examination, we conducted routine blood tests. Despite Joe's outward well-being, I was immediately alarmed when my lab technician presented his blood sample. It appeared unusually pink instead of red. Upon centrifugation, the upper portion of the sample was thick and creamy, indicating excessive fat content. The lab results were even more concerning. Joe's total cholesterol measured 250 milligrams per deciliters. His HDL, good cholesterol, was dangerously low at 31 milligrams per deciliter, and his triglyceride level was an astounding 1,208 milligrams per deciliters. To put this in perspective, optimal triglyceride levels should be under 150 milligrams per deciliter, and the triglyceride to HDL ratio should be below 2. Joe's ratio was a staggering 40, signaling a severe metabolic imbalance. Although his fasting blood glucose appeared normal, further evaluation confirmed that he had developed syndrome X, also known as metabolic syndrome, a harbinger of type 2 diabetes. Joe's case underscores an important reality. Diabetes and its precursors can develop silently without noticeable symptoms until serious complications arise. Understanding the early warning signs, risk factors, and preventative strategies is critical to mitigating this global health crisis. In the following sections, we will explore the mechanisms behind type 2 diabetes, identify key lifestyle modifications that can dramatically lower your risk, and provide actionable insights to safeguard your long-term health. Whether or not you have been diagnosed with diabetes, this knowledge could save your life or the life of someone you love. Syndrome X. Is it silently harming you? Like Joe, most people have never heard of Syndrome X, yet they absolutely should. The term was coined by Dr. Gerald Reaven, a distinguished physician and professor at Stanford University, to describe a cluster of metabolic disorders linked by a common underlying factor, insulin resistance. Based on extensive medical research, Dr. Reaven estimated that more than 80 million adults in the United States are affected by Syndrome X. Understanding this condition is critical as it significantly increases the risk of cardiovascular disease, diabetes, and other life-threatening conditions. Let's explore its root cause, insulin resistance, and how it may be quietly impacting your health.
What is insulin resistance?
The modern Western diet is often described as high carbohydrate and low fat, but in reality, it tends to be both high in carbohydrates and high in unhealthy fats. Over time, this dietary pattern can take a serious toll on the body, leading to a progressive decline in insulin sensitivity. Insulin, a hormone produced by the pancreas, plays a fundamental role in regulating blood sugar levels. Its primary function is to facilitate the uptake of glucose, sugar, into cells where it can be used for energy or stored as fat. However, when the body becomes resistant to insulin, blood sugar levels rise, prompting the pancreas to compensate by producing more insulin. Over time, this compensatory response leads to chronic hyperinsulinemia, excess insulin in the bloodstream, which, while initially effective at controlling blood sugar, has serious long-term consequences. The following conditions collectively define Syndrome X: chronic arterial inflammation, increasing the risk of heart attacks and strokes, hypertension, high blood pressure, elevated triglycerides, an independent risk factor for cardiovascular disease, lowered HDL good cholesterol, impairing heart health, increased LDL bad cholesterol, promoting arterial plaque buildup, enhanced blood clotting tendency, elevating stroke and heart attack risk, progressive weight gain, particularly around the abdomen, central obesity. When these risk factors combine, the likelihood of developing heart disease increases by up to 20-fold. Given that cardiovascular disease remains the leading cause of death in the industrialized world, ignoring the dangers of Syndrome X is simply not an option. The progression toward diabetes. In the early stages, the pancreas can maintain blood sugar control by overproducing insulin. However, after years, sometimes 10 to 20 years, the beta cells of the pancreas begin to fail. At this point, insulin production declines and blood sugar levels start to rise uncontrollably. Initially, this manifests as glucose intolerance prediabetes, a condition affecting more than 24 million Americans. If left unaddressed, full-blown type 2 diabetes usually develops within 1 to 2 years, further accelerating arterial damage and increasing the risk of severe complications, including blindness, kidney failure, and neuropathy. What causes insulin resistance? Several theories have been proposed regarding why we become insulin resistant over time, but the most compelling evidence points to dietary habits, specifically the overconsumption of high glycemic carbohydrates. While much of the focus in recent decades has been on reducing dietary fat, the real issue is excessive intake of refined carbohydrates. Many Americans are unaware that common staples such as white bread, white flour, pasta, rice, and potatoes break down into sugar even faster than table sugar itself. These foods cause rapid spikes in blood sugar, triggering a surge in insulin release. In contrast, low glycemic foods such as green beans, Brussels sprouts, tomatoes, apples, and oranges release sugar slowly, minimizing insulin spikes and helping to maintain metabolic stability. The typical high glycemic diet fuels a vicious cycle. 1. Blood sugar rises quickly after consuming refined carbohydrates. 2. Insulin surges to manage the glucose load. 3. Blood sugar drops sharply, triggering hunger and cravings. 4. More high glycemic foods are consumed, restarting the cycle. Over time, this repetitive stimulation of insulin secretion leads to insulin resistance, forcing the pancreas to work harder to keep blood sugar in check. The end result? Chronically elevated insulin levels, which are the primary driver of Syndrome X and its associated metabolic dysfunctions. The takeaway: a silent but deadly epidemic. Syndrome X is widespread, insidious, and dangerous, yet largely preventable. By understanding the role of insulin resistance and making targeted dietary changes, favoring low glycemic foods, reducing processed carbohydrates and incorporating healthier fats, we can take proactive steps to reverse metabolic dysfunction and significantly reduce the risk of diabetes, heart disease, and premature aging. Are you unknowingly living with Syndrome X? Addressing it now could be the key to a longer, healthier life. How to recognize and address Syndrome X, an expert perspective. Most physicians do not routinely measure fasting insulin levels in clinical practice, despite its critical role in detecting early insulin resistance. However, a simple yet effective indirect method can help determine whether a patient is developing Syndrome X, also known as metabolic syndrome or insulin resistance. This involves evaluating the patient's standard lipid profile, which includes total cholesterol, HDL cholesterol, the good cholesterol, LDL cholesterol, the bad cholesterol, and triglycerides. A well-known marker in lipid assessment is the total cholesterol to HDL ratio. However, a more predictive indicator of insulin resistance is the triglyceride to HDL ratio. If this ratio exceeds 2, it suggests the early development of Syndrome X. Additional warning signs include increasing blood pressure and central adiposity, particularly an expanding waist circumference, which further indicate advancing metabolic dysfunction. Applying the triglyceride to ratio in clinical practice. Consider the following example. A patient presents with a triglyceride level of 210 mg per liter and an HDL cholesterol level of 30 mg per liter. The calculated ratio is 7, 210/30, well above the threshold of 2, indicating early insulin resistance and the potential onset of Syndrome X. Early identification of insulin resistance is paramount because this is the stage where cardiovascular damage begins to accelerate. Physicians must be vigilant and proactive in recognizing these early metabolic shifts. The good news is that insulin resistance is reversible at this point, and intervention can prevent progression to full-blown diabetes. Rather than waiting for a formal diabetes diagnosis, physicians should implement timely lifestyle interventions to mitigate long-term complications. The role of lifestyle modification in reversing insulin resistance. A fundamental aspect of preventive medicine is educating patients on the significance of lifestyle modifications. While pharmacological interventions play a role in diabetes management, over-reliance on medication often detracts from addressing the root cause, insulin resistance. Physicians widely acknowledge that diet and exercise are beneficial, yet these interventions are frequently underemphasized in clinical encounters. The challenge lies in dedicating sufficient time to educate and motivate patients. While prescribing medication is straightforward, empowering patients with knowledge about nutrition and physical activity yields more sustainable results. Interestingly, pharmaceutical representatives themselves recognize the efficacy of dietary modification, particularly those incorporating high-fiber and low-glycemic foods. However, they often argue that patients are unlikely to adhere to such changes, necessitating medication. In clinical practice, this perspective does not always hold true. Many patients, when given the option and adequate support, prefer to implement lifestyle adjustments rather than initiate or escalate pharmacotherapy. With a physician's guidance and encouragement, a majority of patients demonstrate a willingness to make meaningful changes that improve their metabolic health. Case study: Joe's remarkable transformation. Joe, a patient concerned about his deteriorating lab results, took immediate action upon learning about his metabolic risk. Under physician supervision, he adopted a structured exercise regimen, a low glycemic diet, and targeted supplementation with antioxidants and essential minerals. After just 12 weeks, his laboratory results showed remarkable improvement. Total cholesterol decreased from 250 milliliters to 150 milligrams per deciliter. HDL cholesterol increased from 31 milligrams per point to 41 milligrams. Triglycerides plummeted to 2002 to 8 milligrams to 102 milligrams. The triglyceride to HDL ratio improved significantly from 40 to 2.5. Crucially, Joe achieved these results without pharmacological intervention. His success underscores the profound impact of lifestyle modifications in reversing metabolic syndrome and preventing diabetes. Conclusion: for patients exhibiting signs of Syndrome X, early intervention through lifestyle optimization can prevent its progression to diabetes and its associated complications. Physicians must prioritize patient education and support behavioral modifications as the first line of defense. By shifting the focus from medication dependency to sustainable lifestyle interventions, we can achieve superior metabolic outcomes and long-term health benefits. Next, we will examine the progression of diabetes and explore strategies to mitigate its systemic effects. Diagnosis and monitoring of diabetes mellitus. The most widely used screening test for diabetes mellitus is the fasting plasma glucose (FPG) test, which provides a direct assessment of baseline glycemic control. Additionally, physicians often utilize an oral glucose tolerance test, OGTT, in which a patient ingests a standardized glucose load, typically a 75 grams glucose solution, followed by a plasma glucose measurement 2 hours post-ingestion. Diagnostic criteria for diabetes are well established. A 2-hour post-glucose challenge value exceeding 200 mg/dL is diagnostic for diabetes mellitus, whereas normal glucose tolerance is defined by a 2-hour post-load glucose level of less than 140 mg/dL. Patients with intermediate values, typically a fasting glucose of 100 to 125 mg/dL or a 2-hour glucose between 140 to 199 mg/dL, are categorized as having impaired glucose tolerance (IGT) or prediabetes, which places them at an elevated risk for progression to overt diabetes and associated cardiovascular complications. Given that plasma glucose levels provide only a snapshot of glycemic control at a single time point, a more comprehensive assessment is achieved through the hemoglobin A1C (HbA1c) test. This assay reflects average blood glucose levels over the preceding 8 to 12 weeks, corresponding to the lifespan of erythrocytes to 120 days. The reference range for HbA1c in most laboratories is 4.0 to 5.7%, with values between 5.7% and 6.4%, indicating an increased risk of diabetes, and values 6.5% confirming a diagnosis of diabetes. For patients with diabetes, maintaining an HbA1c level below 6.5% is critical for reducing long-term complications. Studies indicate that patients who achieve this level of glycemic control have a complication rate below 3%. However, those with HbA1c levels exceeding 9% face a significantly increased risk, up to 60% of microvascular and macrovascular complications, including retinopathy, nephropathy, neuropathy, and cardiovascular disease. Alarmingly, national data suggests that the average treated diabetic in the United States has an HbA1c of approximately 9.2%, highlighting significant gaps in effective diabetes management. Of even greater concern is the high prevalence of advanced cardiovascular disease at the time of diabetes diagnosis. More than 60% of newly diagnosed diabetic patients already exhibit significant atherosclerotic burden, emphasizing the need for early intervention. Insulin resistance, a hallmark of metabolic syndrome, syndrome X, predisposes individuals to accelerated atherogenesis, often preceding clinical diabetes by several years. Early recognition and aggressive management of metabolic syndrome through lifestyle interventions, including dietary modification, weight reduction, and increased physical activity, are essential to mitigating long-term cardiovascular risk and delaying disease progression. Effective diabetes management necessitates a proactive, multifaceted approach that extends beyond glycemic control to encompass cardiovascular risk reduction and metabolic optimization. Physicians must remain vigilant in identifying at-risk individuals early and implementing targeted interventions to prevent the cascade of complications associated with this progressive disease. Obesity and insulin resistance, understanding the true culprit. The prevailing narrative in both the media and mainstream medicine suggests that obesity is the driving force behind the rising epidemic of type 2 diabetes. However, this perspective misrepresents the underlying pathophysiology. In reality, the sequence of events is reversed. Insulin resistance, often referred to as syndrome X, is the primary instigator, leading to the development of central obesity rather than the other way around. Obesity is not the cause, but rather a hallmark manifestation of this metabolic disorder. The significance of central obesity. Not all weight gain is created equal. The pattern of fat distribution is a critical determinant of metabolic risk. Individuals with a predominantly lower body fat distribution, pear-shaped, may have excess weight, but do not necessarily exhibit the same metabolic dysfunction as those with central obesity. The latter, characterized by excessive fat accumulation around the abdomen, apple-shaped, is strongly linked to insulin resistance, systemic inflammation, and an increased risk of cardiovascular disease and diabetes. Unexplained weight gain, a red flag for insulin resistance. Many of my patients, often in their late 20s or early 30s, present with a perplexing complaint. They are gaining significant weight despite no discernible changes in their dietary habits or physical activity levels. They report a rapid increase of 30 to 40 pounds over just a few years. This pattern of weight gain is frequently indicative of underlying insulin resistance. A common yet counterproductive approach many individuals take is adopting a high-carbohydrate, low-fat diet, believing it to be the key to weight loss. Unfortunately, such dietary choices exacerbate insulin resistance, making weight loss exceedingly difficult. These patients often find themselves frustrated, unable to achieve meaningful results despite adhering to conventional weight loss strategies. The root issue is not excess weight per se, but rather the metabolic dysfunction driving it.
To correct insulin resistance.
The key to sustainable weight loss. Effective management of insulin resistance requires a comprehensive, science-based approach. I advise my patients to shift their focus away from calorie restriction and instead prioritize metabolic health. This includes adopting a balanced macronutrient approach with low glycemic carbohydrates, high-quality protein, and healthy fats. Engaging in regular moderate exercise, which improves insulin sensitivity and facilitates fat metabolism. Incorporating targeted nutritional interventions to support cellular metabolism and reduce systemic inflammation. Once insulin resistance is addressed, patients often experience a gradual and sustainable weight loss, often without the excessive effort they previously struggled with. They report increased energy levels, improved mental clarity, and an overall enhancement in well-being. It is essential to recognize that weight loss itself is not the ultimate goal. Correcting insulin resistance is. A well-structured lifestyle modification, rather than transient fad diets, is the foundation for long-term metabolic health. Over the course of a structured 12-week program, I guide my patients in implementing these principles into their daily routines, ensuring they achieve lasting success. By shifting the focus from weight loss to metabolic restoration, we can address the true cause of obesity and its associated complications, paving the way for improved health and longevity. Expert perspective on treating diabetes, addressing the root cause, insulin resistance. All physicians recognize that the initial approach to managing diabetes should prioritize lifestyle modifications. Encouraging patients to adopt healthier habits can significantly impact disease progression. However, in clinical practice, many healthcare providers merely acknowledge lifestyle changes without actively reinforcing them, instead relying heavily on pharmacologic interventions. To achieve meaningful progress in both reducing the incidence of diabetes and improving glycemic control in existing patients, two fundamental shifts must occur. First, a greater emphasis must be placed on addressing insulin resistance, the primary pathophysiologic mechanism underlying type 2 diabetes mellitus, rather than focusing solely on lowering blood glucose levels. Second, we must adopt a more proactive stance in promoting lifestyle interventions that enhance insulin sensitivity. Pharmacologic treatment should be reserved as a secondary measure when lifestyle modifications prove insufficient. A misguided focus on hyperglycemia. A common shortcoming in diabetes management is the excessive focus on glycemic control without addressing the broader metabolic dysfunction. As Dr. James O'Keefe articulated in a review published in the Mayo Clinic Proceedings, therapeutic efforts in patients with diabetes have focused predominantly on normalizing increased blood sugar levels while often ignoring many of these other modifiable risks, which are caused by the underlying insulin resistance. This misplaced emphasis on glycemic targets rather than insulin resistance may explain why cardiovascular disease remains the leading cause of mortality among diabetics, with approximately 80% of patients succumbing to cardiovascular complications. By shifting the focus to improving insulin sensitivity through dietary modifications, physical activity and weight management, we can better mitigate the long-term risks associated with type 2 diabetes mellitus. Implementing an effective treatment strategy, a robust diabetes management plan should incorporate the following key elements. Dietary interventions. A whole food, low glycemic diet rich in fiber, healthy fats, and lean protein can significantly enhance insulin sensitivity. Physical activity. Engaging in regular aerobic and resistance exercise improves glucose metabolism and reduces insulin resistance. Weight optimization. Even a modest weight reduction of 5 to 10% can lead to substantial improvements in glycemic control and cardiovascular outcomes. Sleep and stress management. Poor sleep and chronic stress exacerbate insulin resistance and should be addressed as part of a comprehensive treatment approach. Only when these strategies have been maximized and remain insufficient should pharmacologic intervention be considered. Even then, medications should be selected with a preference for those that target insulin resistance, such as metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. By reframing diabetes management to prioritize insulin resistance over hyperglycemia, physicians can play a pivotal role in improving long-term outcomes and reducing the burden of diabetes-related complications. Lifestyle changes. A targeted approach to insulin resistance. Many patients fail to recognize how straightforward lifestyle modifications can be in addressing the core issue underlying both diabetes mellitus and insulin resistance. The essential interventions, moderate physical activity, dietary adjustments to prevent blood sugar spikes, and strategic nutritional supplementation to enhance insulin sensitivity, form a powerful trifecta for metabolic health. When implemented together As illustrated in Joe's case, the outcomes can be remarkable. Let's examine each component of this targeted approach to insulin resistance. Diet. Rethinking conventional guidelines. A critical misstep in diabetes management is the persistent adherence to outdated dietary recommendations. Given that cardiovascular disease remains the leading cause of mortality in diabetics, the American Diabetes Association, ADA, has historically emphasized low-fat dietary patterns. As a result, many practitioners and dietitians continue to advocate high-carbohydrate, low-fat diets. Despite decades of compliance with these guidelines, cardiovascular mortality among diabetics remains unchanged. 80% of diabetic patients succumbed to cardiovascular disease in the 1970s, and that figure remains the same today. This stagnant outcome should prompt a reassessment of our dietary strategies. The fundamental issue in diabetes is insulin resistance, which necessitates a shift in dietary priorities. Carbohydrates play a central role in this dysfunction, yet many dietitians still promote the outdated notion that a carbohydrate is a carbohydrate, disregarding the glycemic index, GI, a critical determinant of how rapidly a carbohydrate converts to glucose in the bloodstream. Evidence consistently demonstrates that carbohydrates differ significantly in their metabolic impact. Low glycemic carbohydrates such as beans, cauliflower, Brussels sprouts, and apples release glucose gradually, mitigating postprandial blood sugar spikes. When these are consumed alongside high-quality proteins and healthy fats, glycemic control improves significantly, reducing the need for pharmacologic interventions. Dr. Walter C. Willett, a leading authority in nutrition and preventive medicine at Harvard Medical School, has advocated for a paradigm shift in dietary recommendations. In Eat, Drink, and Be Healthy, he proposes revising the traditional food pyramid, placing low glycemic carbohydrates at its foundation while relegating high glycemic foods such as white bread, white flour, pasta, rice, and potatoes to the top alongside refined sugars. While most individuals recognize that sweets are detrimental to diabetes management, fewer appreciate that high glycemic carbohydrates can elevate blood glucose levels more aggressively than candy. When patients adopt a diet centered on low glycemic carbohydrates, combined with quality protein and beneficial fats, they often experience dramatic improvements in glycemic control and marked enhancement in insulin sensitivity. By prioritizing these targeted lifestyle interventions, we can shift the trajectory of diabetes management from reactive pharmacologic treatment to proactive metabolic optimization. Basic diet instructions. A well-balanced diet is fundamental for maintaining stable blood glucose levels, improving metabolic function, and supporting overall health. By strategically combining appropriate fats, proteins, and carbohydrates in each meal or snack, we can prevent dangerous fluctuations in blood sugar that contribute to metabolic disorders. Optimal sources of protein and fats. The most beneficial proteins and fats are derived from plant-based sources. Avocados, olive oil, nuts, legumes, and soy-based products provide high-quality proteins while supplying healthy fats that actively reduce cholesterol levels. These sources also contain essential micronutrients and fiber that enhance cardiovascular and metabolic health. Preferred carbohydrates. The most effective carbohydrates for maintaining metabolic stability come from whole, unprocessed fruits and vegetables. Unlike refined products, whole foods maintain fiber content, which slows glucose absorption and minimizes insulin spikes. For this reason, whole grains should be prioritized over processed grains, making them a cornerstone of a healthy diet, particularly for individuals managing diabetes. Secondary protein and fat sources. Cold water fish, including mackerel, tuna, salmon, and sardines, provide high-quality protein while delivering essential omega-3 fatty acids. These polyunsaturated fats are known for their anti-inflammatory properties and their role in reducing cholesterol and triglyceride levels. Poultry is another viable protein option, as the fat content is primarily external rather than marbled within the muscle. By removing the skin, one can obtain a lean protein source that supports overall health. Foods to limit or avoid. Red meats and full-fat dairy products contribute saturated fats, which may exacerbate insulin resistance and cardiovascular risk. If consumed, lean cuts of red meat should be selected, and dairy intake should be restricted to low-fat or fat-free options such as cottage cheese and skim milk. Eggs should ideally be sourced from pasture-raised chickens as they contain higher levels of omega-3 fatty acids. Trans fats, particularly those found in partially hydrogenated oils, pose significant health risks. These rancid fats contribute to systemic inflammation and should be completely avoided. Reading ingredient labels carefully can help in identifying and eliminating such harmful additives from the diet. Dietary ratios and macronutrient balance. For optimal metabolic function, I often recommend a macronutrient distribution of 50% carbohydrates, 25% protein, and 25% fat per meal. While other balanced dietary approaches such as the 40-30-30 plan have demonstrated efficacy, the key principle remains consistent, ensuring a well-balanced intake of macronutrients that stabilizes blood glucose and enhances metabolic function. This approach is distinct from high-protein diets such as the Atkins regimen. Instead, it promotes sustainable long-term health benefits. Proper dietary habits in combination with regular physical activity and adequate micronutrient intake have the potential to significantly reduce the prevalence of diabetes and metabolic disorders. The role of exercise. Regular physical activity plays an indispensable role in managing insulin sensitivity and metabolic health. Clinical research consistently demonstrates that exercise enhances the body's ability to utilize insulin efficiently. As such, it is an essential component of lifestyle modifications for individuals with diabetes or metabolic syndrome. A well-rounded exercise regimen should include both aerobic activities and resistance training performed at least 3 to 5 times per week. Even moderate intensity activities, such as brisk walking for 30 to 40 minutes 3 times per week, can yield profound metabolic benefits. Nutritional supplementation. Emerging research indicates that individuals with insulin resistance or prediabetes exhibit increased oxidative stress and impaired antioxidant defense mechanisms. Additionally, deficiencies in key micronutrients can exacerbate metabolic dysfunction. Supplementing with specific vitamins and minerals can mitigate these effects and enhance overall metabolic stability. Key micronutrients and their recommended dosages for individuals at risk of or managing diabetes include chromium, 300 milligrams per day, essential for glucose metabolism and insulin function. Approximately 90% of the US population is deficient in chromium, making supplementation critical for improving insulin sensitivity. Vitamin E, a potent antioxidant that also appears to improve insulin resistance. Studies suggest that individuals with low vitamin E levels are at significantly greater risk of developing type 2 diabetes. Magnesium, 400 to 500 milligrams per day. Magnesium deficiency is prevalent among individuals with both type 1 and type 2 diabetes and is associated with increased complications, including retinopathy. Addressing this deficiency can enhance insulin function and overall metabolic health. Vanadium, 50 to 100 milligrams per day, an under-recognized mineral that has been shown to enhance insulin sensitivity when supplemented appropriately. Despite the challenges of diagnosing magnesium deficiency through standard serum tests, addressing potential deficiencies through targeted supplementation can yield substantial improvements in metabolic parameters. Conclusion: the integration of a balanced diet, structured exercise, and strategic supplementation can dramatically improve insulin sensitivity, reduce inflammation, and mitigate the complications associated with metabolic disorders. In my clinical experience, patients who commit to these lifestyle modifications often achieve remarkable improvements in health outcomes. This holistic approach not only addresses diabetes management, but also fosters long-term wellness and disease prevention. Matt's story, a case of reversible diabetes. Matt, a 23-year-old aspiring Peace Corps volunteer, presented to my clinic for his required physical examination. During our consultation, he reported excessive thirst and frequent urination, particularly nocturnally. Given his age, he was understandably perplexed by these symptoms. Recognizing the potential significance of his complaints, I promptly ordered a fasting blood glucose test. The results were alarming. His blood sugar measured 590 milligrams per deciliter, an unequivocally dangerous level. Immediate hospitalization was warranted and he was started on an intravenous insulin infusion. Despite aggressive therapy, his glucose levels remained refractory to standard treatment, necessitating consultation with an endocrinologist. Even under specialist care, Matt required extraordinarily high insulin doses, at one point reaching 90 units twice daily, a tenfold increase over standard therapeutic regimens. Once stabilized and discharged, I emphasized the critical role of lifestyle modifications in managing his condition. Matt committed to a regimen of structured physical activity, dietary adjustments aimed at mitigating postprandial glycemic spikes, and targeted supplementation with minerals and antioxidants. His adherence was remarkable. Over subsequent months, his insulin requirements steadily declined, correlating with progressive weight loss and improved metabolic markers. At his 4-month follow-up, Matt claimed he had discontinued insulin entirely, maintaining normal glycemia. Skeptical, I conducted a comprehensive evaluation, including fasting and postprandial glucose assessments. His results were striking. A fasting glucose of 84 milligrams per L, a post-challenge glucose of 88 milligrams per L, and an HbA1c of 5.4%, all within non-diabetic parameters. By clinical criteria, Matt was no longer diabetic. This presented an unusual challenge, drafting a medical clearance letter for the Peace Corps. I detailed his prior insulin dependence juxtaposed with his current euglycemic state, uncertain whether such a dramatic reversal would jeopardize his candidacy. The Peace Corps, to their credit, performed independent verification and confirmed his remission. Matt was granted clearance and subsequently served 2 years in Africa. During his tenure, the organization facilitated biannual medical evaluations to monitor his glycemic control. Despite dietary limitations, he maintained stability by adhering to whole, unprocessed foods. His commitment yielded profound results. On his return to my clinic, he had sustained normoglycemia and achieved a weight reduction from 315 to 205 pounds. He attributed his continued success to the fundamental principles established at the outset of his journey. Clinical implications. Matt's case exemplifies the potential for diabetes remission through aggressive lifestyle intervention. While not all cases will mirror his trajectory, his success underscores the importance of addressing insulin resistance at its root, rather than merely managing hyperglycemia pharmacologically. Diabetes mellitus, particularly type 2, is proliferating at epidemic rates. Despite extensive pharmaceutical advancements, outcomes remain suboptimal. Clinicians must shift focus towards early detection of insulin resistance, manifesting as hypertriglyceridemia, reduced HDL cholesterol, hypertension, or central adiposity, and implement strategies that prioritize metabolic correction over symptom management. For patients currently managing diabetes, the potential for significant improvement exists. Optimal glycemic control, defined by an HbA1c target of 6.5%, is difficult to achieve through medication alone. A structured approach emphasizing dietary modifications, physical activity, and vigilant glucose monitoring can lead to medication tapering and, in select cases, remission. Patients should collaborate closely with their healthcare providers to tailor interventions and adjust treatment regimens accordingly. Matt's story is a compelling reminder. With the right interventions, even seemingly entrenched disease states can be reversed. The key lies not just in treating diabetes, but in fundamentally addressing the underlying metabolic dysfunction driving it. Chronic fatigue and fibromyalgia, a physician's perspective. I'm just so tired all the time. It is difficult for me to concentrate. I can't remember the last time I felt good. In fact, I'm having a hard time remembering a lot of things. I know something is wrong with me. I don't have any energy and I seem to catch every bug that comes along. I need help, but I don't know where to start. Maybe it's my thyroid. My family has a history of thyroid problems. If these words sound familiar, you are not alone. As a physician with decades of experience treating patients with chronic fatigue and fibromyalgia, I have encountered countless individuals who present with similar complaints. Their frustration is palpable. After numerous consultations and extensive testing, they are often left without clear answers, let alone effective solutions.
The diagnostic challenge!
When patients present with persistent fatigue, physicians typically begin with a thorough clinical evaluation. This process includes a detailed medical history, a comprehensive physical examination, and extensive laboratory testing to rule out underlying conditions such as hypothyroidism, diabetes, anemia, or autoimmune disorders. Occasionally, we identify an underlying medical cause. However, in the vast majority of cases, no definitive pathology is found, leaving both physician and patient searching for answers. When no clear diagnosis emerges, at this juncture, medical practitioners may shift their focus to psychological factors, exploring potential contributors such as chronic stress, anxiety, or depression. While these conditions can undoubtedly exacerbate fatigue, they do not account for all cases. Unfortunately, when no clear pathology is identified, patients may feel dismissed or even stigmatized. The implicit message, sometimes verbalized, sometimes merely inferred, is that their symptoms are psychosomatic. This response, while not intentionally dismissive, is deeply frustrating for patients who know their fatigue is real and life-altering. Many leave medical consultations feeling invalidated, with no clear plan for improvement. The reality of chronic fatigue syndrome, CFS, and fibromyalgia. For those experiencing persistent unexplained fatigue, two conditions warrant particular consideration: chronic fatigue syndrome, CFS, and fibromyalgia. While distinct disorders, they share overlapping features, including unrelenting exhaustion, cognitive difficulties, often referred to as brain fog, and diffuse musculoskeletal pain. These conditions are complex and multifaceted, often requiring a multidisciplinary approach to diagnosis and management. Chronic fatigue syndrome, CFS, profound unexplained fatigue lasting 6 months or more, worsening of symptoms after physical or mental exertion, post-exertional malaise, unrefreshing sleep, cognitive impairment, dizziness, headaches and muscle pain, fibromyalgia, chronic widespread pain, tender points in specific anatomical locations, fatigue and sleep disturbances, cognitive dysfunction, heightened pain sensitivity, central sensitization. Navigating the path to relief. Patients suffering from these conditions often embark on a long and frustrating journey before receiving a definitive diagnosis. In many cases, conventional medical evaluations fail to provide clarity, leading some individuals to explore alternative or integrative medicine approaches. These can include lifestyle modifications, nutritional interventions, physical therapy, cognitive behavioral therapy, and even emerging pharmacologic treatments designed to address pain modulation and neural dysfunction. A call for a comprehensive approach. Chronic fatigue and fibromyalgia require a nuanced, patient-centered approach. Physicians must acknowledge the legitimacy of these conditions and provide compassionate, evidence-based care. Likewise, patients should seek out healthcare providers experienced in managing these disorders, ensuring they receive both validation and effective treatment strategies. For those currently navigating this journey, know that you are not alone. Advances in research continue to shed light on the underlying mechanisms of these complex conditions, offering hope for improved diagnostics and therapies. The key lies in persistence, advocacy, and a willingness to explore multidisciplinary solutions tailored to your unique needs. Alternative healthcare, a critical perspective. As your search for answers extends beyond conventional medicine, you turn to alternative healthcare in hopes of finding relief. Frustrated by the limitations or even perceived harm of traditional medical treatments, you explore a more natural approach. To your surprise, an alternative healthcare provider quickly identifies a potential cause of your symptoms. You may be told you have systemic yeast overgrowth, leaky gut syndrome, or subclinical hypothyroidism, conditions frequently referenced in alternative medicine, but not always well defined within evidence-based practice. Diagnostic methods in alternative healthcare often include hair mineral analysis, iridology, eye examination, blood tests, urine analysis, or applied kinesiology, muscle testing. Based on these findings, practitioners may recommend herbal therapies, detox regimens, dietary modifications, and nutritional supplementation to address the presumed imbalance. Initially, you experience a sense of validation. Someone is finally listening and offering a tangible explanation for your chronic fatigue and other symptoms. Positive changes in lifestyle and nutrition may lead to some improvement in your overall well-being. However, as time passes, you might notice that while you feel somewhat better, you are still not fully restored to health. Here's why. Many alternative health approaches focus on correcting perceived nutritional deficiencies or metabolic imbalances without addressing the underlying pathology driving your symptoms. The fundamental issue, often related to oxidative stress, chronic inflammation, or a more complex physiological dysfunction, remains unresolved. Consequently, despite short-term gains, you may continue searching for more effective, lasting solutions. A truly comprehensive approach to health integrates both conventional medical expertise and evidence-based complementary therapies. A thorough evaluation by a qualified medical professional can help distinguish between well-supported interventions and those that may offer only temporary or placebo-driven improvements. The goal should always be to identify and address the root cause of illness through a balanced, scientifically sound strategy. Immunologically depressed, a deeper understanding of fatigue and oxidative stress. Many patients present with persistent fatigue, leaving their physician's office with a prescription for antidepressants. When routine evaluations fail to reveal an underlying pathology, the default assumption is often psychological distress or primary depression. However, in my clinical experience, I have found that a significant subset of these patients suffer from what I term immunologically depressed states, a physiological condition distinct from classic depressive disorders. The impact of oxidative stress on immunological function. Oxidative stress plays a crucial role in depleting the immune system, leading to fatigue and malaise. Chronic exposure to oxidative stress not only disrupts cellular homeostasis, but also contributes to immune dysregulation. Patients with prolonged fatigue often develop secondary emotional symptoms, not as a primary mood disorder, but as a consequence of their diminished physiological state. Through targeted nutritional interventions aimed at mitigating oxidative stress, patients frequently report a significant improvement in energy levels and overall well-being. Many express frustration that prior treatments, including antidepressants, failed to address their core symptoms. The relief they experience when oxidative balance is restored underscores the necessity of a broader diagnostic perspective. The continuum of fatigue to chronic illness. Prolonged oxidative stress is not an isolated event. It is a precursor to more severe degenerative diseases. Chronic fatigue syndrome, CFS, and fibromyalgia do not manifest suddenly. Rather, they develop progressively as the body's defenses erode under sustained oxidative burden. Patients presenting with fatigue, recurrent infections, poor sleep, anxiety, and cognitive dysfunction are often in the early stages of this continuum. Recognizing and addressing oxidative stress early is crucial to preventing progression toward more debilitating conditions. Clinical approach: identifying and addressing oxidative stress. Rather than dismissing these patients with an inconclusive diagnosis, I take a comprehensive approach by assessing lifestyle factors and environmental exposures that contribute to oxidative stress. This includes evaluating for potential toxic insults such as secondary smoke exposure, pesticides and herbicides, airborne pollutants, chronic psychological stress. In addition to lifestyle modifications, adequate rest, structured exercise, and dietary adjustments, I incorporate targeted supplementation. My regimen typically includes a potent antioxidant complex, essential mineral supplementation, grapeseed extract for its robust free radical scavenging properties. Patients are re-evaluated within 4 to 6 weeks to assess progress and make necessary adjustments. Unlike alternative medicine approaches that focus on expensive, often unreliable testing for specific deficiencies, my method prioritizes comprehensive cellular support, allowing the body to utilize what it needs for optimal function. Clinical outcomes and patient follow-up. The response to this approach has been overwhelmingly positive. Patients frequently return reporting significant improvements with enhanced skin tone, increased energy, and overall restored vitality. The transformation is often visible, reinforcing the fundamental role oxidative stress plays in chronic fatigue and immunological dysfunction. For years, conventional medicine has struggled to provide these patients with effective solutions. By shifting the focus toward oxidative balance and cellular nutrition, we can offer real hope and tangible improvements in quality of life. A clinical perspective on chronic fatigue and fibromyalgia, Judy's journey. Judy first presented with symptoms indicative of fibromyalgia in late 1990. A previously healthy individual with no significant medical history, she experienced an acute viral illness characterized by severe myalgia, profound fatigue, and systemic discomfort. The viral syndrome persisted for approximately 2 weeks before resolving, yet this episode marked the beginning of a chronic, progressively debilitating condition. In the spring of 1991, Judy engaged in routine yard work, an activity well within her usual capabilities. However, the following morning, she experienced profound myalgia and fatigue disproportionate to the exertion, akin to the after effects of intense physical labor over consecutive days. This phenomenon, known as post-exertional malaise, is a hallmark of fibromyalgia and chronic fatigue syndrome, often serving as an early warning sign of systemic dysregulation. Subsequent symptoms emerged over the next several months, including non-restorative sleep, cognitive impairment, often referred to as fibrofog, visual disturbances, morning joint stiffness, persistent headaches, cervical and shoulder myalgia, chronic pharyngitis. Despite efforts to improve sleep hygiene, including pharmacologic intervention, dietary modifications, and behavioral strategies, Judy's sleep disturbances persisted, exacerbating her symptoms and contributing to emotional lability and heightened sensory sensitivity. Upon evaluation, Judy's symptomatology was consistent with fibromyalgia syndrome, FMS, a central sensitization disorder characterized by widespread musculoskeletal pain, sleep dysfunction, cognitive impairment, autonomic dysregulation. She was initially prescribed pharmacologic agents aimed at improving sleep architecture and reducing central sensitization. While these interventions provided temporary relief, they were ultimately limited by adverse effects, including tachycardia, mood instability, parasomnias. Given the unfavorable risk-benefit profile, she elected to discontinue medication. During a follow-up consultation, Judy expressed concerns about long-term pharmacotherapy and inquired about alternative management strategies. Notably, she initiated a regimen of targeted nutritional supplementation, including antioxidants and micronutrients with purported neuroprotective and anti-inflammatory properties. Historically, my position had been that optimal nutrition could be achieved through a well-balanced diet. However, emerging evidence on oxidative stress and mitochondrial dysfunction in fibromyalgia prompted a reconsideration of this stance. Judy commenced a structured antioxidant regimen in September 1995. Within 3 weeks, she reported a notable improvement in energy levels and endurance. Sleep patterns gradually normalized, and the characteristic myofascial trigger points in her upper back resolved. By November, musculoskeletal discomfort and morning stiffness had markedly decreased. Following minor surgery in December, she experienced a transient symptom exacerbation, which was mitigated by increasing her antioxidant intake. By March 1996, Judy achieved her first uninterrupted 8-hour sleep cycle in years. Cognitive clarity improved, emotional resilience returned, and her overall functionality significantly enhanced. Over the subsequent 6 years, she maintained a stable health trajectory with sustained symptomatic relief, underscoring the multifaceted nature of fibromyalgia management and the potential role of integrative therapeutic strategies. Conclusion: Judy's case illustrates the complex interplay of immune dysregulation, central sensitization, mitochondrial dysfunction in fibromyalgia. While pharmacologic therapy remains a cornerstone in symptom management, individualized treatment approaches, including nutritional optimization and lifestyle modifications, can provide substantial benefit. Her sustained improvement highlights the importance of a comprehensive, patient-centered approach to chronic multisystem disorders, such as fibromyalgia and chronic fatigue syndrome. The root cause: chronic fatigue and fibromyalgia. Chronic fatigue syndrome, CFS, and fibromyalgia, FM, are debilitating conditions that have long confounded both patients and healthcare providers. While traditionally viewed as separate disorders, emerging evidence suggests that they may be different manifestations of the same underlying pathology. The primary distinction lies in symptomatology. CFS is characterized by profound fatigue, often accompanied by recurrent sore throats, swollen lymph nodes, and low-grade fever, whereas FM presents with widespread musculoskeletal pain alongside severe fatigue. A growing body of research supports the hypothesis that oxidative stress plays a central role in the pathophysiology of both conditions. Despite this, conventional medicine has yet to identify a definitive treatment, and as a result, fibromyalgia was historically dismissed as psychosomatic rheumatism. Unfortunately, this misconception persists among some clinicians, leaving many patients feeling invalidated. Current treatment paradigms are largely symptomatic, relying on non-steroidal anti-inflammatory drugs, NSAIDs, muscle relaxants, antidepressants, and sedative hypnotics. Patients are often referred to support groups and advised to adapt to their condition rather than being offered curative solutions. Epidemiology and clinical presentation. In the United States alone, approximately 8 million individuals are affected by fibromyalgia, with a striking female predominance. 8 out of 9 patients are women. This demographic trend has led some researchers to explore personality traits as a potential contributing factor. Notably, many FM patients exhibit perfectionist tendencies and heightened sensitivity to stimuli, which may predispose them to the disorder. The clinical burden of fibromyalgia is profound. Patients frequently report diffuse pain, severe fatigue, cognitive dysfunction, commonly referred to as fibro-fog, and non-restorative sleep. Additional comorbidities are common, including irritable bowel syndrome, IBS, and temporomandibular joint disorder, TMJ, the latter often presenting with jaw pain and tension headaches. Challenges in diagnosis. Diagnosing fibromyalgia remains a formidable challenge. On average, patients endure a diagnostic journey spanning 7 to 8 years, consulting multiple specialists before receiving a definitive diagnosis. Many arrive at a physician's office with extensive medical records documenting numerous investigations, all yielding unremarkable findings. The American College of Rheumatology (ACR) criteria for fibromyalgia include a tender point examination. The presence of significant tenderness in at least 11 out of 18 predefined anatomical sites upon mild palpation supports the diagnosis. However, newer diagnostic criteria incorporate symptom severity and widespread pain indices, acknowledging the variability in clinical presentation. Pathophysiology and disease progression. Many patients report the onset of fibromyalgia following a major physiological or psychological stressor. Common triggers include severe infections, traumatic injuries, particularly cervical trauma, and prolonged emotional distress. These events correlate with an increase in oxidative stress and dysregulated neuroimmune interactions, perpetuating a state of heightened pain sensitivity and metabolic dysfunction. Once established, fibromyalgia follows a chronic course with periodic fluctuations in symptom severity. Patients may experience brief remissions interspersed with exacerbations triggered by physical overexertion, psychological stress, or environmental changes. Unlike other chronic illnesses, fibromyalgia patients often lack physiological reserves, meaning that even minimal exertion can precipitate prolonged episodes of profound fatigue lasting days to weeks. Looking ahead. Given the limitations of conventional symptomatic treatments, there is a critical need for a paradigm shift in the management of fibromyalgia and chronic fatigue syndrome. A deeper understanding of oxidative stress and its role in these conditions may pave the way for more targeted and effective interventions. Future therapies should aim not only to alleviate symptoms, but to address the underlying biochemical and immunological disturbances driving these complex syndromes. Treatment. Capturing the disease. Once a definitive diagnosis of fibromyalgia or chronic fatigue syndrome, CFS, has been established, the primary therapeutic objective is to mitigate oxidative stress, a key contributor to symptom severity. The most effective approach to achieving this is through targeted cellular nutrition, which is discussed in detail in Chapter 115. Additionally, I emphasize the importance of a well-balanced, nutrient-dense diet combined with a structured, low-impact exercise regimen. Patients are advised to avoid consecutive days of exercise and to incorporate both mild aerobic activity and light resistance training into their routine. It is imperative to acknowledge that fibromyalgia and CFS are chronic conditions requiring sustained effort and patience for meaningful improvement. While some individuals experience rapid and significant symptom relief, this is not the norm. I counsel my patients to commit to a structured treatment plan for a minimum of 6 months. During this period, they may not reach their ultimate health goals, but they will begin to observe tangible progress. A hallmark of successful management is what I refer to as capturing the disease, where oxidative stress is effectively controlled, leading to noticeable symptom relief. The initial and often most encouraging improvement is the resolution of cognitive dysfunction, commonly described as mental fog. Patients report enhanced clarity of thought and improved concentration. Subsequently, sleep quality improves, resulting in more restorative rest and a significant increase in energy levels. Pain, typically the most persistent and distressing symptom, is usually the last to subside. Adherence to this comprehensive protocol has yielded favourable outcomes in approximately 70–75% of my fibromyalgia patients. Over the past 7 years, several hundred individuals have experienced significant relief of symptoms by following my prescribed nutritional rules. For patients who fail to respond adequately to oral supplementation alone, intravenous IV nutritional therapy is often necessary to gain control over oxidative stress. In such cases, I refer patients to specialized medical centers that provide IV nutritional supplementation. Once oxidative stress is adequately managed through IV therapy, oral supplementation can then be used as a maintenance strategy to sustain improvements. It is crucial to emphasize that these interventions do not constitute a cure for fibromyalgia or CFS. Rather, they provide patients with the tools to manage their condition effectively, enabling them to regain control over their health, rather than allowing the illness to dictate their quality of life. Over time, with persistence and dedication, patients can build physiological resilience, experience meaningful symptom relief, and ultimately improve their overall well-being. Mariano's story, a case study in fibromyalgia management. Mariano first introduced himself to me in Philadelphia, where I was presenting at a medical conference. He had driven over 200 miles for the opportunity to speak with me, and his story left a profound impact. A practicing psychiatrist, Mariano was battling severe fibromyalgia, a condition that significantly impaired his professional and personal life. His pain was so debilitating that he relied on more than 300 Advil tablets per month for symptom management. The persistent fatigue forced him to leave his office by 3:30 p.m. daily, and he was typically in bed by 7 p.m., completely exhausted. Recognizing the limitations of conventional pain management strategies, Mariano sought alternative solutions. He adopted the comprehensive nutritional protocol I have successfully implemented with numerous fibromyalgia patients. Within weeks, he began to experience a marked transformation. His cognitive clarity improved, his fatigue lessened, and he was able to extend his work hours. As his energy levels rebounded, he started staying up later, regaining a sense of normalcy in his daily routine. Notably, within approximately 1 month, Mariano observed a remarkable reduction in his pain levels. His dependence on Advil ceased entirely. Through targeted nutritional interventions, he reclaimed his ability to maintain a full psychiatric practice, extending his workdays by an additional 4 to 5 hours. Today, years later, he continues to thrive, a testament to the efficacy of strategic nutritional support in fibromyalgia management. Given his professional background, Mariano possesses a deep understanding of the psychological toll chronic illnesses impose. His experience underscores the necessity of a multidisciplinary approach to treating fibromyalgia, one that goes beyond symptomatic relief to address underlying metabolic and oxidative stress factors.
The shift toward integrative medicine.
Implications for clinical practice. The increasing patient-driven shift toward integrative and alternative medicine should serve as a wake-up call to the medical community. A growing number of individuals are dissatisfied with the limitations of conventional healthcare models, often turning to self-directed wellness strategies and alternative practitioners, even at their own expense. The prevailing sentiment is clear: people are exhausted by persistent illness and the lack of sustainable treatment solutions. Despite the surge in antidepressant prescriptions, the demand for alternative care continues to rise, both in the United States and globally. This shift is not merely a rejection of traditional medicine, but an indication that patients are seeking more comprehensive and proactive health solutions. Contrary to common misconceptions among physicians, patients are not inherently inclined toward pharmacological dependency. Rather, they desire viable, non-pharmacologic options to manage their conditions effectively. As physicians, we must acknowledge our role in this paradigm shift. The initial point of contact for most patients remains within conventional medicine. However, when traditional treatment protocols fail to provide relief, patients feel compelled to explore alternative avenues. While many physicians now recognize the benefits of a balanced diet and regular exercise, there remains a critical gap in understanding the impact of oxidative stress and nutritional deficiencies on chronic disease progression. By integrating evidence-based nutritional interventions and emphasizing metabolic health, we can enhance patient outcomes and reduce the reliance on alternative care. Encouraging patients to adopt high-quality, potent nutritional supplementation should not be viewed as a fringe approach, but rather as a fundamental component of modern medical practice. Addressing these foundational health concerns will not only alleviate symptoms, but also restore confidence in conventional medicine, ultimately leading to more effective and sustainable patient care. Physicians' bias against nutritional supplements. In my early years of medical practice, I distinctly recall my own skepticism toward nutritional supplements. My perspective was in line with the conventional medical wisdom that most physicians continue to hold today. Like many of my colleagues, I firmly believed that patients could obtain all necessary nutrients from a well-balanced diet. I routinely advised patients that if they simply adhered to healthy eating habits, supplementation was unnecessary. Just shop wisely at your local grocery store, choose the right foods, and you won't need any vitamins, I would assert. Taking supplements is an unnecessary expense. When confronted with patients who remained unconvinced, I often cited studies that suggested certain vitamins might be ineffective or even harmful. I realized in hindsight that these were the only studies I had truly internalized. Whenever a negative study was publicized in medical journals or the lay press, it reinforced my existing bias. I would think, this just confirms what I've always believed. It's unfortunate that so many patients fall prey to supplement industry marketing. Over time, however, my perspective evolved, largely due to a more nuanced understanding of modern dietary patterns and the limitations of our food supply. The typical American diet, a physician's perspective. As a medical professional, I must admit, yes, I have indulged in fast food. A Big Mac, French fries, a large supersized Coke, and even a hot apple pie. However, that was years ago, long before I fully grasped the profound impact of dietary choices on long-term health. This admission may elicit a chuckle, as it is a shared experience among many. Despite an overwhelming body of evidence highlighting the detrimental effects of fast food, we continue to frequent these establishments, often prioritizing convenience over well-being. Knowledge and action are unfortunately two distinct realities. While discussions surrounding weight loss and healthy eating are prevalent, genuine lifestyle changes remain elusive for most individuals. The nutritional deficiencies in the American diet. Current dietary trends in the United States paint a concerning picture. Approximately 40% of caloric intake in the average American diet derives from fat, predominantly saturated fat, the type associated with increased cardiovascular risk. A study published in Pediatrics September 1997 revealed that only 1% of American children meet the recommended daily allowance (RDA) for essential nutrients. This nutritional deficit during critical growth years sets the stage for lifelong poor dietary habits, contributing to a rise in metabolic disorders, including insulin resistance. Alarmingly, many adolescents already exhibit signs of this condition, underscoring the urgency of dietary intervention. Insights from national nutritional surveys. The second National Health and Nutrition Examination Survey, NAIMS-2, which evaluated the dietary habits of 12,000 American adults, uncovered the following concerning trends. 17% of the population reported consuming no vegetables whatsoever. 50% of the population, excluding potatoes and salads, did not consume any vegetables, meaning only half of Americans eat nutrient-rich garden vegetables. 41% consumed no fruits or fruit juices. Only 10% of the population met the USDA's recommendation of 5 daily servings of fruits and vegetables. Among African Americans, this figure dropped to a mere 5%. Despite medical and nutritional guidance advocating for increased fruit and vegetable consumption, the majority of the population fails to meet these recommendations. When French fries and baked potatoes, often the most consumed vegetables, are excluded, more than half of Americans are effectively neglecting plant-based nutrition. This dietary shortfall contributes to the widespread prevalence of chronic disease. The consequences of poor dietary habits. Given these dietary patterns, it is hardly surprising that more than half of the US population is classified as significantly overweight or obese. When coupled with the consumption of high glycemic foods, which will be discussed further in Chapter 90, the risk of developing metabolic disorders skyrockets. The prevalence of insulin resistance and type 2 diabetes continues to rise at alarming rates. If tasked with avoiding all refined carbohydrates, white bread, white flour, pasta, rice and potatoes, for just 2 weeks, many individuals would quickly appreciate the magnitude of their dependence on these foods. Currently, more than 80 million Americans are affected by insulin resistance, commonly referred to as Syndrome X. This condition is a precursor to type 2 diabetes and cardiovascular disease, both of which are largely preventable through dietary and lifestyle modifications. As healthcare professionals, we must emphasize the critical role of nutrition in disease prevention and empower individuals to make informed dietary choices that promote long-term health. Quality of food in the US, a physician's perspective. No nation in history has produced an abundance of food on the scale that the United States has over the past half-century. However, when evaluated through the lens of health and nutritional integrity, there are profound concerns regarding food quality. The agricultural and food processing methods that have enabled mass production and prolonged shelf life have also compromised the nutritional value of our food supply. The state of nutrient depletion in American agriculture. In 1936, Rex Beach, in his report to the US Senate, highlighted the stark reality of soil depletion. Most of us today are suffering from certain dangerous diet deficiencies, which cannot be remedied until the depleted soils from which our foods come are brought into proper mineral balance. The alarming fact is that foods, fruits, vegetables and grains now being raised on millions of acres of land that no longer contain enough of certain minerals are starving us no matter how much we eat. This statement, made nearly 90 years ago, remains relevant today. The depletion of soil minerals has only worsened, contributing to a significant decline in the nutrient density of our food. 5 major minerals, calcium, magnesium, chloride, phosphorus and potassium, along with at least 16 essential trace minerals, are critical for human health. Plants rely on soil to absorb these minerals, yet conventional agricultural practices fail to replenish them adequately. The role of fertilization practices. Due to economic constraints, US farmers primarily use nitrogen, phosphorus, and potassium (NPK) fertilizers. These fertilizers enhance crop yield, but do not restore the full spectrum of essential minerals required for optimal plant nutrition. The result is visually appealing produce that is fundamentally deficient in vital micronutrients. This economic-driven approach to agriculture prioritizes yield over quality, reinforcing a system where food production is measured in bushels per acre rather than nutrient density. The impact of hybridization and processing. Modern hybrid grains, fruits and vegetables are designed for higher yields and disease resistance, but often contain significantly fewer nutrients than their non-hybridized counterparts. The economic structure of farming incentivizes quantity over quality, further exacerbating the decline in food nutrition. Additionally, the widespread practice of early harvesting, long-distance transportation, and food processing significantly reduces nutrient content. Cold storage and preservation techniques, while necessary for distribution, contribute to nutrient degradation. For example, the refinement of flour removes over 23 essential nutrients, including magnesium, of which more than 80% is lost. Meat processing strips 50 to 70% of vitamin B6. Cold storage can deplete up to 50% of vitamin C in tangerines. Asparagus stored for just 1 week may lose 90% of its vitamin C. Nutrient loss in food preparation. Even after purchase, the way food is handled, stored, and prepared further impacts its nutritional value. Common food preparation methods contribute to additional depletion. Fresh salads and cut vegetables lose 40 to 50% of their nutrients if left standing for more than 3 hours. Vitamin C is particularly vulnerable to both heat and cold storage. Cooking significantly reduces folic acid content. Freezing meats can destroy more than 50% of their B vitamins. The case for nutritional supplementation. Given the extensive depletion of nutrients, from soil degradation to hybridization, processing and preparation, it is evident that modern food alone does not provide adequate nutrition. These factors present a compelling argument for the strategic use of high-quality nutritional supplementation. However, the rationale for supplementation extends beyond compensating for food nutrient loss. It also addresses widespread misconceptions about dietary requirements and health maintenance. A reassessment of recommended daily allowances, RDAs, is crucial. RDAs were initially established to prevent acute nutrient deficiencies, but do not necessarily reflect optimal health needs. With modern environmental and dietary challenges, a more comprehensive understanding of nutrition is essential for disease prevention and long-term wellness. Conclusion: the American food supply, while abundant, is deeply compromised in nutritional integrity. The depletion of soil minerals, reliance on hybridized crops, widespread food processing, and suboptimal food preparation methods collectively contribute to a diet insufficient in essential nutrients. In response, physicians and healthcare professionals must advocate for not only better dietary choices, but also informed supplementation strategies to support overall health and prevent chronic disease. Optimal levels versus RDA levels. Understanding the difference between recommended daily allowances, RDAs, and optimal nutrient levels is crucial for anyone concerned with long-term health and disease prevention. RDAs were originally established in the early 1920s and 1930s as the minimal nutritional intake necessary to prevent acute deficiency diseases such as scurvy, vitamin C deficiency, rickets, vitamin D deficiency, and pellagra, niacin deficiency. By consuming the RDAs for these vitamins, one would avoid these specific conditions. Over the past century, RDAs have been successful in eliminating many acute deficiency diseases in developed nations. Indeed, in my 3 decades of clinical practice, I have never encountered a case of scurvy, rickets, or pellagra. The Centers for Disease Control and Prevention, CDC, no longer tracks these diseases due to their rarity. In the early 1950s, RDAs were expanded to include amounts of nutrients needed for normal growth and development, further cementing their role in public health. Despite their utility, RDAs are often misunderstood, both by the medical community and the general public. Physicians, dietitians, and nutritionists frequently assume that RDA levels reflect the intake required for optimal health. This assumption is incorrect and contributes to widespread skepticism about the role of nutritional supplementation in preventing chronic degenerative diseases. Medical literature consistently demonstrates that the nutrient levels required to reduce oxidative stress and support long-term health far exceed RDA levels. Consider vitamin E. The RDA is set at 10 to 30 IU, while the average American diet provides approximately 8-10 IU daily. However, research indicates that measurable health benefits begin at 100 IU and continue to improve up to 400 IU or more. Similarly, the RDA for vitamin C is 60 milligrams, with recent discussions suggesting an increase to 200 milligrams. Yet, clinical studies indicate that a minimum intake of 1,000 milligrams is necessary for meaningful health benefits, with further improvements seen at 2,000 milligrams. The stark contrast between RDAs and optimal levels is evident across various essential nutrients. Table 1 illustrates the sheer quantity of food required to reach these optimal levels, emphasizing the impracticality of achieving them through diet alone. Table 1 amount of food needed to achieve optimal levels of key nutrients. Vitamin E, 450 IU, 33 heads of spinach, 27 pounds of butter, 80 medium avocados, 80 mangoes, 2 pounds of sunflower seeds, 23 cups of wheat germ, 1.5 quarts of corn oil. Vitamin D, 600 IU, 22 large egg yolks, 6 cups of fortified milk, 30 tablespoons of margarine, 15 ounces of shrimp, vitamin C, 1,300 milligrams, 17 medium kiwi fruit, 16 medium oranges, 160 medium apples including the skin, 10.5 cups of fresh orange juice, 16 cups of raw chopped broccoli, folate 1 milligrams, 3.8 cups of cooked asparagus, 4 cups of black beans, 20 medium oranges, 10 cups of Brussels sprouts, 3.8 cups of cooked spinach, vitamin B6 27 milligrams, 41 medium bananas, 38 medium baked potatoes with skin, 77 cups of lentils, 15 pounds of chicken breast, 18 cups of wheat germ, riboflavin 27 milligrams, 22 ounces of beef liver, 16 cups of low-fat yogurt, 9 dozen eggs, 3.25 gallons of low-fat milk, 64 cups of cooked spinach, thiamine 27 milligrams, 135 cups of brown rice, 2 pounds of ham, 3 pounds of sunflower seeds, 64 cups of green peas, 12 cups of wheat germ. Given these realities, achieving optimal nutrient levels solely through dietary sources is virtually impossible. Those seeking to reduce their risk of chronic degenerative diseases must supplement their diet with high-quality vitamins, minerals, and antioxidants. A common misconception is that taking a multivitamin ensures adequate nutrient intake. However, multivitamins are generally formulated based on RDA guidelines, which do not reflect the levels required for disease prevention. Medical literature rarely identifies significant health benefits from routine multivitamin use. Instead, targeted supplementation with optimal doses of key nutrients is essential for preventing and managing chronic diseases. A crucial question arises: is it safe to consume these nutrients at optimal levels? While concerns regarding potential toxicity exist, they must be considered within the context of well-designed clinical studies. Some physicians cite studies suggesting harm from high-dose supplementation, but a closer examination often reveals methodological flaws or confounding variables. As we delve deeper into the safety of nutritional supplementation, it is essential to separate scientific evidence from outdated assumptions and media sensationalism. The medical community must shift its perspective from merely preventing acute deficiency diseases to actively optimizing health through proper nutrition. By aligning our nutritional strategies with the latest scientific findings, we can make significant strides in reducing the burden of chronic degenerative diseases and improving overall well-being. Dangers versus safety of nutritional supplements, a physician's perspective. Throughout this book, I have presented extensive medical evidence demonstrating the efficacy of nutritional supplements in the prevention and mitigation of degenerative diseases. To derive optimal benefits, these supplements must be integrated into one's daily regimen over a lifetime. Given the necessity for higher than RDA levels, their safety profile must be exceptionally high, ensuring minimal risk of toxicity even at therapeutic doses. Comparative safety. Nutritional supplements versus pharmaceutical drugs. Nutritional supplements, when taken correctly, are fundamentally safe. They consist of naturally occurring nutrients already present in the human diet, albeit at more concentrated levels. In contrast, pharmaceutical agents, while clinically beneficial in managing chronic conditions, inherently pose risks, often necessitating physician oversight. Dr. Bruce Pomeranz, in the April 15, 1998, issue of the Journal of the American Medical Association, JAMA, reported that properly prescribed medications contribute to over 100,000 deaths annually, with an additional 2.1 million individuals experiencing serious adverse effects. Conversely, nutrients do not exhibit such risks when consumed within recommended parameters. Despite the significant mortality associated with prescription medications, the medical community seldom addresses this issue with the same urgency applied to cardiovascular disease, stroke, and cancer prevention. It is paradoxical that while physicians frequently caution against nutritional supplementation due to perceived dangers, the documented risks of pharmaceuticals remain a less publicized concern. Potential risks and toxicities of individual nutrients. While nutritional supplements maintain an excellent safety record, excessive dosages can lead to toxicity. Below, I discuss key vitamins and minerals that warrant particular attention regarding dosage thresholds and potential adverse effects. Vitamin A. Vitamin A toxicity is among the most well-documented concerns. Chronic intake exceeding 50,000 IU per day can result in toxicity, especially in individuals with liver disease. Symptoms include dry skin, brittle nails, alopecia, anorexia, nausea, and irritability. Acute toxicity in children following ingestion of 100,000, 300,000 IU may present with intracranial hypertension, vomiting, and stupor. Pregnant women should avoid excess intake due to teratogenic risks at doses as low as 5,000 to 10,000 IU. Instead of direct vitamin A supplementation, beta-carotene and mixed carotenoids serve as safer alternatives. Beta-carotene. High-dose beta-carotene supplementation has not been associated with significant toxicity. A benign condition, carotenodermia, yellowing of the skin, may occur but resolves upon dose reduction. Vitamin E. Despite being a fat-soluble vitamin, vitamin E has demonstrated a strong safety profile. Clinical trials utilizing doses up to 3,200 IU day report no severe adverse effects. Moreover, vitamin E's antiplatelet properties may enhance cardiovascular health, complementing aspirin therapy. Vitamin C. Even at high doses, vitamin C is well tolerated. Some individuals may experience gastrointestinal discomfort. Early concerns regarding kidney stone formation have not been substantiated in subsequent clinical studies. Vitamin D. Vitamin D toxicity is a legitimate concern at doses exceeding 1,500 IU day. Excessive intake may elevate serum calcium levels, promoting ectopic calcification and increasing nephrolithiasis risk. However, emerging research suggests that the RDA of 200 IU is insufficient, with optimal doses ranging from 500 to 800 IU per day, which remains within the safe threshold. Niacin, vitamin B3. High-dose niacin is effective in lipid management but may induce flushing, nausea, and hepatotoxicity. Slow-release formulations may mitigate flushing but increase liver toxicity risks. Clinical supervision is advised when using pharmacologic doses. Vitamin B6 pyridoxine. Excessive vitamin B6, 2,000 mg per day, may result in neuropathy. However, doses below 100 mg per day remain well within a safe range. Folic acid, even at doses up to 5 grams a day, has not demonstrated toxicity. However, it may mask vitamin B12 deficiency, necessitating concurrent supplementation. Choline is well tolerated, but at extremely high intakes, 20 grams per day, it may cause gastrointestinal discomfort and a fishy body odor. Calcium. Calcium intake up to 2,000 milligrams per day is generally safe. Contrary to prior beliefs, higher dietary calcium intake correlates with a reduced risk of nephrolithiasis. Iodine. Excessive iodine, 750 milligrams per day, may suppress thyroid function and induce dermatologic reactions. Iron. Routine iron supplementation in populations with adequate dietary intake may contribute to oxidative stress and increased cardiovascular risk, particularly in men. Manganese. While manganese toxicity is rare in supplementation, occupational exposure, e.g. mining, can lead to neurotoxicity, manifesting as irritability and hallucinations. Molybdenum doses exceeding 10 to 15 milligrams per day have been linked to gout-like symptoms. Selenium. While selenium remains safe up to 300 milligrams per day, excess intake, at 400 to 500 milligrams per day, may induce irritability, gastrointestinal distress, and alopecia. Conclusion. Nutritional supplementation, when properly administered, presents a significantly lower risk profile compared to pharmaceutical interventions. The primary concern lies in excessive consumption, which can lead to toxicities. However, when taken within established safety parameters, these nutrients provide substantial health benefits without the systemic risks associated with conventional drug therapies. Medical professionals must balance caution with evidence-based advocacy for appropriate supplementation, ensuring optimal patient outcomes while mitigating potential risks. A physician's defense. My medical training, like that of the vast majority of practicing physicians today, did not include formal education in nutrition. In fact, nutrition was not a required component of my medical school curriculum. This is not particularly surprising. As I noted in Chapter 1, only a handful of medical schools across the country currently mandate coursework in nutrition. While elective courses in nutrition are available in approximately 50% of medical schools, studies indicate that only about 6% of graduating medical students receive any meaningful education in this area. Furthermore, even for those who do take a nutrition course, the subject of nutritional supplementation is rarely emphasized. Medical training by design is centered on the diagnosis and treatment of disease, with a heavy reliance on pharmacology and interventional medicine. It was not until I dedicated the past 7 years to rigorously examining the medical literature on nutrition and supplementation that my perspective began to shift. For the first 23 years of my clinical practice, my stance on nutritional supplementation reflected the prevailing medical paradigm. I maintained strong, conviction-driven opinions that my patients trusted implicitly. After all, as physicians, we are often perceived as having comprehensive knowledge about health. The reality, however, is that there are significant gaps in our training. Medical practice is built on the foundation of clinical research, and our therapeutic decisions, whether related to pharmaceuticals or nutritional supplements, are guided by evidence from published studies. However, the landscape of nutritional research is complex. While many high-quality studies support the benefits of supplementation, others have reported neutral or even adverse outcomes. These negative findings tend to receive widespread attention, both in the medical literature and the mainstream media. Earlier in my career, when I was skeptical of supplementation, I frequently cited these negative studies to my patients. At the time, a single unfavorable study seemed sufficient to override the collective weight of hundreds of well-conducted investigations demonstrating clear health benefits. Given the accessibility of medical literature today, any physician or health-conscious individual will inevitably encounter such studies. It is therefore imperative to critically examine some of the most widely publicized research on nutritional supplementation and its implications for clinical practice. The case against nutritional supplements, a review of key clinical trials. The Finnish study, ATBC trial. One of the most frequently cited studies in the debate on nutritional supplementation is the alpha-tocopherol beta-carotene cancer prevention, ATBC study, conducted in Finland. This randomized, double-blind, placebo-controlled trial included nearly 30,000 male smokers who were divided into 4 groups. Group 1 received no supplementation, placebo group. Group 2 received DL-alpha-tocopherol, synthetic vitamin E. Group 3 received synthetic beta-carotene. Group 4 received both DL-alpha-tocopherol and beta-carotene. Subjects were followed over a period ranging from 5 to 8 years. The findings were unexpected and concerning. Not only did the supplementation fail to reduce lung cancer incidence in any of the groups, but those receiving beta-carotene actually demonstrated an increased incidence of lung cancer. This was particularly alarming, as previous observational studies had suggested a protective association between high dietary intake of beta-carotene and vitamin E with lower cancer risk. The discrepancy highlighted the complex interactions between isolated supplementation and real-world dietary patterns.
The carrot study.
The beta-carotene and retinol efficacy trial involved 18,000 smokers and asbestos-exposed individuals in Washington state. Participants were administered 15 milligrams of beta-carotene and 25,000 IU of preformed vitamin A daily. Over the 4-year study period, researchers observed no reduction in cancer risk. More troublingly, there was an increased incidence of lung cancer in the group receiving supplementation. These findings reinforced concerns that high-dose antioxidant supplementation, rather than being protective, might actually contribute to disease progression in high-risk populations.
The Physicians' Health Study.
The Physicians' Health Study, PHS, enrolled over 22,000 healthy male physicians in the United States to examine the long-term effects of beta-carotene supplementation. Participants received either 50 milligrams of beta-carotene or a placebo every other day for 12 years. Unlike the previous studies, this trial found no significant impact, either beneficial or harmful, on lung cancer or cardiovascular disease risk. While this suggested a neutral effect in a generally healthy population, it further called into question the assumed protective benefits of isolated micronutrient supplementation. Clinical implications. The cumulative evidence from these major trials underscores the limitations and potential risks of high-dose nutritional supplements, particularly in high-risk populations such as smokers. While epidemiological data suggests that diets rich in antioxidants are associated with health benefits, isolated supplementation appears to have a different and often unpredictable impact. These findings emphasize the importance of a food-first approach to nutrition, advocating for whole foods rather than reliance on synthetic vitamin formulations. Conclusion. The evidence from the ATBC, CARE and Physicians' Health studies collectively challenges the notion that antioxidant supplementation provides protective effects against chronic diseases. Instead, these trials highlight potential risks, particularly in vulnerable populations. Clinicians should counsel patients on the importance of obtaining nutrients through a balanced diet rather than unregulated supplementation, particularly in the absence of a demonstrated deficiency. Future research should continue to explore the complex interactions between dietary patterns and disease outcomes to refine evidence-based nutritional guidelines. My response. Are the findings of these studies concerning? At first glance, they may seem discouraging, but a deeper analysis provides valuable insight. The evidence is clear. Individuals who smoke or are at high risk for lung cancer should avoid high-dose beta-carotene supplementation in isolation. As a physician, I always seek overarching principles in medical literature, and this is a prime example. High doses of a single nutrient, particularly in high-risk populations, can have unintended consequences. In smokers, beta-carotene and other antioxidants may act as pro-oxidants, potentially increasing free radical production rather than reducing it. However, these findings should not lead to a blanket rejection of supplementation. Instead, they highlight the risk of using beta-carotene alone or in combination with synthetic vitamin E, DL-alpha-tocopherol in smokers. This distinction is critical as synthetic vitamin E has been associated with adverse effects, whereas most studies on natural vitamin E, D-alpha-tocopherol, have demonstrated beneficial outcomes. A major limitation of many studies is their reductionist approach, evaluating the effects of one or two isolated antioxidants rather than considering the broader context of oxidative stress. Expecting a single nutrient to counteract decades of damage is akin to attempting to stop a speeding locomotive with a single rifle shot. Additionally, it is essential to recognize the long latency period of lung cancer, which typically develops over 2 to 3 decades. Given this, the Finnish study was inherently limited from the outset. The participants, long-term smokers experiencing significant oxidative stress, required a comprehensive strategy, not a singular intervention. True cellular nutrition involves a well-balanced spectrum of antioxidants and minerals at optimal levels, rather than relying on isolated magic bullet solutions. A more recent study. A study published in the New England Journal of Medicine on November 29, 2001, has garnered substantial media attention. This investigation, commonly referred to as the simvastatin ZOCI, evaluated 160 patients with hyperlipidemia and atherosclerosis, assigning them to one of 4 study arms. 1. Control group received no intervention. 2. Statin-niacin group received simvastatin, Zocor, and niacin. 3. Antioxidant group received vitamin E, vitamin C, selenium, and beta-carotene. 4. Combination group received simvastatin, niacin, and the aforementioned antioxidants. The most favorable outcomes were observed in the statin-niacin group, Group 2, which demonstrated modest regression of atherosclerosis. The antioxidant-only group, Group 3, exhibited notable improvement as well. However, the combination group, Group 4, which received both statins and antioxidants, showed a blunted increase in HDL cholesterol. While this particular finding was marginal and not statistically significant, it nevertheless became a focal point in media narratives, leading to broad generalizations regarding potential interactions between antioxidants and statin therapy. This selective interpretation of data has led many clinicians to diss the potential benefits of nutritional supplementation. Despite extensive research demonstrating the role of antioxidants in mitigating oxidative stress, a key factor in cardiovascular disease, there remains a reluctance within the medical community to integrate such findings into clinical practice. It is crucial to recognize that cardiovascular disease is not solely a disorder of dyslipidemia, but rather a chronic inflammatory condition affecting the arterial system. Notably, this same study revealed that LDL cholesterol in the antioxidant group exhibited a 35% increase in resistance to oxidation compared to those receiving statins. However, this significant finding received little attention from mainstream media. Moreover, an often overlooked consequence of statin therapy is its depletion of coenzyme Q10, CoQ10, a vital component for mitochondrial function and muscle health. Reduced CoQ10 levels have been implicated in statin-associated myopathies, yet this concern is rarely addressed in clinical guidelines. The tendency of many physicians to base their stance on nutritional supplementation on selective or misinterpreted study findings underscores the need for a more balanced, evidence-based approach. Rather than dismissing the potential of cellular nutrition, we must consider the broader implications of oxidative stress and the role of comprehensive antioxidant defense systems in disease prevention and management. A paradigm shift in medical thinking, one that acknowledges both pharmacologic and nutritional strategies, is imperative. The ultimate goal is to enhance patient outcomes through a more integrative approach to chronic disease management, leveraging the full spectrum of available scientific knowledge to optimize long-term health. Cellular nutrition, putting it all together. As physicians, we often find ourselves in the trenches of medicine, battling some of the most frustrating and painful diseases that afflict our patients. Yet, the deepest fulfillment in our profession comes not from prescribing medications, but from witnessing men, women, and children reclaim their health, living fully once again after a debilitating illness. The true triumph of medicine is not just in treating disease, but in restoring vitality. However, the reality is this: I have rarely, if ever, seen such remarkable recoveries occur with conventional medicine alone. In isolated cases, one might attribute these outcomes to sheer luck or even divine intervention. But in truth, the human body has always possessed an extraordinary capacity for self-repair. We are indeed fearfully and wonderfully made, equipped with intricate biological systems designed to heal. Modern medical science is now catching up to this understanding, revealing that our greatest asset in recovery is not a single drug or therapy, it is the host itself. Despite our best efforts, there are times when healing remains elusive. Few scenarios are more frustrating for a physician than facing a severely compromised immune system, whether due to advanced AIDS, intensive chemotherapy, or other immunosuppressive conditions. In these cases, infections become not only severe, but often atypical, requiring the most potent antimicrobial agents available. Yet even the best pharmacologic interventions struggle to compensate for an immune system that is barely functioning. At these critical moments, the physician gains a profound appreciation for the body's natural defense mechanisms. This is precisely why the integration of high-quality, evidence-based nutritional support is not alternative medicine. It is complementary medicine. Drugs alone are often insufficient. They require a resilient biological foundation to be truly effective. By optimizing cellular nutrition, we do not replace traditional medicine, we enhance it, leveraging the body's own intrinsic healing capabilities to achieve better clinical outcomes. It is time we embrace a more comprehensive medical paradigm, one that acknowledges both the indispensable role of pharmaceuticals and the unparalleled power of the human body's self-restorative potential. This synergy is the future of medicine, and it is the key to unlocking true, lasting health. Optimal levels of nutrition, a physician's perspective. As healthcare practitioners, we must recognize that essential nutrients, such as vitamin E, selenium, calcium, magnesium, and vitamin C, are fundamental components of a well-balanced diet. However, scientific inquiry continues to approach these nutrients as though they were pharmacologic agents. Unlike synthetic drugs, which necessitate rigorous clinical trials to assess safety and efficacy due to their potential to disrupt natural enzymatic processes, these nutrients function synergistically within the body's intrinsic biochemical pathways. In the preceding chapter, we explored the potential risks associated with nutritional supplementation. However, the risk profile of these essential nutrients remains minimal, particularly when contrasted with pharmaceutical interventions. Vitamin E, vitamin C, selenium, and other micronutrients play an integral role in supporting enzymatic function, antioxidant defense, and immune modulation. With advancements in nutritional science and supplement manufacturing, we can now provide these nutrients at optimal levels, dosages substantiated by empirical evidence demonstrating health benefits beyond the basic recommended dietary allowance, RDA. When taken in combination at these optimal levels, the physiological benefits can be profound.
Cellular nutrition, a foundational approach.
The concept of cellular nutrition centers on delivering all essential nutrients to the cell at optimal levels, thereby allowing intrinsic cellular mechanisms to determine utilization based on physiological needs. This approach eliminates the need for precise deficiency diagnosis in many cases. Instead, it ensures comprehensive nutritional support, facilitating gradual correction of suboptimal micronutrient status over time. An apt analogy can be drawn from the art of baking. While traditional bakers relied on precision and experience, modern automatic bread machines enable even novices to produce consistent results by ensuring the correct proportions of essential ingredients. Similarly, in cellular nutrition, comprehensive and balanced nutrient intake provides the necessary biochemical substrates for optimal cellular function. Evidence-based nutritional supplement recommendations, antioxidants. A diverse and broad-spectrum intake of antioxidants offers superior protection against oxidative stress. Vitamin A and carotenoids. Direct vitamin A supplementation is generally discouraged due to potential toxicity. Instead, mixed carotenoid supplementation is recommended. Beta-carotene, 10,000 to 15,000 IU. Lycopene, 1 to 3 mg. Lutein zeaxanthin, 1 to 6 mg. Alpha-carotene, 500 to 800 mg. Vitamin C, a complex of vitamin C derivatives, enhances bioavailability and efficacy. Recommended dosage, 1,000 to 2,000 mg. Vitamin E, a blend of natural vitamin E forms, including tocopherols and tocotrienols, is preferable. Recommended dosage, 400 to 800 IU. Bioflavonoid antioxidant complex includes key compounds such as rutin, quercetin, broccoli extract, green tea, bilberry, grapeseed extract, bromelain, cruciferous vegetable extracts. Alpha-lipoic acid, recommended dosage 15 to 30 mg. Coenzyme Q10 and Q10, recommended dosage 20 to 30 mg. Glutathione, 10 to 20 mg. N-acetyl L-cysteine, NAC, 50 to 75 mg. B complex vitamins, cofactors for metabolic processes, folic acid, 800 to 1000 mg. Vitamin B-warmin, 20 to 30 mg. Vitamin B2 riboflavin, 25 to 50 mg. Vitamin B3 niacin, 30 to 75 mg. Vitamin B5 acid, 80 to 200 mg. Vitamin B6 pyridoxine, 25 to 50 mg. Vitamin B12 cobalamin, 100 to 250 mg. Bio 300 to 1000 mesograms. Additional key vitamins and minerals. Vitamin D3, 450 to 800 IU. Vitamin K, 50 to 100 mg. Calcium, 800 to 100 grams depending on dietary intake. Magnesium, 500 to 800 mg. Zinc, 20 to 30 mg. Selenium, 200 mg. Chromium, 200 to 300 mg. Copper, 1 to 3 mg. Manganese, 3 to 6 mg. Vanadium, 30 to 100 mg. Iodine, 100 to 200 mg. Molybdenum, 50 to 100 mg. Trace minerals, balanced complex. Nutrients for bone health, silicon, 3 mg. Boron, 2 to 3 mg. Cognitive and cardiovascular support, choline, 100 to 200 mg. Trimethylglycine, TMG, 200 to 500 mg. Inositol, 150 to 50 mg. Dietary supplementation considerations. Essential fatty acids, cold-pressed flaxseed oil, fish oil capsules rich in EPA and DHA.
Dietary fiber.
A blend of soluble and insoluble fiber, 10 to 30 gram depending on dietary intake. Target total fiber intake, 35 to 50 grams per day. Ensuring quality in supplementation. Several reputable nutritional manufacturers are now producing comprehensive supplement formulations that incorporate these essential nutrients in well-balanced combinations. Selecting a high-quality product that adheres to pharmaceutical-grade good manufacturing practices, GMP, and United States Pharmacopeia, USP, standards ensures both potency and bioavailability. The inclusion of essential fats and fiber further enhances overall health benefits, addressing common deficiencies observed in Western diets. By maintaining optimal levels of key nutrients, individuals can significantly reduce oxidative stress, improve metabolic function, and support overall cellular health. By adhering to these evidence-based nutritional principles, healthcare providers can guide patients toward a proactive, preventive approach to wellness, one that integrates cellular nutrition with comprehensive dietary and lifestyle modifications. Protecting your health, the role of nutritional supplementation. Nutritional supplementation is fundamentally about preserving health, not merely addressing disease. True preventive medicine targets the root causes of chronic degenerative conditions before they manifest. While many individuals already enjoy good health, the key to longevity and vitality lies in maintaining it proactively rather than attempting to restore it after decline. Decades of clinical experience confirm that those who integrate foundational health principles, including targeted nutritional supplementation, significantly reduce their risk of chronic disease. For individuals currently managing health challenges, the right interventions can empower the body's innate ability to combat, and in some cases, even reverse disease processes. A well-balanced diet, consistent physical activity, and optimal cellular nutrition form the cornerstone of a winning health strategy. However, the notion that an apple a day keeps the doctor away is no longer sufficient in today's environment. Given the toxic burden of modern life and the nutritional deficiencies prevalent in even the best diets, high-quality supplementation is no longer optional. It is essential. The following core nutrients serve as the foundation for optimal cellular health, enhancing physiological resilience at every level. Cardiovascular health, reducing LDL oxidation and lowering homocysteine levels to minimize the risk of atherosclerosis. Neurological protection, supporting cognitive function and reducing the risk of neurodegenerative conditions such as Alzheimer's and Parkinson's disease. Ocular health, providing antioxidant protection against macular degeneration and cataracts. Immune and respiratory function, enhancing immune defense mechanisms and optimizing lung health. Metabolic and autoimmune support, strengthening cellular defense against diabetes, arthritis, lupus, and multiple sclerosis. In a world where environmental toxins and chronic stress place continuous strain on physiological systems, fortifying the body's immune and antioxidant defense mechanisms is imperative. Investing in comprehensive nutritional support is not merely a recommendation, it is a proactive strategy for sustained health and disease prevention. Optimizers. Advanced nutritional strategies for enhancing cellular health. In some cases, patients require more than the essential nutrients mentioned. Those experiencing persistent fatigue or managing chronic degenerative conditions are under heightened oxidative stress, necessitating the addition of what I refer to as optimizers to their supplementation regimen. These are highly potent antioxidants, rigorously studied for their efficacy. While the search for more effective antioxidants continues, the most powerful currently available is grapeseed extract, which is abundant in proanthocyanidins, a subclass of bioflavonoids found in the pigmented portions of fruits. Grapeseed extract provides antioxidant potency significantly greater than conventional vitamins, offering an efficacy approximately 50 times that of vitamin E and 20 times that of vitamin C when incorporated into a comprehensive antioxidant protocol. However, when used in isolation, its potency is reduced, demonstrating the fundamental principle of nutrient synergy. A key advantage of grapeseed extract is its ability to cross the blood-brain barrier, discussed further in previous chapter, allowing direct access to cerebrospinal fluid and neural tissues. For patients with chronic fatigue, I typically recommend an initial dosage of 100 to 200 milligrams, adjusted based on symptom severity. Noticeable improvements are often observed within 4 to 6 weeks, at which point the dosage may be tapered as long as clinical progress is maintained. Optimizers for chronic degenerative diseases. Patients suffering from chronic degenerative diseases, including multiple sclerosis (MS), cardiovascular disease, lupus, Crohn's disease, cancer, and Parkinson's disease, are at significantly increased risk for oxidative damage at the cellular level. The body's natural repair mechanisms in these individuals are often overwhelmed, unable to keep pace with ongoing oxidative stress. In such cases, the strategic use of optimizers is critical to mitigating further cellular damage and potentially improving overall health outcomes. Among the optimizers I commonly recommend, grapeseed extract remains a primary choice. However, for those with more advanced disease states, I frequently incorporate additional potent antioxidants such as coenzyme Q10, CoQ10, glucosamine sulfate, lutein, zeaxanthin, niacin, magnesium, and calcium. Note, CoQ10 absorption is variable. The following recommendations refer to the powdered form. Lower doses may be required when using Q-gel or soft gel formulations. Disease-specific optimization strategies, cardiovascular disease. Grapeseed extract, 100 mg per day, CoQ10, 100 mg per day, magnesium 100 to 300 mg per day. If homocysteine remains above 7 despite B vitamin therapy, consider adding 1 to 5 gram trimethylglycine G. Cardiomyopathy, grapeseed extract, 100 mg per day, CoQ10, 300 to 600 mg a day, magnesium, additional supplementation as needed. Patients often respond within 4 months. Dosage adjustments should be guided by clinical response and, in some cases, CoQ10 blood level testing. Cancer, non-metastatic cases, grapeseed extract 200 mg a day, CoQ10 200 mg a day. Metastatic cases, grapeseed extract 300 mg per day, CoQ10 500 to 600 mg per day. Pediatric patients ages 8 to 15, half the adult dosage. Macular degeneration, grapeseed extract 300 mg per day, lutein 6 to 12 mg a day. Improvements, if occurring, are typically seen within 4 months. Multiple sclerosis, grapeseed extract 400 mg a day, CoQ10 200 to 300 mg per day, vitamin C 500 to 1000 mg a day. Symptomatic improvement may take up to 6 months. Lupus and Crohn's disease, grapeseed extract 300 mg per day, CoQ10 200 mg per day. Response typically observed after 6 months. Osteoarthritis, glucosamine sulfate 1500 to 2000 mg per day, grapeseed extract 100 to 200 mg are optional. Chondroitin sulfate 400 to 600 mg or MSM 100 mg based on individual response. Rheumatoid arthritis, glucosamine sulfate 1100 to 2000 mg per day, CoQ10 300 mg per day, grapeseed extract 400 mg per day, magnesium and calcium 200 mg each day. Omega-3s 3 to 4 fish oil capsules or 2 teaspoon cold pressed flaxseed oil daily. Osteoporosis, no additional optimizers beyond Table 1 recommendations. Emphasis on vitamin D, calcium, magnesium, and weight-bearing exercise. Asthma, grapeseed extract, 200 to 300 mg a day, children 2 mg per day. Vitamin C, 1000 mg a day, children 200 to 500 mg. Magnesium, 200 mg a day, children 100 mg. Emphysema, grapeseed extract, 200 mg a day. Additional vitamin C and magnesium as per asthma recommendations. Alzheimer's and Parkinson's disease, grapeseed extract, 400 mg a day. Emerging evidence suggests potential for disease progression attenuation. Diabetes mellitus, grapeseed extract, 100 to 200 mg a day. Foundational cellular nutrition, Table 1, provides remaining essential support. Chronic fatigue and fibromyalgia, grapeseed extract, 200 to 300 mg per day, may be increased to 400 to 500 mg as needed. CoQ10, 100 to 200 mg per day. Once symptom control is achieved, dosage may be reduced to a maintenance level. Conclusion: incorporating optimizers into a patient's nutritional regimen provides a targeted approach to mitigating oxidative stress and supporting cellular function, particularly in those with chronic degenerative diseases. While foundational cellular nutrition remains essential, optimizers serve as critical adjuncts for patients requiring additional support. Personalized dosing adjustments based on disease severity, clinical response, and emerging research ensure an evidence-based, patient-centered approach to supplementation. Need more help? The recommendations outlined in this book may appear straightforward, yet they are the foundational principles that have consistently yielded the clinical results I have shared. It is beyond the scope of this book to provide individualized recommendations for every medical condition. Choosing your nutritional supplements. This book is not intended to endorse specific brands or types of nutritional supplements. However, ensuring the quality of the supplements you choose is critical to achieving optimal health outcomes. I strongly advise against selecting supplements based solely on cost. Your health is an invaluable asset, and inferior products will not yield the benefits described in this book. The nutritional supplement industry remains inadequately regulated, requiring due diligence when selecting products. High-quality supplements should be complete, balanced, and manufactured under stringent quality control standards. When assessing supplement options, consider the following. Manufacturing standards. Choose supplements produced under good manufacturing practices, GMP, for pharmaceuticals, ensuring rigorous quality control measures. Label transparency. Opt for products that disclose full ingredient lists, nutrient concentrations, and expiration dates. Dissolution and absorption. Pharmaceutical-grade supplements should comply with US Pharmacopoeia (USP) standards to guarantee proper dissolution and bioavailability. Regulatory oversight. Companies marketing internationally, particularly in countries such as Canada, Australia, and Western Europe, are often subject to higher manufacturing standards and periodic inspections. Third-party certification. Seek independent quality verification from reputable organizations to confirm the supplement's integrity and potency. A study published in the Tufts University Health and Nutrition Letter in November 1997 revealed that only 3 out of 9 prescription prenatal vitamins tested adequately dissolved. If a supplement does not dissolve properly, its nutrient content is irrelevant. Ensuring that your chosen supplements meet USP dissolution standards is a vital step toward optimizing absorption and efficacy. The sheer number of available supplements can be overwhelming, and marketing claims often obscure the true quality of products. By focusing on scientific evidence and industry best practices, you can make informed decisions that support your health goals. A paradigm shift in medicine. If we were to compress all medical advancements since recorded history into a 24-hour time frame, the research presented in this book would have emerged within the last 5 or 6 seconds. This represents cutting-edge science that many healthcare practitioners have yet to integrate into clinical practice. Nevertheless, the fundamental principle of cellular nutrition remains one of the most effective strategies for mitigating oxidative stress, the underlying factor in numerous chronic diseases. By incorporating a nutrient-dense diet, regular physical activity, and targeted supplementation, you empower your body's innate healing mechanisms, offering the best chance for disease prevention and health restoration. The real-world cases discussed in this book illustrate the remarkable resilience of the human body. While these patients continue to manage their underlying conditions and, in many cases, require conventional medical therapies, they have experienced profound improvements in their quality of life. When physicians embrace and support the body's intrinsic ability to heal, rather than merely treating symptoms, the potential for clinical success expands exponentially. Tricia Rhodes, in her insightful book Taking Up Your Cross, provides a fitting perspective. Always remember the brevity of life, the certainty of death, and the length of eternity. Our physical bodies are temporary, and despite our best efforts, they will ultimately decline. However, by applying these evidence-based health principles, we can maximize our vitality and well-being for as long as possible. The goal is not merely to extend lifespan, but to enhance the quality of life so that we may truly live until we die.